Good morning, one and all. I'm Dr. Sudarshan Ahire, Secretary IMA Nashik. I welcome all of you on behalf of IMA Nashik for the academic feast Refreshercon Rhythm 2021. As the name suggests, rhythm that we are coming back to our pace of our life. So this the whole academic feast, it has topics from cardiology till the psychological analysis of our Indian team who has won and made a record at Australia. Also, there's various other topics also. So, without wasting much of your time, I will hand over mic to our MOC, Dr. Kiran. Over to you, sir.
Good morning, everyone. Myself, Dr. Kiran Virari. Our opening lecture will be delivered by Dr. Manoj Chopra, who has also opened the cardiology inning in Nasik. He is a senior interventional cardiologist from Nasik. He has done his MBBS and MD from BJ Medical College and DM cardiology from prestigious Grand Medical College, Mumbai. He has pioneered the work of international cardiology in Nasik, coronary angiography, angioplasties, balloon metal valvulotomies, device closure, and also recently he has started robotics assisted PCI in Maharashtra. He has established cardiac units in Rukad Hospital, Nasik, Sandarbh Seva Rugnalaya, Nasik, and Sai Baba Hospital, Shirdi. He has almost performed more than 50,000 coronary angiographies, more than 10,000 PTCAs, more than 2,000 balloon valvuloplasties. He has many national and international journals to his name. And also, he has written a Marathi book named Hrudayrog Ani Apan, which has more than 24 editions, and till date it has sold more than 50,000 copies. So to begin with the first lecture, he will be talking on what's new in cardiology. Over to you, sir.
Hi, good morning, everybody. I think after the COVID, the first big conference, Refreshercon, I congratulate all the Samir Chandratre and his team for organizing this wonderful conference. What I am going to take you through advances in cardiology, what's new. Basically, you can see here the cardiac MRI, PET scans, then there is a valves which can be implanted transcatheter and different electrophysiological applications. The way cardiology changed, I think there is a changing face of patients also. Initially in my practice, they were unaware, surrendering type. We were treated as a god and was not questioned. But then they became aware, curious, and don't want to take chances. Cardiologists respected, but questioned. And nowadays, it's a Google doctor, too aware, net savvy, demanding, and not only demanding, it's a damaging. And now doctor has been treated as a professional, which has been hired. I'll pay you your fees. I want the results. And if you look at it, why it has changed, I think the economics is the main thing. The big infrastructures, latest technology, the human resource which is required is a real challenges that he should be very well trained, and all has put into a lot of costs. And that's why the modern medicine has become costly. And people have in mind that the medicine, it should be a cheap or it should be free. And that contrast is making a lot of problems. What we are seeing here is it's all air movement. You can see in the night, it's the Asian and the Australian countries are having a dense air movement. Then it's in the European countries, and then it goes to the USA. So this lifestyle, that's the movement across the globe has increased, and that has increased that what we can say, hurry, worry, and curry. And these are the main culprits for the neurocoronary artery disease. And that's the lifestyle what we are facing today. You can look at it, how we have changed and how the lifestyle has affected new diseases. New risk factors we all talk about is a psychosocial factor is one of the important risk factor. Same way the air pollution, water pollution, food pollution, oral hygiene is important. Inflammation plays an important role in coronary artery disease, vitamin deficiencies, and the vitamin D deficiency. All these are important risk factor on which we need to look into. And you can see here the patient with the age 38 years and you can see our yoga guru age 88 years, but the intima thickening is the minimum. And here the thickening of the intima at 38 years age is like 80 years old. And so how do you keep your lifestyle is important. India has become a very big pharmaceutical manufacturing units, providing the generic drugs to all over the world. And the polypill concept, which has been launched by the Indians, fixed dose combinations for hypertension, and similarly ACE inhibitors, beta blockers, statin, and aspirin for ischemic heart disease. It starts with the ECG because for a diagnosis of cardiac problems, I think ECG plays an important role. Many times of the patient having the arrhythmia, syncope, we are not able to tackle it. So there the patch Holter recorder where the patch transfers the ECG to a server and where you can monitor the ECG 24 hours or it can be up to 7 days to 30 days. And then you can diagnose that the patient is having arrhythmias or what and what type of treatment patient can be offered. Implantable root recorders that records the ECG for almost 2 years. The patients where you need to monitor his ECG, his arrhythmias, that can be done. Similarly, the blood pressure management, the measurement is the most important thing in the today's world, where the clinic measurement, home measurement, and ambulatory blood pressure measurement plays an important role. Thereby, diagnosis of hypertension, when you are treating them, 2 to 3 drugs are required, and there you need to change the drugs or not. Many times in a ambulatory VP, you know the night dipping that tells us about the vascular elasticity, morning surge of BP. Thereby, accordingly, you adjust the drug dosage. It is some drugs to be taken in the night. In echocardiography, we all know that the strain imaging is there, where the patient on chemotherapy, patient of ischemic heart disease, early stages strain can be reduced and where the patients can be picked up and the sent for angio or angioplasty if it's required, or in patients with cardiomyopathies, the strain plays an important role. How do we evaluate them? Similarly, 4D echo is playing a very important role where in diagnosis of valvular heart diseases, whatever the congenital heart disease, ASDs, VSDs, where we can know that the exact size of the atrial septal defect, what are the rims patient is suitable for surgery or patient is suitable for the device. So this is how the 4D echo images look like. Hypertension, as I said, that what are the newer molecules are there? The calcium channel blockers like azlodapine, these newer molecules have come in. But there is one treatment that is where the sympathetic activation, efferent nerves and afferent nerves, which are located in the renal artery, there you put a catheter and try to denerve these nerves, thereby the control of hypertension is good. Where you require a 3 to 4 drugs that can be reduced to a 1 drug or no drug at all. There was a lot of controversy for this uh, treatment, but again, the last 2 years trials have shown that it's effective treatment. This is how the catheter is placed and you put a laser there and try to denerve the artery and thereby the BP is controlled. We all talk about the angiography and angioplasty. Angiography has remained the same. There is an X-ray, you put a dye and you take images. That is a high-end CM machine is required. You diagnose that it's a blockages there are not. And then accordingly, we decide that the patient requires angioplasty, medical treatment, or the bypass surgery. When we talk about angioplasty, it's, I think, putting a guide catheter, guide wire, dilating the lesion and putting a stent. Is it only putting a balloon and the stent, or is it makes a difference that how do we do angioplasty? I think radial artery angioplasty has made a tremendous difference. Patient walk in, walk out, where the radial artery is a small artery, thereby the bleeding complications are reduced. Patient's mobility is very good, and that's why it's become a popular mode of doing interventions. You can see here the patients just walking after the procedure, and in 2 hours after the angio, which came normal, can be discharged. For radial angioplasty nowadays, 12 to 24-hour discharge is also there. In patients with acute coronary syndrome or acute myocardial infarct, I think the time is the muscle. The first 3 hours are the most important. We talk about the primary angioplasty, but I always say that in Indian settings, T with Dr. Chopra, that is thrombolize early and do angio, and if required, angioplasty. That's the best way to treat the patient. Stents, there is a lot of improvements has occurred. The thinness has reduced, thereby the flexibility has reduced. The polymer which is used nowadays, when we do angioplasty, we require antiplatelet agents to be given after the angioplasty, and many patients, the bleeding risks are there. So nowadays, the polymer-free stents are available, or the polymers which are available where we can give only 1 month or 3 months dual antiplatelet agents. After that, we can shift them on a single antiplatelet agents. And similarly, the bioabsorbable stents. We all know about the Abbott Absorb stent, but which has been withdrawn from the market. And now there is an Indian company which has launched the bioabsorbable stent, and it's going to be a leader in the field of bioabsorbable stents. When I say that the angioplasty, the technology plays an important role. When we do angioplasty, the evaluation of the lesion is important. Then accordingly, the length and the what stents should be used. And after doing a stenting, the stent has been apposed well or not, because that decides that our complete lesion has been covered or not. That decides not only the short-term, but the long-term results. You can see the IOS and OCT. These are the two technologies which play important role in this. And intravascular ultrasound, I'll just show you, these are the different images which we see: lipid-laden lesion, then the thrombotic lesion that can be differentiated in young patients. If we do IOS and if it is only a thrombus, patient can be left with the medical treatment and no angioplasty is required. So here there is an animation about you can see a catheter with an ultrasound at the end, which releases the ultrasonic waves, and it can have images. You can see here the catheter has been pulled back. The lesion, which is the lipid-rich lesion, is there. Significant stenosis, which we can see. That is the tightest lesion site, which has been documented. And side branch is seen very well in that. There is a dissection and the rupture of the plaque, which has caused the thrombotic occlusion of this vessel. So this is how the ultrasound helps us. Similarly, the OCT, that is the optical coherence tomography, the light is used where you can see a very good clear images. You can see there is a dissection, then there is a hematoma which is inside the vessel wall, and similarly we can, after putting a stent, OCT can help us in delineation of the stent. It's really apposed very well or not, and it shows that the red marks are there. We say that you need a post-stenting dilatation, lesion is completely covered or not, and this is the way OCT helps us in the pre-treatment planning and the post-treatment planning. If the calcified vessel is there, really it's eccentric or what, or it's a concentric or what, and accordingly we decide that it's required or not. Many times we see that there is a dilemma of a treatment in a coronary artery. Angiography is done. One cardiologist say go for angioplasty. One cardiologist say don't do angioplasty. And there are many 3 vessel blocks. There's a bypass is suggested, and we are in the doubt that what should be done. So basically, the FFR is a technique which helps us in delineating the lesion-specific physiology. You measure a proximal blood pressure in the vessel proximal to the block and the distal to the block, and that tells us about that if it is 100 and below it is goes down to 75, we say that it's a significant hemodynamic stenosis and that needs to be treated. In many patients which come to me for opinion, triple vessel diseases, their one lesion is significant, others are not significant. Their FFR plays an important role in delineating that the patient needs only one vessel angioplasty, other 2 vessels can be treated medically. Or when it is a single vessel disease and we are in doubt, many times we come with that the patient requires only medical treatment. This is the pressure gauge wire where the pressure transducer is there and which measures the pressures in the vessel, and that has been transmitted to a hemodynamic monitor. And here we use adenosine to induce the ischemia, and that gives us the really hemodynamic significant probability that the balloons and the stents will not go. In those patients, many times the bypass is advised. And there, I think the rotablator technology, where the rotational atherectomy, we put there is a diamond bar at the tip. 1.8 to 2 lakh RPM is the speed of the drilling machine. And I think that's, you need a very precise, concise movement of the rotablator burr, and thereby you cut the calcium, and then we can put a balloon and the stents easily. You can see one case here I did, which was a almost long segment calcium was there, and we put a rotablator burr and cut the calcium completely, and then easily we put a long 60 millimeter stent in this patient, and we could do a plasty there. Similarly, nowadays there is a shockwave lithotripsy where there is a calcium. Similarly, in the kidney stones, we put a balloon here, and through balloon you deliver the shockwave, and thereby the calcium is broken, and then the angioplasty can be completed very well. Now we have robotic angioplasty. We all are talking about the robotic and artificial intelligence in the cardiology or the other many procedures or the interventions. So Magnum is having a robotic angioplasty, which is the second center in the India and the first in the Maharashtra. Here is the console, here is the robotic arm, and this is the cath lab, which we can see. I'll just show you one video there. This is a core path. Now it's been taken by the Siemens. You can see that where we load our wires, balloons. There are rotators in this cassette which rotate the wires and balloons that can be moved from the joysticks by sitting in the console. This is the console where cardiologist sits. You can see 3 knobs are there. One is for catheter, and the other 2 are the wire and the balloon and stents. Here the cardiologist fixes the sheath, and fixed, it can be attached to a robotic arm, and once the attachment is done, this is a console from where you can give the commands to a console. And from here, then you load the wires, balloons, and by sitting in a console, you can move the wires, you can move the balloons and the stents. I'll show you the one case which I performed. This was a long stent which has been taken for the right coronary artery lesion. You can see that there is a wire which has been loaded in the Y connector. These are the rotators which you can see which moves the wire. These are the rotators where the balloon, see, this stent is going in. Now the stent has been inserted into the Y connector. So once you load the stent and the wires, you close the cassette, and then from the console, then you can move the wires and the stents. In the COVID era, when there was a problem and we did a COVID positive patient's angioplasty, it really helped. Only one person with a PPE kit, they loaded all the kits and everything, and I sat in the console and did the angioplasty. You can see a movement of the balloon going into the vessel Y connector. It's moving on its own by, see, this is the joystick which moves the balloons and the stents, and this is how we do a robotic angioplasty. And I have done around 200 angioplasties till date. Osteal stents, millimeter movements of the stents, bifurcation lesions, long segment stents, it can be pushed easily because you can fix the catheters and the wires. Similarly, the patients coming with cardiogenic shock, patient coming into the heart failure, resistant, anti-wall MI, the intra-aortic balloon pump helps. It's a balloon which inflates into a diastole, and thereby the perfusion of the brain, kidney, and the heart is maintained very well. And there is augmentation of blood pressure of 20 millimeters of mercury. Similarly, the ECMO can be used in patients with a cardiogenic shock and a lot of resistant heart failure, where the patient is on optimal medical treatment and we are not able to bring him out. Recently, we had a patient with Lepman stenosis and patient coming with cardiogenic shock. We put him on a ECMO, that is where veno-arterial ECMO is used for the heart and the veno-venous ECMO for the lung patients. We had one case where the swine flu lung affection was there, and we used veno-venous ECMO for almost 28 days, and the patient could go home. This is how the ECMO can help us in bringing the patients out, which are the resistant to the treatment. As I talked about the coronary, similarly, the non-coronary interventions are there, which I'll take you through that. Valvular interventions. At present, we will open heart surgeries for the aortic valve and the mitral valve replacement. Here you can see TAVI, that is a transcatheter aortic valve implantation, and which is now become a mainstay of treatment. Initially, it was for a high-risk patients, but now we say that the low-risk patients also can be done very well with a aortic wall implantation. This is how the wall is there on the catheter, on the balloon, and you can see a tricuspid wall, which is a ring is there, and this is how the wall is taken and the implanted. You can see the catheter across the aortic wall, and slowly the wall is released over there, and this is the how wall looks after implantation. So now the transcatheter aortic wall replacement is possible. Only the cost is the issue, but I think over the period the cost will come down. Only the patient having a mitral regurgitation, the mitral clip is available. The transcatheter, you can see taken the clip that across the mitral wall. You do a transesophageal echo, see that the mitral regurgitation, how much is there, and you can take a clip across the leaflet and put it in a. This is how the you can move the clip and fro that leaflet, thereby the regurgitation can be stopped. Similarly, the patients with a stroke and having the atrial fibrillation, you need a atrial fibrillation, stroke prevention is required. And many times we give anticoagulants, but some patients bleeding risk is high, where the left atrial appendage can be isolated by using a LAA closure technology. This is a Watchman's device which been kept into the left atrial appendage, thereby the clot formation in left atrial appendage is reduced, and thereby the chances of stroke is reduced. So this is the one technology which we can use in this. You can see a angiography, left atrial appendage, there the device has been left and the device has been reduced, deployed there in the left atrial appendage. In electrophysiology, in atrial fibrillation, ventricular tachycardia, now respond to a treatment, optical medical treatment. There the mapping of the heart for atrial fibrillation, pulmonary vein isolation, similarly the ventricular tachycardia or fibrillation, try to find out the source, and thereby you can ablate those areas so that patient will have a control of atrial fibrillation heart rate, or the whatever the foci for the ventricular tachycardia fibrillation is there can be removed. In electrophysiology, when we talk about the bradyarrhythmias, the pacemakers becomes the main important stay of treatment. There the pacemaker sizes have come down. They are 32 grams only. Defibrillator. Now the patient having a sudden cardiac death, cardiac arrest, resuscitated, VT, VF is documented. And if you are in hospital or ambulance, the shock can be given. But afterwards, what? Nowadays there is a ICD, that is the intracardiac defibrillator, around 40 to 50 grams weight, and the intracardiac defibrillator can be implanted inside the heart, and which will detect the VT, VF and give you the shock, and you can reach the hospital or your life can be saved. Similarly, the leadless pacemakers are available. You can see here the pacemaker which is taken into the RV Apex, and it's been delivered, and there is no lead, and it works on the Bluetooth technology. See, this is how it looks like. You can see that when you take a patient, catheter has been pushed into the right ventricle, and here is the pacemaker which is released by this, and by telemetry you can control the pacemaker functions. Heart failure has become the increase in the incidence, and a lot of costs are involved in treating the heart failure patients. We have a new drug like ERNI, that is a ARB receptor blocker, and the naproxen inhibitor, that is a sacubitril, and that combination has reduced the heart failure admissions. The quality of life, that is the NYHA class from 3, 4 has been come down to 2, and it's doing very well. In these patients where they have a left bundle branch block or the QRS is more than 150 millisecond, and on optical medical treatment, patients repeated heart failure admissions are there. There the synchronization of the electrical currents, that is the RV lead, RA lead, and the synchro increase in this patient. We have heart failure or CR devices are available where we can LV assist device pump. There is a LV apex in the aorta, and that works as a heart lung pump and reduces the afterload, and the patient can function. With this machine can move around, and up to 8 to 10 years survival has been seen very well with these machines also, in spite of going for the heart transplant. And last resort is heart transplant. I think in India, heart transplant is much cheaper than the LV assist devices, but they have disease, I think problem patient have device and newer devices, the VSDs can be closed very well with the devices. And I have done around 150 cases of VSD device closure with the single disc device, and that was one of the largest series which was published 2 years back. Similarly, in the patient with cryptogenic stroke and the migraine, if you find a patent foramen oval, that can be closed with a device, and there you can reduce the migraine and the stroke prevention is found role in the PFO. We have Apple Watch where the ECG can be transmitted very well. Pressure monitoring, sugar monitoring, or it can be a jersey, what we and we'll be treating them on the online, and that's what the corona has taught us. And similarly, you can see a jersey which we can tell us about the BP, oxygen saturation, sodium, potassiums, and the temperatures changing or not. And this is the monitoring which is going to be the future of our OPDs. And here where I can show you that this important thing where you can see a close-up ad where you can put a steam, whatever in morning you get up and you just blow on your glass, and that will give us all the parameters which are required. That is the oxygen levels, sodium, potassium levels, and that's how we are looking at monitoring of the lab parameters also. But all in all, whatever the changes in technology has occurred, whatever in unstable patients, it becomes very important. But in stable patients or in prevention, I think clinician in doctor tops, we need to respect nature healing powers. We don't treat investigation, but it is the person who is important. And I think the prevention, that is the lifestyle, is very important. Lives saved, longevity increased, is misery saved. But really, we are going to increase the happiness or not, it becomes important. That's why ultimate rehab is lifestyle modification, diet, exercise, stress management, and the sleep patterns, how they are. And whenever it is acute coronary syndrome or acute myocardial infarct, I think timing becomes everything, because how you treat the patient, and it's a 3 to 24 hours is the most important thing, and the patient should be treated in that. We know the death is important, but the problem is premature death, and hearts and brains are too good to die. And that's why younger and younger population is getting affected with acute myocardial infarct. We need to prevent the premature deaths. And how do we do it? I think it's a prevention. Then the development of the hub and spoke models, ambulance services, where we can treat the patient in first 3 hours. And that's how we can change the morbidity, mortality of acute myocardial infarct. So to summarize, technology has changed the face of cardiology. Lot of new developments in angioplasty, valvular interventions, non-valvular interventions. And I think in this short time, I tried to cover each and every intervention which can be useful in our day-to-day practice. As I said, Magnum is having the robotic angioplasty. We have a OCT, IVUS, FFR, and I think these technologies have helped me in treating the patients in a different ways. Decision making has changed, and the outcome of the treatment, not only the short term but long term, has also improved over this. I thank you for giving me this opportunity. Thank you very much.
Thank you, Chopra sir, for such a nice presentation in time, particularly. Uh, our next speaker is Dr. Sudarshana Patil. Friends, as you know, we all thought that life is getting on track. We have achieved a victory on this COVID-19 infection, but we are on the verge of receiving the second wave of this dreaded infection. So, to talk on extrapulmonary complications of COVID-19 disease, we have with us Dr. Sudarshana Patil. Uh, she is consulting physician and intensivist at Okad Hospital, Nasik. She has done her MBBS and MD from BJ Medical College, and she has received her Indian Diploma in Critical Care Medicine from Ruby Hall Clinic. She is also a PG guide for IDCCM, and she has handled successfully the complicated COVID-19 cases at Okad Hospital. So she will be talking on extrapulmonary complications of COVID disease. Over to you, madam.
Good morning, friends. At the outset, I'd like to thank Team IMA for allowing me to be a part of this academic feast. In the next 20 minutes, I would like to take you the journey of the extrapulmonary manifestation of COVID disease. Okay. Thanks, Dr. Birari, for a warm welcome. I'll start with my presentation. So the COVID virus came in 2019, but it was only after 114 countries got affected that the WHO announced that it is a pandemic. This was somewhere in March 11, 2020. Initially, the clinicians thought it would be a disease which would be limited only to the lung. But as the months went by, we found that many other organs were getting affected. And the reason for this was the mystery lies in the molecular structure of the virus. So this is the molecular structure of the virus. It has got four major structural proteins, as you can see in the figure. Spike protein, that is the S protein, membrane protein, envelope glycoprotein, and the nucleocapsid protein, along with the lipid bilayer. And among all these proteins, it is the S protein which plays a very important role in the attachment of the virus to the host cell and allowing the entry of the virus into the host cell. Now, this SARS-CoV-2 virus, it recognizes the ACE2 receptors as the host cell entry receptor. And this ACE2 receptor has got very high expression in the type 2 alveolar cells of the lungs, and hence primarily it is the lung which gets affected. But however, you can see it is also present in other organs like the intestine, esophagus, cardiomyocyte, glial cells, and the neurons. And that is the reason why, in addition to the lung, we've got involvement of the other organs. And you can see in this figure the involvement of the other organs. Usual COVID-19 presentation, I will not go into the detail of this. We know all of this, and the laboratory markers which are significant like lymphopenia and the increased COVID markers like D-dimer, lactate dehydrogenase, C-reactive protein, the IL-6 levels, and the ferritin. This is our data. We started the COVID ward in June 2019, and this is our data up to January 2021. We treated nearly 1,108 patients, out of which males were 705, females were 303, comorbidities 530, ICU admission 393, and ward admission 615. This was our discharges, 854, and some others getting transferred to other hospitals because of financial constraint. So in this figure, we found that nearly 335 patients had involvement of other organs besides the lungs. So as you can see, the involvement of other organs is nearly to the tune of 30 to 40% in COVID disease. And hence it is necessary for us to know which organs and how they get affected. So coming first to the neurology. Recent case series, Mayo et al., out of 214 patients, 36.4% had associated neurological features. How does the neurological system get affected? So it is both by a direct affection. Direct affection is the virus moving by the blood circulation or the lymphatics or the cerebrospinal fluid into the brain. And indirect affection is because of the inflammatory problems that we face with this disease. So neuroinflammation in the period of cytokine storm, which usually sets in the second week. Attachment of the virus to the ECE2 receptors causing unregulated elevations in the blood pressure and giving rise to hemorrhagic strokes, hypoxia caused by metabolic changes, and of course the thrombotic complications. So this is the list of affections of the neurology of COVID. So you can see it affects the central nervous system, and these are the presentations which we will talk about in some details, like headache, delirium, strokes, which are both ischemic and hemorrhagic, seizures, toxic encephalopathy, encephalitis, and meningitis. Affection of the peripheral nervous system, loss of taste, loss of smell, acute myelitis, and of course the Guillain-Barré syndrome, and affection of the musculoskeletal system. So coming to the most common ones, which we will talk in a little bit in detail. So anosmia, which is nothing but the loss of smell, and ageusia, which is nothing but the loss of taste. This can be seen as the initial presentation even in absence of other symptoms. It is so common and unique that in fact it can be used as a screening test in our OPDs for even the asymptomatic COVID patients. And the cause is of course the direct involvement of the olfactory nerve by the virus. Coming to headache, yes, it is also a very key symptom of COVID. In a recent European study of 1420 patients, it was the most prevalent symptom in nearly 70% of the patients. Cause of the headache, low oxygen levels in the brain, anxiety, mental stress, and of course, swelling or inflammation of the brain tissue and the meninges. Headaches which appear between 7 to 10 days of the illness are related to the cytokine storm. Even pre-existing primary headaches, if the patient is already having like say migraine or tension headaches, they can also get exacerbated due to COVID. So it goes with this rule that any new onset headache with or without fever and respiratory symptoms, think of COVID. Coming to viral encephalitis, commonly manifests as fever, headache, vomiting, convulsion, and consciousness disorders. This hospital in Wuhan, it confirmed the presence of SARS-CoV-2 virus in the cerebrospinal fluid of patients with COVID-19 by genome sequencing, thereby clinically verifying viral encephalitis. Then another common presentation is infectious and toxic encephalopathy. The cause being the systemic toxemia. It occurs secondary to the systemic toxemia, and also because of the hypoxia, which occurs during the process of acute infections. Commonly manifests with symptoms like headache, vomiting, diaphoresis, and delirium. Diagnosis is of course by the CSF analysis. This again is a very common presentation, that is the strokes. Now strokes can be both thrombotic as well as hemorrhagic. The cause of thrombotic strokes are that the COVID virus aggravates the ischemic brain injury by triggering the cytokine cascade. And the reason for the hemorrhagic strokes is because of the binding of the virus to the ACE2 receptors, causing an elevation in the blood pressure and giving rise to hemorrhages. Elevated levels of D-dimer and thrombocytopenia also render these patients very much prone to the acute cardiovascular, cerebrovascular events. The treatment, if they come during the window period, the treatment is nothing different than the non-COVID patients. So you can thrombolize them with alteplase or tenecteplase, or if that is not possible and it is a candidate for mechanical thrombectomy. In those who do not come within the window period, anticoagulation is recommended. In these patients, blood pressure fluctuations are very commonly seen post COVID infection, and hence there is the recommendation that if the patients are on ACE inhibitors or ARBs, you can suggest to shift them to the calcium channel blockers or the diuretics. Coming to demyelination, this is usually seen in the second phase of the illness where the cytokine storm has set in. So the inflammation is the one which is responsible for this illness. It can affect the brain, it can affect the spinal cord, or it can affect the peripheral nervous system, and patients can come with Guillain-Barré syndrome. In Mumbai, nearly 28 to 29 cases of Guillain-Barré syndrome were seen, and even in our unit, we have seen one case of Guillain-Barré syndrome. So what is this? A progressive ascending limb weakness which evolves over 1 to 4 days, usually comes in the second week. So the interval between the onset of viral illness and the development of muscle weakness is around 5 to 10 days. It occurs as a para-infectious rather than a post-infectious complication in most of the patients. And also some reports suggest that these symptoms appear to progress more rapidly and more severe than in a non-COVID patients. Variants of Guillain-Barré syndrome have also been seen, like the Miller-Fisher syndrome, multiple cranial neuropathies, facial dysplasia, ophthalmoparesis. Diagnosis by nerve conduction study and the CSF examination, and treatment part, like the non-COVID patients with IV immunoglobulins and steroids, they show a very dramatic recovery. Coming to myelitis, spinal cord involvement as such is very uncommon. Zhao and co-workers described this acute myelitis in a 66-year-old patient who developed acute flaccid paraplegia with spinal sensory level at around T10 and urinary incontinence. Patients was treated with intravenous immunoglobulin and steroids and responded very well to treatment. We have, however, not seen any case of myelitis in our setup. This was the MRI picture of that, showing the typical lesions suggestive of transverse myelitis. Then status epilepticus, also very common, causes being the withdrawal of anti-seizure medication, stress, fever, metabolic disturbances, cytokine storm, and drugs, which we should remember, out of which is HCQ. Management, it is like the non-COVID patient, but the choice of agent is usually levetiracetam, ketamine and phenytoin to be avoided because they can push the patient into cytokine storm. EEG is diagnostic for these patients. Then if these patients already have got some comorbid illnesses like Parkinson's disease and myasthenia gravis and they get COVID, you see a worsening of the motor as well as the non-motor complications. And however, these patients definitely do respond very nicely to IV immunoglobulins and steroids, which improves their symptoms. We have also seen one such case which improved of myasthenia gravis who responded very well to immunoglobulins. This is our data in our unit of the neurological complications that we had seen. So ischemic strokes in 4, meningoencephalitis 4, Guillain-Barré syndrome 1, which I said responded very well to immunoglobulins. Patient went home walking. Anosmia 5, Bell's palsy was also seen in around 7 cases. Seizures with status epilepticus in 4 cases and headache in 15. In all these cases, as you can see, comorbidities were there, and also the D dimer and the interleukin levels were very much raised. Again, documenting that the inflammatory part of the COVID disease is very important, plays a very important role in the neurological complications. Some images which I would like to share. This was a 3 months old baby who presented with meningoencephalitis, and you can see the MRI picture, the bilateral thalamic hyperintensities. This is a recent case. She's still admitted with us. Patient came with a COVID positive status and a neurodeficit. The MRI showing a malignant MCA infarct, and of course the angiography also showing a intra-ICS stenosis. Patient came in the window period, so was received thrombolysis and responded very well. Her neurodeficit has improved significantly. Coming to the next organ, that is the kidney. So kidneys are again one of the most frequently affected extrapulmonary organs, especially in the ones who have got severe disease. Binding of the virus to the EC2 receptors, which is highly expressed in the kidney tubules, is of course the cause. And also these patients get acute kidney injury in the phase of septic shock syndrome, which is often seen in the terminally ill patients. Drugs can also be responsible, like favipiravir and remdesivir. So the modification of the doses have to be done. COVID-19 patients with a prior history of chronic kidney disease and renal transplant patients are very much likely to develop acute kidney injury. And once this sets in, these patients have got a very poor prognosis. Coming to the heart, American College of Cardiology has listed the following events in COVID-19 disease: acute coronary syndromes, cardiac arrhythmias, myocarditis, heart failure, sudden cardiac death, cardiogenic shock, and venous thromboembolism. Reason for the cardiac injury: direct myocardial injury by the virus, prothrombotic state induced by the COVID disease, immune-mediated injury by the inflammatory markers and the T-cell response during the phase of cytokine syndrome, and hypoxia-induced excess of intracellular calcium, giving rise to cardiac myocyte death. And drugs, of course, should not be forgotten. HCQ causing rhythm disturbances, and remdesivir also giving rise to a drop in the blood pressure and dysarrhythmias. This is so it is currently recommended that physicians should regularly monitor the cardiac enzymes and the NT-proBNP levels in all COVID-19 patients. This was a very useful statement made by the JAMA cardiology study, which used cardiac MRIs as 100 people who had recovered from COVID-19 disease in the past 2 to 3 months, and they showed that ongoing myocardial inflammation was continuing in nearly 60% of the patients, and of these 76% of the patients had high TROP-T levels, and hence it goes without saying that even on the patients who have got discharged, you should be having a tab on their cardiac status, and they should be regularly screened for their cardiac damage, because this is often a cause of mortality in these patients. Coming to arrhythmias, a study of 121 COVID-19 patients showed that most of these patients had some arrhythmias, including 87 who had sinus tachycardia, which was unrelated to the fever, 18 had bradycardia, and one patient had paroxysmal atrial tachycardia. Often these patients have got elevations in the blood pressure, which is another factor for the dysarrhythmias. Sudden cardiac death, this is also very common. This was one of the studies involving 99 SARS-CoV-2 patients, out of which 11% of the deaths was due to sudden cardiac arrest. And these patients did not have any prior history of ischemic heart disease. And hence the reason which was put in was the imbalance of the pulmonary ventilation perfusion ratio and a decrease in the capacity of the pulmonary vasculature. This is again our data, which we found: acute coronary syndrome, arrhythmias, cardiogenic shock, sudden cardiac death, myocarditis, and heart failure. All these patients again showing very high inflammatory markers like D-dimer and IL-6. Coming to the gastrointestinal system, affects nearly all the organs of the gastrointestinal system. Liver dysfunction, very commonly seen. It usually occurs in those patients who have got severe COVID disease. Renal liver transplant patients and cirrhotic livers are the ones which are very much predisposed for this injury. The deranged liver function tests, which are seen in the form of raised serum transaminases, bilirubin, LDH, prolonged prothrombin time, and hypoalbuminemia. Prognosis in these patients is very poor. Also, these patients are very much prone for opportunistic infections. Pancreatitis, ACE2 receptors are highly expressed in the pancreatic islet cells, and hence onset of pancreatitis is very common in these patients. They usually present as acute abdomen with lab parameters showing more than 3 times elevation in the serum lipase and the amylase levels, and CT scan is diagnostic. Other GI complications, routinely these are seen in the first week, like vomiting, loose motions, abdominal pain. But the one which I would like to stress on is, of course, the constipation, because we have seen this in most of the patients, nearly 70 to 80% of the patients. And this is because of the very poor oral intake of the patients, non-ambulatory state, and comorbidities like gastroparesis, diabetes gastroparesis, and of course the drug remdesivir. Rectal bleed due to anal fissures and piles secondary to the chronic constipation is also seen. And we have also seen complications like portal vein thrombosis and superior mesenteric vein thrombosis, especially in the patients who have got cirrhotic livers. This is again our data. We had all these cases of liver cell failure, pancreatitis, superior mesenteric thrombosis, one patient, portal vein thrombosis, constipation, significantly seen in nearly 126 of the patients, PR bleeds because of piles and anal fissure, and one very interesting case of retroperitoneal hematoma secondary to liver cell failure, the images of which I would like to share with. So this was a 65-year-old male, diabetic, hypertensive, obese, came with a CT score of 23 by 25. He had acute respiratory failure and acute kidney injury, was managed according to the guidelines. In the second week of the illness, patient complained of severe abdominal pain, vomiting, and reduced appetite. Lab investigation showed a drop in the hemoglobin, platelets, and the deranged coagulation parameters like raised PT-INR and APTT. We got a urgent CT abdomen done, which showed a very large retroperitoneal hematoma. So as you can see in the figure, it was a very large hematoma, 11 by 42 by 13.98 centimeter. Luckily, we had the interventional radiologist who got involved, and he did the embolization of the bleeder point and coiling of the left lumbar arteries. However, the patient continued to deteriorate. His lab parameters deteriorated, and the repeat CT showed an increase in the hematoma. Patient was then managed conservatively with the blood products, however, succumbed to the illness. So this was a very good case that we could treat, and unfortunately, we lost the patient. This was another case, a 59-year-old lady, diabetic, hypertensive, hypothyroidism, again presented with acute abdominal pain, showing deranged liver function tests, thrombocytopenia, and raised COVID markers. The CT scan abdomen showed a bleeding in the perihepatic, perisplenic, and bilateral pericolic gutters. The patient was treated with antivirals, inotropes, antibiotics, blood products. Fortunately, we could save this patient and she went home. This was her CT picture showing the bleeding in the pericolic gutters. And this was another case, a young male who came with acute abdominal pain. He had a history of COVID disease 2 months back. The pain was radiating to the back, and the angio, which was done, CT angio, which was done, showed a thrombosis in the superior mesenteric vein as well as the portal vein. The patient was managed conservatively with low molecular weight heparin, PPI infusion, and antacids, and discharged on oral anticoagulants. Coming to hematological complications, septic shock and multi-organ failure, very commonly seen. It is usually a terminal event. Then thromboembolism, this is a significant problem that we see in our COVID-19 patients, and it is because of the heightened inflammatory response and the phase of cytokine storm. And hence, it goes without saying that these patients should be on thromboprophylaxis. So, all hospitalized patients with COVID-19, moderate to severe disease, should receive prophylactic dose of anticoagulation unless contraindicated, which means whether the patient has got an active bleeding tendency. Otherwise, all the patients should receive prophylactic anticoagulation. Which anticoagulation? Low molecular weight heparin or unfractionated heparin is preferred over the oral anticoagulants because of their shorter half-life and ability to be administered intravenously or subcutaneously, and very few drug-drug interactions. You may think of fondaparinux if it is a problem, and mechanical thromboprophylaxis like pneumatic compression pumps if anticoagulation is contraindicated. All those patients who are getting discharged from the hospital, whether they should be put on thromboprophylaxis, yes, there are certain guidelines. So all those patients who are at very high risk, like the bedridden patients, the patients who had got moderate to severe disease with high CT scores and high oxygen requirements, obese patients, and those patients who had got very high D-dimer levels, that means more to 2 to 3 times normal pre-discharge, should be going home with thromboprophylaxis. The FDA has approved the molecule rivaroxaban 10 milligram daily, and the duration is around 4 to 6 weeks for these patients. Psychological problems, very commonly seen, and usually very common in those who already had got a psychiatric illness, elderly patients, prolonged hospital stay, patients who have already had addictions, and healthcare workers. The spectrum can be anywhere from hallucinations, psychosis, fear, frustration, guilt, and depression. Coming to pregnancy and COVID, some guidelines by the UK Royal College of Obstetricians and Gynecologists. It definitely causes a significant disease and mortality in pregnant women. However, pregnancy is not a contraindication to any of the treatment options which we are going to discuss. This is by the UK Obstetric Surveillance Survey, which has defined that there is increased rates of ICU admissions in pregnant patients with COVID disease. Commonly, risk factors are the ones like maternal age more than 35, body mass index more than 30, and all those ladies who already had got chronic hypertension and pre-pregnancy diabetes. The rate of fetal loss, it is still under investigation. We still need more data, how much is the rate of fetal loss. About the imaging, the national guidelines state that pregnant women should not be exposed to doses of radiation more than 50 microgyri. However, a single chest X-ray or a single CT scan should not be denied to the ladies in the benefit of the mother status and can be done. Treatment options, recovery trial has advocated the use of steroids, either oral or intravenous for these ladies. And remdesivir can be used, though there is very limited data on the what effects is going to have on the fetus. So in favor of the mother status, it can be used. And so is the case with tocilizumab. documented in the recovery trial. Male reproductive complications, we are still not very sure what it causes, but it probably the previous SARS infection which caused orchitis and male infertility. So we still need more data about the COVID-19 virus, about male reproductive complications. And coming to the last one, that is the opportunistic infections. They are extremely common in moderate to severe COVID disease, nearly 10 to 30%. The causes being mainly the immune dysfunction because of the virus and immunosuppressive drugs which we are using in the treatment like steroids, monoclonal antibodies, addictions like alcohol, smoking, these patients are more prone, misuse of antibiotics, and of course the prolonged hospital stay. They are commonly seen in the second or the third week of the illness. This is a spectrum of infections, bacterial, gram-negatives like Klebsiella, Pseudomonas, E. coli, Acinetobacter, gram-positive, and atypical infections. Co-infections like other viruses like influenza A and B also should be kept into mind. And of course, the fungal infections. This is nothing but the fungal infection, that is the aspergillosis, which can be seen in the severe COVID-19 patients. The diagnosis, it really needs bowel sampling, but it should often be suspected in all those patients who start showing a worsening of the respiratory function in the third week of the illness. Candida auris is being recognized continuously in this COVID-19 pandemic, and the mucormycosis. So we had one recent case of mucormycosis. So this is the infection by the mold from the family Mucorales, and it often occurs only in the immunosuppressed patients. The common risk factors in COVID being uncontrolled diabetes mellitus, use of broad spectrum antibiotics, use of steroids, and the monoclonal antibodies like tocilizumab. It is a very aggressive and life-threatening infection because it is angio-invasive. It usually affects the sinuses, eyes, and brain. So, what the term which is coined is rhino-orbitocerebral. The diagnosis can be done by direct microscopy or by fungal cultures. And in the treatment part, amphotericin B, posaconazole, the newer drugs like isavuconazole, and early surgical debridement, maybe even fixation of the eyeball. And in spite of aggressive treatment, very high mortality. So this is my last case, a 65-year-old male, diabetic, hypertensive, ischemic heart disease, severe CT score of 24 by 25, was treated by the usual guidelines. However, in the third week of the illness, he developed severe headache, vomiting, left eye pain, and diminution of vision. Imaging, CT PNA, CT orbit, MRI orbit confirmed the diagnosis of the left rhino-orbital mucor. Scrapings were sent for HPE, which also confirmed the mucor. Patient was treated with liposomal amphotericin B. ENT surgeon was involved. Surgical debridement was done. Ophthalmologist was involved. He also advised evisceration of the eyeball. However, the relatives refused. Posaconazole was added because the relative refused aggressive treatment. So, as part of medical treatment, posaconazole was added. However, because of financial constraints, the patient went against medical advice and later succumbed to the illness. These are the imagings of the patient. You can see the the affection of the sinuses, also erosion of the orbital wall. However, there was no involvement of the brain in this patient. And these were the surgical images the ENT surgical surgeon shared with us. And the video, which you can see the black patches of the mucor. So I'll end with these take-home messages. COVID is not over as yet. We have to be prepared for a long haul and multiple waves. And any new or uncommon presentation of a common disease or ailment should be suspected as COVID. The road is very long. We are still not seeing the end to it, but let's keep fighting. I thank all my ICU team who have been with me in the COVID as well as in the non-COVID areas, and all my co-consultants who have shared their cases and their inputs in preparation of this PPT. I thank all the participants for a patient listening. I'll hand over the mic to the organizers. Thank you.
Thank you, madam. Thank you for providing us with this always evolving, ever-evolving infection of this COVID-19. Still, we are in a learning phase of learning the pathophysiology and the complications of this dreaded disease. Thank you, ma'am. Our next speaker is Dr. Harish Shetty, an eminent speaker. He's a senior consultant psychiatrist working in community mental health in Mumbai. He has worked with victims of disaster and communal riots. His legal interventions have changed mental health policies throughout the country. He is an avid blogger and mental health activist. He has visited Nasik IMA many a times and always is willing to help IMA for a good cause. He is very media friendly and he's an opinion maker in mental health. So let's listen from our eminent speaker, Dr. Harish Shetty. Over to you, sir.
My topic today is trying to see the metaphor between the India-Australia match and Corona. And thank you, IMA, for inviting me. And what a brilliant presentation by Dr. Sudarshana Patil. Absolutely lucid, very clear, and a lot of learnings which go straight into the brain. When I look at COVID and I look at cricket, two C's, I recall Saurav Ganguly waving his shirt in the Lord's Test match. A lot of opinions from the country said that he's audacious, he's abrasive, he's arrogant, आपली पद्धत नाही असं लोक म्हणाले. माझं म्हणणं दुसरं आहे. India got independence in 1947 out of an accident. British had to leave. The real war of independence is happening now. And when he did that, what he said was, we have arrived. It may not be only by the shirt, but it's also by the bat and the ball. Audacity shakes you from your sleep. It recharges your brain. It brings you out of the complex of inferiority. And nobody, India had it. In spite of the independence of 1947, we felt the yoke of the British for a very long time. Indians never had opinion. हो म्हणायचं सगळ्यांना. चांगला पुरुष सगळ्यांना हो म्हणणारा. ट्रेन मध्ये जाताना बाजूला कोरोना व्हायरस असला तर तो म्हणणार कोरोना व्हायरस तू तुझं काम कर मी माझं काम करतो. Abrasiveness, audacity, उद्धटपणा is important in life, occasionally, not always, along with skills. And I bring that metaphor back to the CMEs. Sudarshana Patil made a brilliant presentation. Honestly, I'm not praising her just like that, but lovely presentation. But there are so many others who quote a lot of journals just to show.
Sir, may I interrupt you?
Yeah.
Sir, please start your video. I'm not able to see you.
It is on. I can see myself.
We can see Dr. Harish.
Huh.
Okay.
Yeah.
Thank you.
So there are CMEs which happen where people just share information from journals out of arrogance. And people like me sit and say, आम्हाला काही माहित नाही, हे लोक पुष्कळ बोलतात, ते लिहितात, आम्ही काम करतो, पण हे लोक काय बोलतात? And that has to change. That will change only when people who sit in the audience also read and put their hands up and say, तुम्ही फेकतात, हे खरं नाही, खरं म्हणजे असं आहे, तुम्ही लॅन्सेटचे आर्टिकल संपूर्ण वाचलेलं नाही आणि आमचा अनुभव वेगळा आहे. And that confidence was brought in the country by people like Saurav Ganguly and others in all fields. Saurav Ganguly coincides with a lot of middle-class parents going to America for the convocation of the children who are studying in America. Saurav Ganguly coincides also with a lot of Indians who can look into the eye and talk, who can look into the eye without any confidence, without any inferiority. Those days it was different. When Imran Khan bowled, you felt Aurangzeb was bowling at you. When Ian Botham bowled, you felt Robert Clive was bowling at you. But a few people, Sunil Gavaskar, Sachin Tendulkar, and others stopped them. But the numbers were few. Everything changed, and from there we had different people. We had Dhoni, we had Kohli, we had Sehwag. We had so many others who looked into the eye and without any inferiority complex, without any complex, would hit the ball and be like a true Indian. What happened afterwards is extremely important. The India-Australia test match started and we were bowled out at 36 completely, all out. And that's how I can see the metaphor of Corona attacking India. A lot of people across all institutes said, 5 लाख लोक मरणार, IIT बॉम्बे घरी बसून कम्प्युटरवर मॅथमॅटिकल फॉर्म्युला सांगून लोक मरणार आहेत, एवढे लोक मरणार, forgetting that India is a different country. India is a changing country. India is a country that is looking ahead. India is not the Rana Pratap who allowed Man Singh to escape when he was trapped in the jungle. India was Shivaji who did not spare Afzal Khan when he went to war. India was Tanaji who stopped the army of Aurangzeb to save Indians around that time. India was different, and then India lost 36 all out. I can imagine the dressing room behavior. It was not shoulders drooped. It was not atak आम्ही काय करणार. It was not सगळं जगा पॉलिटिक्स आहे. ग्रीन टॉप मध्ये आम्ही खेळू शकत नाही. आमच्या घरी ते लोक ग्रीन टॉप ठेवत नाही. It was a black belt karate. Ajinkya Rahane talking to everybody. It was Ajinkya Rahane who probably thali bajaya hoga, diya jalaya hoga. And these two metaphors were important at that time in the country to get the country together, to get a sense of belonging so that we can fight the war together. And there were few players who have never played. The top players were injured because Corona hit the country very badly. And the few players who were waiting to play did not say, आम्हाला चान्स नाही मिळत, सगळे ठिकाणी पॉलिटिक्स आहे, ते असे नाही म्हणाले. ते म्हणाले मला चान्स दिया, हम चान्स पे डांस करेंगे, हम छोड़ेंगे नहीं, हमें 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 प्लेग्राउंड पे उतारो. And they were our Corona warriors who went without fear. Fearless is the metaphor for the youth in India. Fearless is the metaphor for the young doctors in India. Fearless was the metaphor for doctors. It was not Jinku Kiva Maru, it was Jinku and Jinku. Many of us died. Many of our brothers passed away. And it was a sad moment for us. I lost many of my friends. But these boys, when they went up to the pitch, they looked into the eyes of the bowlers. They said, "Chance पे dance करेंगे." Rahul Dravid ने हमें सिखाया है. Under 19 में हमने बहुत खेला है. As RMOs, we have practiced, we have worked and seen 200 patients. We will not spare the coronavirus. And then the dance started. Muhammad Siraj, like Muhammad, who was an archaeologist, excavating temples and mosques in UP. Muhammad, who was like Abdul Hamid in the 1965 war with Pakistan. Muhammad, who was like any Indian across the country. No fear. समोरचा माणूस गोरा आहे की काला आहे, सावला आहे की तांबडा आहे, काही भीती नाही. माझं स्किल आहे आणि मी सोडणार नाही. माझ्याकडे रेमडेसिवीर आहे, मी सोडणार नाही. मी प्रत्येक पेशंटवर तेवढंच उपचार करणार आणि तेवढाच कमिटमेंट मी काम करणार. असं करत करत what happened after that was Akshay Rane stood there and scored 100. Hanuman Vihari stood there and saved the test. Ashwin batted, who never was expected to bat, and saved the third test. India is changing. Whoever is the prime minister, India is changing. And in the test, in the deciding test, there was one man who stood there, facing all the blows. Similarly, like the man who's sitting in Delhi, who's facing all the criticism. Cheteshwar Pujara is like the man who's abused day in and day out. But he doesn't bother. Karma yogis don't bother. Karma yogis like Cheteshwar Pujara did not bother. 2 hits on the head and many hits across the body. He faced it all. तो पण गुजराती, हा पण गुजराती. आणि असं करत असताना it showed the mettle of an Indian, of the new Indian. It showed the courage of the new Indian. It showed that India has arrived. What happened in 1962 will not happen in 2021. आम्ही घाबरणार नाही, आम्ही गप्प बसणार नाही, आम्ही येडे नाही, आम्ही तुमच्यावर विश्वास ठेवणार नाही. We have guile. We are not as foolish as we were. A culture which is old is always pure, has a lot of compassion, and that's a sign of weakness because the cultures around us have less compassion and have a lot of guile. असं असताना 1962 जे काय झालं ते 2021 मध्ये 2020 and 21 मध्ये आम्ही ठोस उत्तर दिले. आम्ही घाबरणार नाही. That is seen in the cricket field, that is seen in the hospitals, and that is seen in the war zone. India is changing. And as we moved and we stood there, there was one man who was facing the blows, and on the other side there was one man known as Pant who was facing the balls and hitting it all over. And this Pant is a metaphor for the Indian doctor, for the Indian healthcare worker in hospitals, going very in great trepidation, inertia initially during the Corona war, fought the corona war by working for 18 hours a day, 20 hours a day. Our ICCU intensivists, our residents, our healthcare workers, our nurses, our ward boys, our morgue attendants, our ambulance drivers, our police, everybody stood the ground, though few made hay where the sun shines, like the ambulance workers, those who sold the PPE kit on blacks, those who sold the mask on black. असे हलकट असतात तो समजत काय करू शकत नाही त्यांचं प्रमाण कमी करणं आपलं काम आहे. My dear friends, as Pant changed the paradigm of the match, as we changed the paradigm of the country by seeing that the improvement figures were above 95, when people were dying all over, when people wanted herd immunity in one of the most powerful countries, United States of America, where there was negligence and United Kingdom and people died in lakhs, we acted fast. कारण आपण 1947 इंडिया नाही, आपण 2020 इंडिया आहे. And we acted fast, and what happened was history. What happened was history, and that history is something which will teach Indians across the country. छाती खोल उघडून, छाती ठोकून, कोणाचाही डोळ्याला डोळ्या लावून आम्ही काम करू शकतो, and this is what it is. As Corona went ahead, and we were happy that we managed the first surge, we managed the lockdown, we could manage a large number of families. We brought faith in 130 crore Indians. We came back to India to face England. Confidence high. पण Corona म्हणतोय आम्ही तुम्हाला सोडणार नाही आणि फर्स्ट टेस्ट आम्ही हारलो. The balls were flying all over and we lost to a man known as Root and the bowlers who were extraordinarily good. But the small hit, we come back from the hits immediately. Yeah, there was one day when India went to Australia and he lost all 4 matches. एकदा हारलो तर पडलो, आम्ही पडणारा माणूस नाही. We learned from a mistake and we stood up. We stood up in the second test, and when everybody complained, everybody said in Australia also we lose 4-0, and everybody said after England won the first test, we had no match, that was a fluke victory. We stood up. The Corona warriors continued. Vaccines were made across the country. Indian vaccine came up. The Bharat vaccine and the Covishield vaccine. पण आपल्याकडे आहेत ना लोक, ब्रिटिशच्या काळात पण होते, ते पण वॅक्सिन आपलं नाही ना, ते पण थर्ड ते स्टडीज बरोबर झाला. हो दादा, एमर्जन्सी मध्ये एमर्जन्सी नॉर्म्स करणं आवश्यक आहे. दिस इज नॉट आयडियल टाइम्स, दिस इज नॉट व्हेरी युटोपियन टाइम्स. We have been facing an emergency. In emergency times, you need to do shortcuts. Do you want the virus or do you want the vaccine? Tiger paije ki talwar paije? That was the question, and we stood up in the second test. The ball was churning. Ashwin told us what he was. Our Corona warriors told us what they are. Our vaccine committees told us what we are, and we could make so many vaccines which could be sold and sent across the country. Vaccine Maitri. And here Ashwin proved to us, and many others proved to us, that we are not the same. We can come back from a fall quickly. We don't have to wait for years. We don't have to wait for few test matches. And as we continued working, vaccines came up. We won the second test convincingly. सगळे म्हणाले तुमचं pitch काय आहे? Harsha Bhogle said it very beautifully. We won at Lords, you won in Bombay. Pitches are dusty tracks, trampolines, and green tops. It is how you play is important. Coronavirus is everywhere, but how we played the Corona in India was important. And that, I think, credit goes to each and every Indian across the country. Though we also say that we are a fatalistic country, we believe everything is gone, the masks are dropped. And as I slowly stop my presentation, I would like to say, my dear friends, as Dr. Patil said, Corona is not gone. There is evidence to say that the mutant strain is in Maharashtra. And I'll tell you why. People who have come back from England have gone to Hyderabad, landed up in Nandurbar. And from there, the strain has come up. Amravati is now in a very difficult state. The strain has come up across many parts of the country. There is evidence to say that a microbiologist in the state, I will not say which institute, believes that this strain is a mutant strain. And as we slept in 1962, we can't sleep in 2021. Alert, be alert. Eternal vigilance is the price of liberty, said Jawaharlal Nehru ji, and that is more applicable today. That is more applicable. So as Dr. Patil said, Corona is not over. Let us be alert. Let us mask and let us vaccinate. Let us tell the state government if Maharashtra there is a rise, it's because of the population, not because of the party. It's not because of the party, it's because of the population. So let the central government give us a lot of vaccine. Let us vaccine all the ST stand travelers, all the local train travelers, all the BHT travelers, and do something very innovative so that we stop the corona spread in the country. And as we go to the fourth test match, we are not placid, we are not complacent. The third test match, we are not complacent, we are not placid. We are alert. We're alert. We'll wear our helmets. We'll wear our guards. You might hook the ball across square leg to six, but you might leave some balls because we need to leave the virus and not take it on our face. So, my dear friends, to summarize, India is on the threshold of a great tomorrow, and the tomorrow is because of the youth of today, the architects of today. Corona and cricket are metaphors which can be compared. Corona and cricket are learnings which we can learn. Corona and cricket have a lot of lessons for doctors, and those skeptical doctors who always whine. नाही phase 3 study आलेला नाही, खरंच नाही आलेला आहे. In Covishield phase 3 study was not in Covaxin phase 3 study was not published, but all the vaccines are in experimental stage, including the Pfizer. So हाथ आगे करो, take the vaccine so that others also accept the vaccine. Let's push public policy to see to it that the poor, the elderly, and those very vulnerable get the vaccine. Let's play cricket as we are fighting the coronavirus. Let's fight the coronavirus as we play cricket. With this, I thank the organizers for inviting me. I thank Vijay Singh Patil, Kiran Birari, and others who are on the show. I thank my famous friend Umesh Nagapurkar. Thank you all for inviting me. Let's fight Corona. Let's play cricket. Let's enjoy both the games. Thank you.
Thank you, sir, for such a Joshila lecture. Our next speaker is Dr. Vijay Singh Patil. He is a young, dynamic interventional cardiologist, also director of Cath Lab and consultant interventional cardiologist from Ukad Hospital, Nasik. He has done his MBBS and MD from Maharashtra University of Health Sciences. His DNB Medicine and FNB Cardiology. He is member of Cardiological Society of India and also many publications in national and international journals to his name. So we will be speaking on wall replacement without surgery. Have I mispronounced it? Absolutely not. It is wall replacement without surgery. Over to you, Vijay.
Good morning, everyone. Just now we got the refreshing lecture by Dr. Harish. And thank you, Birari sir, for such a nice introduction. So on behalf of IMA and Ukad Hospital, now this is something new I'm going to speak today, wall replacement without surgery. Is it possible? Yes. Then how and where we can do the wall replacement without surgery? Actually, morning's Dr. Chopra sir's lecture has shown some highlight on how the valvular interventions are coming up. So I'm going to show non-surgical interventions in wall lesions. So what are the options for routine surgery, and what are the percutaneous or non-surgical options? As we all know, initially for mitral stenosis, we were doing open mitral commissurotomy surgically. For that, now option came up as a BMV, balloon mitral valvoplasty. And that give fairly 10 to 12 years prolongation of surgery. Yesterday only I did one BMV where a patient underwent previously BMV 10 years back. Now again restenosis, again second time BMV done. So patient got 20 years life without surgery of severe mitral stenosis. Second option for open pulmonary valvoplasty, we can do balloon pulmonary valvoplasty. And most important now in this century or in this last 20 decades, 10 decades, it's coming open aortic wall replacement Now it is replaced by a TAVR, that is transcatheter aortic wall replacement or implantation. And this is most fascinating surgery or percutaneous intervention come up in last few years in intervention cardiology. Along with that, for mitral wall replacement in case of mitral regurgitation, basically when there is LV dysfunction, LV is dilated and MR is there, we have percutaneous option of mitra clip. And for bioprosthetic wall, which previously placed by surgically, for that, if again restenosis or regurgitation happens, then again we can use the similar way at aortic position transcatheter aortic wall replacement and mitral position transcatheter mitral wall replacement. So these are the non-surgical options what cardiologist can offer over the surgery. So now I'm going to speak basically on this TAVR or TAVI. What is it? It's actually in majority physicians, even cardiologists, this is a new thing come up, and this is a very good option and evolving option in intervention cardiology. This is transcatheter aortic wall replacement. So I'm going through the case example and I'm going to show how the technology has developed, what are the current indications, how the procedure has been done, what are the benefits, drawback, and finally summing up the with conclusion. So this was 2 years back. We have done this 66-year male patient admitted with severe degenerative aortic wall stenosis with multiple comorbidities with high Euro score. He was having COPD, post-chest radiotherapy, diabetes, hypertension, and multiple times surgeons were refusing for surgery. But he was symptomatic, shortness of breath, chest pain, syncope was there, and gradient was more than 80, peak gradient and mean gradient was 48, and EF was fairly okay. So what we did through the femoral artery, this big sheath we are placing across the aorta, and we are crossing the valve, and this stiff wire we are placing into the LV, and over that wall, what we are doing first, we are doing this balloon aortic wall valvoplasty. With this, the valve is getting open, and but why we are not doing only this BAV? Because the long-term outcomes and the complications are very high with only BAV. The restenosis rate in a year is again 80% nearly, and if AR develops, it's a devastating. That's why only the BAV is not option. So percutaneously from femoral artery, we are putting a bigger sheath. We're crossing the wall, and with crossing wall, we are placing this aortic wall across the aorta. And now this opening this wall across the aorta, this is a calcific aortic wall, and after proper assessing the position of the aortic wall, we're gradually opening this wall, and finally releasing this wall at the correct position and removing the all assembly. So here, this is a stented wall. This is like a coronary stent. The wall will be, the stent-like structure will be there, and inside that, leaflets will be there. So it's a bioprosthetic stent we are placing at aortic position, and fairly after this, after 6 hours or 8 hours, if we are doing percutaneously, totally percutaneously with proglide, then a patient cannot walk after 6 hours. So definitely this is very good option for the high risk patients. So coming back, how this technology developed. Just now, sir has given a lot of metaphors. So this is also a success example of successful translation from research in medicine. So it's thanks to our outstanding partnership between multidisciplinary clinician and engineer. It's not only one job. It is engineering job also to develop the stent structure and the various bench to the clinic model, clinic to the animal models, and then animal to the final human models. And this is a disruptive technology evoked lot of skepticism, criticism, because it's something new, and how the wall can be replaced without surgery. That was a concept, and it's totally disruptive technology world. Lot of criticism initially, but thanks to our innumerable clinical trials over the last 3 to last 10 years, partner 1, partner 2, partner 3 trials has shows definitely usefulness of this technology, and now it's widely accepted by medical community, and its acceptance is going continue to growing on. In the last 14 years, Tower has been performed in around more than 3 lakh patients in 65 countries. And adoption is increasing by 40% year on year. The field of Tower is rapidly evolving with major refinements in technology, procedural techniques, patient selection, and biomedical engineering. With the development of better devices, new approaches, and new implantation strategy, TAVI has become much simpler and safer over a period. So what are the current indication? Initially, it was very limited for the elderly aortic stenosis with multiple comorbidities. But now, cautiously and appropriately glowing is used in broader population with lower surgical risk, mainly in degenerative surgical bioprosthetic, even in patient with other valvular disease like aortic or even mitral insufficiency. This technique is useful. There are few examples in a clinical field of medicine which match the rapid and careful evaluation of TAVI. So why this technique has developed? Why we need this such a technique, though we have the surgical aortic wall replacement? So calcific aortic stenosis, mostly degenerative. We are seeing a lot of rheumatic patients, but nowadays rheumatic, even in India, rheumatic patients are decreasing. In last month only, I have seen we have doing the surgical AVR where most of the nearly 50-60% patient now coming with a degenerative aortic stenosis, and this is most frequently acquired valvular disease in developed country, but now it's growing in our country also. And this is mainly disease of aging population. As population age is increasing, the AS and incidence of AS is also increasing. And natural history of symptomatic aortic stenosis, as all of us know, it's a very poor prognosis. Once symptom develops, survival rate is 60% at 1 year and 32% at 5 years. The only effective treatment for decades is the surgical aortic wall replacement, and with remarkable result in ideal candidate, but which required invasive heart surgery with extracorporeal circulation. Operative mortality in ideal candidate with low risk patient is less than 5%, and patient can return to normal life expectancy is observed in follow-up patients. However, in elderly patient, operative risk including post-operative complications, mortality significantly increases in elderly patients. And those who are having cardiac and non-cardiac comorbidity, definitely it's going very high. These factors are considered one of the reason for not doing the AVR, surgical AVR in nearly one third of patients. And that's where this tower technology grown and useful. So nearly 60 to 80% or two-thirds of patient can ideal candidate for surgical AVR, and there we should do the surgical AVR only because it's a safe and lower mortality, because their mortality will be the 80% because they have the comorbidity, they will have the severe AS, then they need some solution, and that's why this technology has arisen. And this concept basically came from BAV in 1990s. Initially patient they were doing only BA, balloon aortic valvoplasty. Then this concept came, if we put the stent, the angioplasty concept has came, holding the stent, and the concept of putting stent across the wall and moving the steno's leaflet outside and putting the inside this the stented wall, putting the valvular like structure, bioprosthetic structure, and developing the wall has evolved. So initially in a preclinical state, in vitro to bench testing, they have tested for hydrodynamics, durability, fatigue testing, frame strength testing, and crimping and delivery systems analysis has been done. And over a period, then in vivo animal study has shown for these, and finally it has done in human. And when it was done in 2002. First implantation was done in Rouen by Dr. Alan Cribrier. and he is the pioneer. This man is a pioneer of this technology. He has devoted his whole life. He has not done many coronary work, but for the structural, he is doing. Initially, he was doing BAV and the mitral BMVs, and over a period he devoted life and he developed the stent with help of engineering. Luckily, last time, before Corona, I was able to meet him, and he's excellent orator and he's an excellent teacher. So over a period, the Cribrier and Edward has developed multiple walls, and this is how the wall will. This is balloon inflated wall, and initially what I had shown was core wall, that is self-expanding wall. And now in current scenario, we have two types of wall. Those are the Edward sapien walls. Those are the balloon mounted. The stent, it's like a coronary, coronary stents. Inside balloon will be there. Over that, this stented wall will be the mounted in a crumpled fashion. And in core wall, this is self-expanding over a mechanical device. It will be placed and automatically it will get expanded. And these are the currently available wall. I use this core valve and portico and the sapien wall. Now even Indian walls also available. So going through the some technical aspect or how the procedure is been done. So first we are taking left femoral artery puncture through this small pigtail we are keeping, because this is the most important stage to have the patient percutaneously treated, because this femoral artery is a key for going bigger sheaths. We are putting 14, initially we were putting 18 to 20 French sheath, now 14 French sheaths are there. But if we are not putting properly here at a particular place, the risk of rupture of this artery complications, vascular complications are high. And then after putting the sheath on right femoral artery, we are taking this pigtail injection in aortic root injection. This is showing calcific. This black color is a calcific, severely calcific aortic wall. And next task will be the crossing this wall. This is very difficult stage with multiple wires. We need to cross it properly. You can see how the wall is crossing here. And once wall is crossed, we can place the pigtail, and over that stiffer wire we can place in the LV. And this is how the once the wall is crossed, this assembly will be there. This folded wall, you can see the wall is folded here in the sheath, and this sheath we are crossing across the wall and placing here in the across the wall. This is how I was preparing this wall outside. And this assembly, once prepared properly, we need to push inside human body and across the aortic wall. So once crossing the aortic wall, the stent, we need to take a proper position. Very deep position or superficial position is not required. Proper position, we need to assess multiple angles, multiple times. Here, core wall, we can expand initially till 2/3 level, and then even resheath also. If position is not proper, we can adjust the position, and finally we can release the wall here. And this is how the wall looks. So this is self-expanding wall. Wall will be at this level, and the leaflets will be inside. So over a period, not only the technology, but it has been tested in various clinical trials. So in previous, the concept and development of first in human experiment was 2002, and concept was started in 85. And over a period, once it was tried in a human, it was transapical, and there were 2-3 routes. Mainly the transfemoral is widely accepted and very feasible routes, but we can do transapical, we can do from transcarotid, from subclavian also we have done 1 or 2 cases. And even now IVC side, if femoral artery side is not there, from the IVC side to puncture to the aorta, and that way also nowadays we are doing the procedure. So over a period in multiple trials like partner 1, partner 2, and partner 3, initially it was limited only for the high risk aortic wall stenosis pressure, but now in partner 2 and partner 3 trials they have tested in moderate to severe, moderate or low risk patient also. And mainly in Indian scenario, even bicuspid aortic wall, initially it was dedicated only for degenerative, but Now bicuspid aortic wall also we can use. And what are the advantages? Why we should do this? Why we should develop this technology? Because it seemed like a PTCA. It did not require the general anesthesia. We can do with a conscious sedation from the femoral artery route. It is done like a PTCA, so hospital stay will be limited for 1 to 2 days. There won't be any surgical car, and patient can walk after 6 hours if it is done totally percutaneous, like with ProGlide or ProStride devices. As any technology, any procedure, there will be some drawbacks. And important drawbacks are the pacemaker implantation rate is very high, with some like core wall and those if we implanted on lower side, because near the aortic wall there will be the AV node, and any compression by the calcium of the aortic wall to the AV node will lead to the complete heart block and need of pacemaker. As we are dealing with the calcium at the aortic wall, stroke risk also is very high, which we can minimize with putting filter in both carotids. So stroke risk will be reduced. And most important for Indian scenario, the cost is the main issue. Till date, initially it was only the Sapien and Medtronic's walls were there, but now even Indian Meral company also started my wall, and now cost is reduced by nearly 50%. So concluding, Tower, a 20 years long inspiring and successful journey from concept to real world. This is something new happen in intervention cardiology, and it's a breakthrough technology challenging the foundation of medical practice, enabling thousands of patients with severe AS to receive life-saving effective alternative treatment to surgical aortic wall replacement. It's excellent and unequal collaboration spirit between the clinician, not only the medicine but engineering field also involved in this to develop the prosthesis and develop this technology, and who have provided their expertise with unique goal of making this procedure not just possible but also safe and successful. We are not reaching the end of the story. The continuous translation work promises further technological innovations that will soon make Tower simple and safer. Within 10 years, it is likely that Tower will become the default strategy for the patients with symptomatic AS. So this is how the technique has been done. And mainly all data is from the Alan Cribrier. Thank you.
Thank you, Vijay.
Thank you, sir.
Our next speaker is Dr. Shiv Prakash Naik. He's an eminent speaker, pediatric congenital cardiac disease specialist. He's widely known as Dr. Shiva. He's a director of pediatric cardiac sciences and chief pediatric and congenital heart surgeon at Sir H.N. Reliance Foundation Hospital, Mumbai. He has done his MBBS and MS from Bangalore Medical College and earning gold medal. He has done his MCH from PGI Chandigarh and fellowship in pediatric cardiac surgery from Royal Alexandra Hospital, Sydney, Australia. He has operative experience of more 10,000 pediatric and congenital heart surgeries. His areas of clinical expertise include complex reconstructions, neonatal cardiac surgeries, cosmetic congenital heart surgeries, and valve repair in children. He was also former president of Pediatric Cardiac Society of India from 2016 to 18. He also has several original articles published in various national and international journals and more than 65 publications in leading international journals. So he'll be speaking on pediatric and congenital heart surgery in current era. Over to you, sir.
Am I audible?
Yes, sir.
Very good morning, Kiranji, and all to the respected panelists. And thank you for sharing my whatever the experience, small wisdom I have gained over the last 30 years in my field. To share it with all of you, it's a pleasure and it's a privilege for me. And having said that, काफी बुजुर्ग लोग हैं मेरे चाचा जी जैसे in the group, and मेरा warmest pranam आप सबको. And let me not waste my time. Let me come to the point straight away. Vijay just now spoke about something which was completely exotic and outlandish, and which was extraordinarily good, like a special effects movie. And from there मैं आपको नीचे लेके जा रहा हूँ पूरे के पूरा, like similar to Mumbai local. So this is the pediatric cardiac and congenital heart surgeries. What we do in India, we might be doing a lot of cutting edge work, and there might be a lot of cutting edge technology in our field. But dominantly, it still remains a common man's problem, and we still, as a nation, are still struggling to find ways to address this because of the huge backlog and also of the ever increasing population, and thereby naturally increases the number of congenital heart diseases, the children who are being born every year in this country. And the unique thing about my specialty is it's a fusion, I should say, very brilliant fusion of pediatrics, surgery, and cardiology. And it requires exclusive pediatric heart surgeon, pediatric cardiologist, anesthesiologist, intensive care, and perfusionist, besides nurses who are trying to take care of children, observing the basic hemodynamics, which could be crucial, like just simple CVP, heart rate, BP, to improve the survival. And hence success in this field really depends upon not as a individual surgeon or an operator, but it's to the collective wisdom and the teamwork and an absolute passion to deliver care in the most adverse of circumstances. So in a way, it mandates a sense of ownership from all disciplines, from all professionals who are involved in this care, and not just the surgeon alone. So an index I'll give as an example, an index case, a child who is having a fever and operated for congenital heart defect in this country. There are surgical causes, there are pediatric causes, and there are cardiological causes. And surgical causes, as you know, that usually we learn three things: wound infections and urinary tract infections and thrombophlebitis. At the same time, pediatric context, may pediatrician tends to think that it could be a chest infection, it could be drug related, it could be anemia, or it could be plain and simple sepsis if the child is an infant or otherwise a neonate. A cardiologist, from his viewpoint, he tends to think that it could be endocarditis. So all these three disciplines should come together to precisely identify what exactly is the problem, and then only I think we can find way. And that is how the success in this discipline, in my discipline, essentially depends upon collective wisdom rather than individual heroism. And that's the reason I put this slide to show that synchronized skydiving, just to highlight the importance of various players coming together. There should be good parachute, there should be a long learning curve to go through this skydiving exercises, and then there should be a passion to draw excellent. Third, fourth one is that it requires a lot of discipline to maintain and create these sort of images in the sky. And the pediatric cardiac surgery is something similar like that, because there are various issues which dog a simple child, and a child who could be having a simple ductus arteriosus or otherwise a child who is having a complex heart. It still requires a lot of players coming together and creating a perfect symphony to create great outcomes. As I told you, world population is going to reach shortly close to 8 billion, and more than 60% of the population of this planet, they belong to Asia. And that only indicates the gravity of the problem which could be coming in the form of congenital heart diseases. And as you can see, the top 10 nations, in that almost 5 nations, they belong to Asia, accounting for 60% of the population. So a small article, a very insightful article, Dr. Anita Saxena, my good friend from All India Institute, published, telling that at the worst scenario, it could be 180,000, but the best scenario still is 90,000 children suffer from critical cardiac lesions requiring early intervention and surgery or surgery. And approximately 10% of the infant mortality rate in India, it could be because of congenital heart diseases alone, which has not been audited so far. This is one of my favorite slides. I keep putting that, in 2009, when I came to Maharashtra from Matamrutanandamai, Kerala, I had predicted that, what was there in 2010 and what is there now. I had told that, we require 10 times more centers in India, in the state, to create an adequate platform to address congenital heart diseases. And I'm happy to say that the number have really increased from 2 in 2009 to almost 10 in Maharashtra, indicating the importance of having congenital heart surgery centers and the requirement of them in such large numbers. And this is a prelude because this is my first original publication, what I published after becoming a cardiothoracic surgeon in 1991-92. And 4 years later, when I published this original article along with Dr. K.M. Cherry and my mentor, we had given for 60 cases of a complex heart defect called total anomalous pulmonary venous connection. The mortality rate was 33%, means 1 in 3 children we are losing. And this is about quarter century back. And now if you see, there is a great turnaround. Science has advanced to that extent. The same TAPVCs, we are practically having 1 to 3% mortalities in best of centers in this country. And along with that, I put complete AV canals, transpositions, some of the equally complex lesions. There are much more complex lesions than this, and there are much more simpler problem than this. I am not going to dwell into all those in greater detail. I just want to say that all these complex anomalies, we were having 33 to 50% mortality 25 years back, and now we hardly have anything. We are not reached zero. That's not possible. Only God can achieve that. But as far as I am concerned, we are somewhere close to that. And as mortals, particularly in South Asia, in India, to achieve this from of the selected centers in India, it's really laudable. And it's through the prism of my own eyes, last 3 decades, what I have seen, that this great turnaround has happened. And it is much better, much better, the scenario in Maharashtra, in India as such now, that almost all the children with congenital heart diseases are treated here only. Now there is no need for any child from Maharashtra to go elsewhere in the country. Every child with every possible permutations and combinations of congenital heart defect are operated here or intervened here with equally or maybe sometimes superior results because of the infrastructure what we have developed in the last 10 years. And our outcomes match the Western standards. Given the constraint, I should say that we are far better than our Western counterparts, because a same surgery what could be costing 1 crore, here we are trying to deliver it in 2.5 to 3 lakhs. So that's the actual scenario. But in my own setup, I'm privileged and fortunate to have very exquisite and extraordinary infrastructure, including a hybrid operating room also, so that we can operate some of the rarest lesions which are amenable to only hybrid ways rather than the either interventions or otherwise surgery. So these are the great comforts we have, and I have the privilege of operating in the midst of a brilliant team. So that naturally gives rise to improvement in the outcome by maybe another 1 or 2%. So present challenges high in the contemporary times. Prompt and precise diagnosis, as I said, last 12 years we have had number of pediatric cardiologists and number of pediatric cardiac surgeons almost increasing by maybe 500 to 1000% in the state. The issue only which dogs right now is the finance. How to arrange finance for 3 out of 4 children who come to my OPD. I still feel that 3 of them require some sort of a support. And prompt referral. This is the one issue where I continue to see there is a little bit of, often we come across this situation that the children have reached late to us for the treatment. That should not happen, unfortunately. And setting up an ideal ICU was one of the goals 15 years back. Now it's no more. Most of the centers have got a decent ICU, and some of the very good ICUs are set up by good philanthropic organizations or otherwise organizations who are very passionate to deliver some good care to their citizens. So just to put one, the timing of interventions, when to do, ये बहुत इंपॉर्टेंट है. मैं आप सबको ये बोलना चाहता हूँ that it requires a very intimate knowledge of a natural history of a given condition. मतलब what happens to the disease if it is left untreated, and this knowledge it comes only from a cardiologist or otherwise a cardiac surgeon who has got a deep understanding of the immediate and long-term results of an untreated disease or otherwise even the after the surgery. So this is very important. And not only that, in a given center, it's not necessary that some centers might be having very good arterial switch results, some centers might not be doing. So it all depends upon that center's ability. And and interest to do the intervention.
Sorry to interrupt you.
Hello.
Hello, sir. Sorry to interrupt you. Can you share your screen, sir? We are not able to see your slides.
Oh, I'm sharing it. I'm sorry. Can you? We are not. You are seeing now?
No, sir.
No, sir.
I'm sorry. I'm sorry about it. I didn't know that.
Just click on the green button at the bottom of your screen
Yeah, I clicked already.
and confirm it once.
Yeah. Okay.
Yes, it is now visible.
It's not. I'm very sorry, Kiranji. I thought it was there. So, can I continue, or you want me to start from the beginning
Yes,
again?
sir. Yes, sir. Yes, sir.
Okay, so these some of the guidelines are given in the present day standards, and neonatal heart surgeries are a necessity and they're not luxury. I just want to tell you once again that neonatal heart surgery हमको करना चाहिए, because if we don't operate them in the neonatal period, these children are not going to survive beyond 1 month of life, and that's the reason I want to put it up as a separate heading: the transposition of great arteries, obstructed total anomalous pulmonary veins, arch interruptions. Pulmonary atresia means there is no connection between the heart and the lung. Hypoplastic left hearts means the left heart, which is the basic, most important, most critical aspect of the cardiac structure in human being, if that is undergrown or absent. Now, all these things are neonatal emergencies. हम नहीं करेंगे तो these children will not live. And the present day mortality for this, I have written that the operative risk is only 3 to 5%. So against a 100% certainty of dying if you don't operate, it just to highlight that neonatal heart surgeries are not just luxuries or not options. They are mandatory requirements for certain subsets of complex heart defects. And these are the other complete AV canals, truncus arteriosus, AP window, Alkepa, VSD coarctations, and tetralogies. And these children should be operated before they are 1 year of age. And before school going, our aim in my field is to send all children with a normalized heart, or at least with a normalized circuit. And that's the reason atrial septal defects, anomalous pulmonary veins, Fontan operations, and pulmonary atresia where a conduit is required, all these should be done before the children reach the school. And that's the reason I say that there is a huge backlog of children who are waiting to be operated and who have grown into young adults and older patients with the leftover heart diseases, and those things also add up to the burden of the congenital heart defects in India. Again, it went up. I don't know why. I'm sorry. Can you see now?
Yes, sir.
Yes, sir. So this is some of the surgeries what I have put these days, which are sort of necessities in the modern times, where the intervention is like Vijay presented, where they are trying to put the aortic wall in percutaneous fashion and maybe making the surgical field quite absolute. So in these days, surgeons also are coming out with innovations where we are trying to do the keyhole surgeries or small incision surgeries. We do quite a bit of them in quite large numbers, to be honest with you, in our center, and the results are quite amazing in this group of children when they undergo small incision surgeries, because the sternum is not fully open and there is a huge benefit of minimally invasive procedures, in the sense that cosmetically they are superior and the bone also is kept intact, the upper half of it, resulting in the less incidence of mediastinitis, which is a dreaded complication in open heart surgeries. So these are the advantages of these cosmetic surgeries. We do quite a bit of posterior thoracotomy surgeries, where we do from the surgery from the right side back, that is below the scapula. We put a posterior thoracotomy incisions, and we do very large number of septal defects with these approaches. And in a socially and culturally conscious country like India, this has got a great bearing, because the self-esteem is preserved for the child and self-confidence is restored for the child. Because if we operate the children at the age of 2 years and 3 years and 4 years, and we don't mention them 3 months after the surgery, they are likely to forget that they underwent a very major open heart surgery, and nobody is likely to know, because the scar is hidden completely in the back. So the innovations also, India has not lagged behind in the present times. We keep coming out with our own innovations because of the large number of procedures what we do. in this country. So these are some of the innovations where we have come across, where we have created some techniques which simplify the present challenges of operating. This is one such article of biventricular repairs, means we are creating a normal heart for inverted dextrocardia, where the heart is on the right side instead of the left side, and having a complex problem inside it. And we are a very well known center for operating this kind of hearts in the world. And this is a tetralogy of fellow where with the anomalous coronary artery where a conduit was required. We published an article way back 10 years back stating that a conduit is not required, taking out the cost of the conduit and simplifying the surgery, which was a very, very good cost effective solution for India. And these are some of the complex hearts what we operate, what is called as transposition. TGA means transposition of great arteries with intact septum. And this is a intact septum. What is being seen here, as you can see that the heart is black, whereas when a large VST, ventricular septal defect is there, there's a left-right shunt, those hearts usually are pink. But aortic position and the coronary arteries, you can make out that this is not a normal heart. And for a connoisseur or a professional of my field, he usually recognizes them as a transposition of great arteries. And this is a arterial switch in progress, and after the completion of the artery, how those transposition surgeries, the arterial switch operation, they look like. This is a simple picture, I have put it. And this is a additional muscular VST, what we find out sometimes intraoperatively as surprises. I have just put to show that it's very important to recognize them even after such precise diagnosis and great technology in modern times. Very rarely we come across these sort of surprises, but we need to remember that there are some checklists we create intraoperatively, and using those checklists, we usually eliminate these intraoperative surprises and we handle them. So this is one more for multiple VSTs. We have come out with our own techniques wherein we are creating an umbrella device on the table based on the exact shape and size of the defect, and some of the complex defects which are not possible to close it directly. We use these devices and we suture them on both sides of the septum and eliminating the shunt. These are all articles which have appeared in some of the European and American journals. And this is a picture of a complete AV canal wherein instead of two walls, one on this side, one on this side, a complete AV canal results in one large wall for the entire heart, wherein we have to create two walls out of this one and close the hole. This is a large hole, what is there, what is called as a primum ASD. And also underneath that, underneath this suture, there's one more large ventricular septal defect which needs to be closed. This is one of the complex heart surgeries, and we do it quite frequently. We have come out with lots of publications in the contemporary times to highlight that science always evolves. It doesn't stay in a state of flux, and change is always constant in my field. Particularly, it's a hardly 40-year-old specialty. So that's the reason innovations are sort of inevitable in my field. It's a tertiary heart center where I work right now in Western India, and some of you must be knowing, or many of you are aware of our program, doing some of the very impressive work for this country last 6 years. We are a 8-bedded ICU and operating around 250 congenital heart surgeries per year. And number of interventions, we do about 100. We do very large number of neonates in our setup. And these are the features in the contemporary times, because we do quite a bit of hybrid heart surgeries, simply because we have the facility of having a hybrid war, which is not available in most of the centers in the country. And we have operated some of the smallest and youngest also. And our center is a accredited center for percutaneous pulmonary valve replacements. The program is headed by accomplished cardiologist Dr. Bharat Dalvi for the entire South Asia. We are the only accredited center for this procedure. And we have certain procedures which we operate almost, not almost, on par with the Western counterparts. We have got 0% mortality for some of the complex lesions called complete AV canals and TGV and transpositions. And we are noted for our work in double switch operations for corrected TGAs. And we are doing, as I showed you some photographs, very amazing number of cosmetic congenital heart surgeries using push-to-thoracotomy or mini sternotomies. This is the photo I want to put it to you, that, where me or Bharat or whoever the senior faculty are there, we are a small speck in the large canvas of a very, very large team, which is trying to make this child comfortable and relax in our center and go home with a normal, healthy heart. It takes tremendous amount of passion and persistence to deliver these sort of outcomes. So this is Ganesha. I want to put it deliberately to you with a caption that early correction produce useful persons for mankind. Just to, that if Shiva Bhagwan Mahadev did not have the choice and the decision to take the head of the elephant which was lying in the vicinity and put it back and create Ganesha at that stage, we wouldn't have had this great God who has been patronizing all of us, who has been taking care of all of us. We wouldn't have had him at this stage. So that's the reason. It's just to highlight that, early correction is very, very important in my field. The present scenario, I want to tell you that, early elective surgery is more pediatric cardiologists and surgeons, more centers with the requisite ICU infrastructure, well-informed pediatricians. All these are necessary for us to create and give or deliver good outcomes. And that's what I think in the last 15 years has happened, because some of the select centers in the country and in the state, we have delivered good outcomes because of the combination of all these factors coming successfully together. So this is an exceptional infrastructure and support of manpower what I get, and because of that only we have been able to give these sort of outcomes. It's difficult for centers which are there in the little periphery to manage these sort of where a cardiac anesthesiologist round the clock manages the ICU with a two-tier system of ICU surveillance, and there is a operating suite which is completely out of the blue. Maybe like previous speaker Vijay pointed out, that this is something like a special effects of a Hollywood movie. Unless we create this sort of infrastructure, a success rate from 95% to bring it to 98 is extremely challenging for a cardiac surgeon or a cardiologist. So I don't blame any program which, if it has got a result which is little less than the optimum result what the rest of the world is giving, because of the situation in which he is forced to work. And I just want to put up this slide for all the people who are, some of you might be pediatricians, some of you might be seeing children in your OPD. A breathlessness, a precardial activity, abnormal precardium, a blueness in a child, episodes of altered sensorium, anything other than lub-dub, anything other than a ordinary heart sound, regular normal heart sound, a poor or a questionable pedal pulsations, a saturation below 90%, because all of us, we are having now plethysmography in our hand. For 2,000 rupees, we are getting that probe. So all these things are indicative of a possibly a congenital heart defect, and our duty is to see to it that they are get promptly, they are referred to the appropriate pediatrician or a cardiologist, and from there we come as a last point of contact, pediatric cardiac surgeons, if a surgical correction is necessary. So in conclusion, I don't want to make it any complex, don't want to bring any complexity to my lecture. I just want to give a aerial view of my field, and I just want to say that 90% of the structural cardiac defects in the present day times, regardless of the weight and outcomes, they can be addressed. Coordination between a referring pediatrician and us is extremely critical for timely intervention. And cosmetic approaches जो भी हम कर रहे हैं, they are necessity, and they are not a luxury for us in the face of ever expanding and ever competing interventional field. It's a healthy rivalry between these two professions, and I think the child is the one who gets benefited from this. And prematurity, I just want to add this, it's not a contraindication to do surgery. Even if the child is 1,000 gram or 800 grammars, we have been operating with extremely good outcomes, nothing to do with our own ability. It is just that the overall the science has advanced to that extent where the outcomes have become naturally better. And that's due to improved perfusion, improved surgical techniques and anesthesia techniques. And not only that, we have got oxygenators and all, we have become much more better. Earlier, those were the days we were having bubble oxygenators. Now we have got membrane oxygenators, which actually prevent all air embolism complications, what used to happen 20 years back. and some defect, please remember they require immediate intervention or surgery. So do not delay in contacting us. When in doubt, if there is a resource crunch for the family, you are likely to find. If you are seeing 4 children, I am sure 2 children will belong to this category. Please contact us. We shall meet the requirements regardless of their financial status. So ultimately, I want to help and create every child who comes to us in this sort of poses. And thank you for giving me this opportunity to address to you, all of you. And you can contact me anytime, 365 days a year. Thank you very much.
Thank you, sir, for such an excellent and lucid presentation. To deliver the next talk, I invite Dr. Nitin Patankar. He has done his MBBS and MD from University of Mumbai and fellowship in John Hopkins University, Baltimore, and Duke's University, Durham, USA. He is the president of API Thane chapter, also chief coordinator in public education for Maharashtra Association of Physicians. He is director of Wisdom Clinics and consultant at Jupiter Hospital, Thane and Pune. He has conducted almost more than 500 training programs for doctors in areas of nutrition, obesity, and diabetes. He has pioneered reversal of lifestyle disease and programs in India. He is consultant to various pharma companies for innovation in nutraceutical products. And he is also a nutrition and mind training consultant for Olympian and Commonwealth players like Yogeshwar Dutt, Bajrang Punia, and Madhurika Patkar. So he will be delivering a lecture on diabetes reversal controversy. Over to you, sir.
First of all, let me thank you. I think the slides are visible.
No, sir, not yet.
Okay, one moment. Okay, now?
Yes, we can see
Yes,
now.
yes.
Yeah. Okay. So first of all, thank Dr. Prajakta and all your team for giving me this opportunity to share some controversies. It is always we share the controversies on Facebook and WhatsApp, but this is a better platform to get criticized or get feedbacks. So I have kept the topic title. Prajakta was insisting on only controversy, but I'm saying controversy to consensus in regard to reversal of diabetes. So this concept of reversal is not very new. In 1995, Dr. Dean Ornish, which everyone must be knowing, he published a paper on reversing heart disease, and then his book became a bestseller on how to reverse heart disease without medicines and without surgery. So that was the beginning of a thought process that the diseases can be reversed. And then in 2012, this Dr. Roy Taylor from UK, he presented again an ADA, the Banting Memorial Lecture, and he presented again the evidence that even the diabetes reversal is possible, and that is with intensive dietary therapy. The addition to that was the boom of bariatric surgery, and the bariatric surgery reports said that they can, because of the patients who undergo bariatric surgery, they can reverse their diabetes. So this all combined together, and then people started literally thinking about reversing of diabetes. Now this is what we have been taught up till now, that we diagnose diabetes and then we follow the guidelines. Now the diagnosis, at the diagnosis, everyone must be aware about that famous chart that 50% of the beta cells are already dead when the person is diagnosed with diabetes, and then there's a progressive deterioration of beta cells. And so the guidelines say that you start with diet, exercise, which remains only in the guidelines, and people start with metformin, then drug 1, 2, 3, 4, and then at the end we put the patient on insulin. In recent years, we have some other injectables which are like GLP-1 analogs coming. But once the patient attains a perfect lifestyle modification, and his diet, exercise, everything is under well control, stress management is achieved, then the reversal process, first in terms of whether we can stop insulin, whether we can reduce the number of drugs, whether we can even stop metformin, and patient is controlled on diet and exercise alone. So it required a lot of courage from physicians to go in the reverse path, because there are no guidelines how to reverse the medicines. Now, when it comes to reversal, it is still a big problem, because people who have seen that patients who have been maintaining their diabetes only on diet and exercise, they have this question that how come you can say that diabetes is reversed and it is just not controlled by diet and exercise? So how to first diagnose the reversal, whether it has really happened? That is the first controversy. So how to differentiate between that? So, and I am just posting few photographs from Google, but you can find dime a dozen people like this who claim that you can cure diabetes in type 1 or type 2 diabetes in 72 hours, and you can get free from diabetes, you can eat anything, and so many claims are made, and they don't help in any patient or a doctor who wants to really undertake the reversal process. So the controversy, there is a fire and fuel added to already this burning topic. So let us understand that how the reversal was proved by Dr. Roy Taylor. Now what I am showing, this is the red lines which are shown. This is a normal insulin, say, graph. So there is a first phase response which may be lost in diabetes, but then there is a second phase of response, and what the golden standard to find out whether there are insulin producing beta cells have started functioning and their capacity has increased or their number has increased. So what we do is that keep on giving glucose and keep on measuring the insulin response. Now, if you see the red line, there is a plateau which is achieved, and then if you give more glucose and give arginine with that glucose, still if the beta cells are not functioning properly, there is no pickup or there is no, say, additional benefit by giving arginine, and the insulin level keeps on falling down. So this is what happens when the beta cells are really, say, dead, or beta cells number have reduced, beta cell function has gone down. After the process of reversal, and this arginine response in red, which I am showing, happens even with diet and exercise control, when HbA1c is around 5.8 or 6, and the sugars are extremely controlled, patient is having a wonderful lifestyle, still this hyperglycemic arginine response is absent. That means his beta cell function has not improved. But the time when the patients are put on a reversal programs, they have found out, this is what I've shown in the green line, there is a reappearance of the first phase of insulin. And secondly, you will find that after giving arginine, the insulin cells or beta cells respond vigorously. That means their function has improved, or probably their number has also improved. So maximal insulin response to arginine is a, like what we can say, a sign of improvement or a reversal. And in routine practice, we can say that routine glucose tolerance test, which is abnormal, if that reverts back to normal, then patients can be said to be have reversed their diabetes. And this is the, say, pathophysiology. This is again a very famous twin cycle that the Dr. Roy Taylor has mentioned, that initial phases of diabetes or the common diabetes, that is type 2 diabetes, is not pancreatic, say, originated. It is basically liver generated. So if you look at this, pre-existing muscle insulin resistance is there. So you need a lot of exercises, and the typical yoga kind of exercises plus a muscle building exercises to reduce this, because still this is there, you are always a chance to go back into diabetes. Then the major burden is on liver, where there is an increased liver fat, which we are seeing, and this goes into this cycle, and that's why fasting and postprandial insulin levels first go up and then the sugar levels go up. So it is a liver centered treatment for diabetes which can help in reversal. So this is what the study we have presented, that these are the disorders that we have taken into account. We have seen 118 patients, and there were 28 people were on insulin. Hypertension was present, dyslipidemia was present. Patients were taking oral anti-diabetic agents, and out of 118, 65 patients were diabetic. This is for all lifestyle disorders because we think that the root cause may be insulin resistance. Then this is the impact on diabetic related indicators. So parameter studies are basically mean fasting plasma glucose. If you see, there is not much of a drop in mean plasma glucose. Even in a postprandial glucose, there is a substantial drop, but mean HbA1c has dropped down from 7.1 to 6.2, and insulin users have gone down from 28 to 19. Then impact on this is what I was saying, that we can really get a reversal of diabetes. Now, let me address this because this is the most common thing that is discussed about whether to eat twice a day, what is the relation of meal frequency to reversal. So who will reverse with meal frequency? Because you will find people who advocate very small frequent meals every 2 hours, or people who will say intermittent fasting, people who say eat as much as you want in 55 minutes and twice a day. So let us understand what happens exactly and how it is impacting the reversal process. So there are a lot of studies have gone in. This is the most famous study, and recently one Japanese scientist called Hayasaki has also proved or reinforced these findings. And I will go to the next diagram. See, there are two kinds of insulin secretions. Look at this. This is basically the insulin secretion which peaks at 2 hours. And there's another thing which peaks at 60 minutes or even 30 minutes peak. So let us go back to this. So if you look at this graph, there are two variants. They are called a type 4 and type 3, where the peak of insulin secretion occurs at 120 minutes. And it is really much lesser dependent on the initial intake of food, because insulin say sensitivity, the beta cell sensitivity to glucose or food is much lesser. That's why you eat whatever you want. But if you eat too much, then this peak will always go up. Now in this, what happens is there is a hyperglycemia, then there is a hyperinsulinemia, but it is little independent of food. And then you don't eat for a long time, because in these scenarios, the insulin levels come back to say preprandial levels or fasting levels almost at the end of 6 hours. So you don't have to eat anything that period. So eating twice a day is very useful for these people. And again, the caution is that if you eat too much, there is always a glucose variability. This is to prevent diabetes, or what we can say pre-diabetic conditions. This is useful. Then this is a normal pattern. Now, if you look at this, these are the people who have got a very good sensitivity of pancreatic beta cells to glucose. So they start secreting insulin immediately. And there are type 1, type 2A, 2B, and 3 patterns. So if you look at this black line, this is the most common thing, that the peak occurs at around 30 minutes to 60 minutes time. So this is the interval where the peak occurs. And then the insulin comes back in 1.5 hours or to 2 hours, the insulin comes back to normal. This is on this kind of a insulin secretion, we have based our glucose tolerance test. But these are the people who are highly sensitive to the quantity of the food and the quality of the food. So if you eat more, this peak will be raised. And if the peak is raised, then the insulin come back to fasting levels at 3 hours or 4 hours. So these are the people who are like very good candidates for having a small frequent meals, because every time you eat small quantity, these peaks also go down. And that's why the preprandial levels or fasting levels are achieved even in 1.5 hours or even 1 hour. And that's why keeping small frequent meals and keeping a gap where the insulin levels are low, and you can have either the insulin inhibition is gone, so the fat is mobilized, or the anti-insulin hormones that come into picture, and so that you can control your metabolism. So these are the people who are benefited by small frequent meals. And if these people who are having this pattern of insulin secretion, if we give small frequent meals, then and the total calorie content in a day is kept at around 800 calories to 600 calories, the liver fat is lost even in 2 weeks time, and you can get reversal within 1 month to 1.5 months time. And again, coming back to these people, here we cannot give them small frequent meals. Again, here the calorie content has to be kept around 600 to 800 calories for first 4 to 6 weeks, and they should be eating only twice a day or only thrice a day. And if you do that, then again the liver fat goes down. Along with that, if you have a small muscle exercises, then even muscle resistance goes down, and you can reverse the pathophysiology of diabetes. So this is what the basis of reversal. So I will sum up here, and if anybody has questions, because if it's a controversial topic, there should be more questions. So to sum up, what I will say is that reversal is possible. The proof is available. Evidence-based trials are present. Now to have a larger trials and creating and having or refusing the hypothesis, the consensus among physicians to try it out methodically is the need of the hour. So I will rest here, and I would like to answer any questions, because we are working on this field for last 3 to 4 years now. So thank you so much.
Thank you, Patankar sir, for your lucid presentation. Good afternoon. Myself, Dr. Preetham Maharao, consulting physician, Nasik. It's a privilege to be part of this Rhythm 2021 under the guidance of our beloved President, Dr. Samir sir. And we have almost crossed more than 3,000 registration. And moving to a next part of this conference, which will be conducted by a consultant from Mumbai Onco Care Center, and we'll be discussing on cancer care. And moderation will be by Dr. Chandrasekhar Pethe sir, who is our good friend from Nasik. Sir has pursued DM from Gujarat Cancer Research Institute, Ahmedabad. Sir has almost 11 years in this in the Nasik. Sir is also attached at many corporate hospitals from Nashik, and as assistant professor at Medical College, Luni. We have a group of panelists. Dr. Ajay Jadhav sir is also attached at Mumbai Onco Care Center, Nashik. Sir is a consultant surgical oncologist. Sir has completed MS from VM Medical College, Solapur, and MCH from Tata Memorial Hospital. Sir is also attached in many corporate hospitals. Next panelist is Dr. Ashish Joshi sir. Sir is also a senior consultant medical oncologist at Mumbai Onco Care Center, Borivali and Vileparle. Sir is pursued his DM from Gujarat Cancer Institute, Ahmedabad, with gold medal. Sir is attached at Nanavati and SCG Hospital, Mumbai. We have next panelist, Dr. Vashisht Maniyar sir. Sir is also consultant medical oncologist at Mumbai Onco Care Center, Mumbai. Sir is a meritorious candidate from Gujarat Cancer Research Institute, Ahmedabad. Sir has completed DM with gold medal, and Dr. Maniyar has an experience with in this field for almost 10 years. Sir is also attached at Saifi and HN Reliance Hospital, Mumbai. Next panelist is Dr. Kshitij Joshi, Dr. Center, Vileparle. Sir has his roots from Nasik itself and pursued his DM from Gujarat Cancer Research Institute, Ahmedabad. Sir has experience of over 7 years in the clinical practice. Sir has honorary attachment as a consultant oncophysician at Nanavati, Saifi, and HN Reliance Hospital, Mumbai. Next panelist is Dr. Pritam Kalskar. Sir is also consultant medical oncologist at Mumbai Oncocare Center, Thane. Sir has experience of over 7 years into the clinical practice. Sir is honorary attachment as a consultant at Horizon and Jupiter Hospital, Thane. Next panelist is Dr. Sonal Dhande, who is also from Nasik, and Madam has done DNB from Apollo Hospital, Bangalore. Madam has clinical practice of over almost 6 years, and she has a special interest in breast and gynecological cancer. Next panelist is Dr. Divya Udayawar. She is a MSc certified genetic counselor at Mumbai Oncocare Center. She has completed her MSc in genetic counseling from Kasturba Medical College, Manipal. Before MOC, she served at genetics in genetic clinics at Tata Memorial Hospital, Mumbai. Over to you, Dr. Pethe, sir.
Thank you so much, Pritam, for this kind introduction. Pritam, there is a very famous joke that goes around. There was a certain conference like this one happening. The only difference is that this conference was a physical one, and this conference was being attended by, say, cardiologists and oncologists who came together for certain reasons. Now, as we all know, oncocardiology is one of the developing, or rather rapidly developing branches now. What happened in this conference was that during dinner, as happens with all cardiologists, they were having dinner with the plate full of, say, all possible veggies going around, and we oncologists had our plates full with everything that contains butter. And then suddenly, one of my cardiology friends came in and told me, "Yaar, ye kya sale kha raha hai? This will cause trouble." I said, "Yaar, I'm an oncologist, and I realize that there are better ways of dying." So this is the story about where oncology started. We had nothing a few years back. Now we have everything that we want. The field is rapidly developing, and as everyone knows, it's extremely difficult to talk about excellent speakers that we had before I came into picture. We had excellent talks about cardiology, and diabetes. And now this presentation will again be followed by a talk in cardiology. Thanks to you, Nashik IMA, for letting us oncologists be a part of this August audience. We have had huge registrations. Dr. Samir Chandratre sir and his team has taken wonderful effort for this particular conference. Now, without wasting much time, let me start off with my presentation with with permission from Dr. Pridhar. Now, let me run you through a few slides before we go ahead with the panel discussion. Now, we had selected this topic of healthcare delivery in cancer care. Now, this is something that I do not. This is some topic in which we will not be talking in details about cancer medicines. We'll not be talking anything in details about how we manage cancer patients as such, because I know that most of us who are here are not oncologists. Most of us who are here are have had oncology as a say a topic which was for option, wherein you did not study oncology at all during our MS, MD, and MBBS days. So that is where I stand. This session has been kindly supported by our colleagues. Just to introduce this topic before we have our views from our esteemed panelists. Now let me tell you what is needed for optimum cancer care. What we need is a good all-round team. What we need is a good application of our knowledge. This is what we all know. Cancer care. Now, this is one chart that I am very fond of, meaning that comprehensive care, cancer care is something that is always defined as having everything under the blue moon, under a single roof. That is what ensures comprehensive cancer care. I slightly differ in my opinion. What we need is a good mix of what we call as the medicals of cancer care, meaning that we need to be very thorough with our theory. We need to be very thorough about what the standard international guidelines recommend. But then we cannot miss on the practical aspect of it, meaning that if a certain treatment, say, is going to cost, say, one of the surgeries that one of my previous speaker mentioned costs around 1 crore. Now, I know it is the best possible surgery, but then does it mean that it is right for this particular patient? Probably not, if he does not have those kind of money in pockets. That is where it brings us to our second part, is about the practical or economic aspects of it. But then all these things have to be clubbed together with something called as emotions. In cancer medicine, emotion plays a huge role, and that is what we are going to talk about in our entire session. Meaning that for a patient with cancer care, optimum cancer care delivery will be determined by three topics. One is what do the guidelines recommend. Second is, can we afford whatever is mentioned in those guidelines? And third is, we cannot do away with the emotional aspect of cancer medicine. Now, what does every doctor wish? We all doctors, irrespective of whatever field that we practice, we want to offer quality care to all patients. Definitely, yes. I'm very sure that nobody will have any second thoughts on this. But then we all understand that this comes at a cost. Now, whatever is happening is that the free treatment has now started becoming a rule rather than an exception. How does it bear for us private practitioners? How does it bear for others, a doctor fraternity in toto? Now, let me take you down my memory lane. My memory lane starts when I got my dream. I got my DM in medical oncology in Gujarat Cancer Research Institute. It was heaven for me. I got what I wanted. I had struggled a lot for it. I had spent 4 years after passing my MD, and then I got my heaven. But during residency, I got to see a huge number of cancer patients. I used to enjoy academics, had a very easy access to seniors and teachers for all difficult to treat cancer patients. Practice ethics was never an issue. No patient was refused at least basic treatment for want of funds. We had huge amounts of donations popping in. No patient would be refused treatment, irrespective of the cost of treatment, especially in those patients who had a sort of what we triage into curative intent cancer patients. I realized that individual attention in such a huge workload was simply impossible. However, I may wish, it was not possible for me to do it. But then this came at a cost. My stipend was extremely modest. When I passed out my DM, I remember I had only 24,000 rupees in my pockets in my bank account. I had no knowledge of what is mean by economics of cancer care. I had no knowledge of what do we mean by economics of healthcare delivery, meaning that I have learned everything. But then how do I actually get it across to my patients so that my patients get benefited? And as a sub part of it, I did not know how to set up my own practice. So after passing out my DM, the only thing that I had in my mind was I achieved my dreams, पण मी अजूनही अति उच्च शिक्षित बेकार आहे. मला बऱ्याच गोष्टी मला कळत नाहीत, खिशात पैसे नाही आहेत आणि भरपूर काही अडचणी येणार आहेत ज्याला मला प्रॅक्टिस सेटअप करताना. What did I wish for? Continued academics, ensure top class patient care, a good decent income, excellent quality of life. I don't want to practice in night, and increasing income with increasing stomach girth, meaning that वयानुसार पोट वाढणार आहे, वाढत्या पोटानुसार मला थोडासा माझा इन्कम पण वाढणं मला अपेक्षित आहे. But then the realities of private practice suddenly hit me. Hardly anybody knew that there is a certain species called as a medical oncologist. Leave aside, people did not know what is a DM in medical oncology. I needed to compete with lots and lots of heartbreak people. I do not want to say that I needed to pay for my patients, which I desisted. I do not want to do it at all. Meaning that my ethics started getting challenged right on the day one of practice. Most of the discussions with patients used to revolve around economics of cancer treatment. मी कुठल्या पेशंटला किमोथेरपीचा शब्द काढला की माझ्यासाठी चांगलं काय आहे याच्यापेक्षा ना मला किती पैसे लागणार आहेत याच्यावर डिस्कशन जास्त चालायचं, बिकॉज विल कम बॅक टू इट वन्स अगेन लेटर ऑन. Involved in cancer care, 90% of cost is always drug cost, 10% is rest of it, meaning that yes, it definitely has to involve around the economics of cancer treatment. All this I called, this is none of my business. My job is to consult. My job is to recommend what is the best possible treatment. Rest everything is none of my business. It is not my business to arrange money for patients. It is not my business to see that they get the good possible nursing care, because my job as a medical oncologist when I passed out was to consult, to see that I follow the ethics of clinical practice, and to recommend whatever is the best possible treatment to my patient. But then ultimately, because of this all, none of my business, academics started suffering. And that brought me to my next question. How do I start my practice as a medical oncologist? There are many possible answers. Government institutes, I could join one of them. Government funded institutes, corporate hospitals, trust hospitals, nursing homes, small nursing homes, dedicated hematology or oncology cancer hospitals or centers, or maybe I could just start off with my individual OPD, a small OPD, not more than 200 square feet, and then maybe I see my patients and then let the patient roam around to whatever place that he might get, what might want getting admitted to. But then group practice, this is something I had learned in my residency. My teacher has a huge, excellent group practice, which I realize is thought of by everyone, but is adopted by almost none in clinical practice. There are a lot of issues involved in this sort of, say, what we call as group practice. It's difficult for two highly intellectual people to come together, maybe because of their egos, maybe because of their interpersonal issues, maybe because as the Marathi saying goes, ki "Vadaच्या झाडाखाली काहीच उगवत नाही," nothing goes under a banyan tree, meaning that my junior will not flourish under me. I have my own financial security, the insecurity, because as I said, I passed out my DM. I had just had 24,000 rupees in my pocket, which is simply not enough to set up my own practice. So ultimately, it boiled down to a fear of sabotage, fear of getting embezzled in whatever I did not want to do. Uh, but then I had a small thought in my mind: can I become an entrepreneur and start my own practice? I definitely wanted to do that. We'll come back to it once again later on. But then I realized that most of my patients hail from economically modest background with none to highly inadequate insurance cover, which has normally been taken only for say insurance, what we call as a tax saving purpose. Uh, Patients want all facilities under one roof. They want the best possible care at no possible cost, or preferably no cost or free service. Slowly and slowly, as I realized that the ball game doesn't end here. People who when a patient walks into my OPD, he has first seen a family physician and then a specialist, and then has come to me. Each of them have thought about what is the quality of the care that might be afforded to by a person that he is being referred to. What is the cost? Can I have a feedback about all these personal things that are going to happen once I refer the patient to somebody? Is it sustainable going to say chemotherapy for a patient who stays in Jalgaon every week to Mumbai becomes simply impossible? So what most of us land up doing is that we, instead of doing weekly paclitaxel, which is recommended, we'll end up doing 3-weekly paclitaxel, which we know is inferior to weekly paclitaxel. Then नातेवाईक तर सगळ्यांचे असतातच. Many people start getting involved. They're all well-wishers. So instead of caregiver, I would have definitely should have called them as well-wisher 1 and well-wisher 2. We have two different scenarios. Dr. So and so has treated one of my relatives who has done well, so we must consult him. A second well-wisher drops in and he says that we should visit an institute and see a doctor there in order to get optimal result. Now that brings us to my second question: is it necessary for every patient who is supposed to be on chemotherapy to have this particular issue in my mind? We'll come back to it once again later on. And that is when something started. Patient expectations and my expectations started having a fight. We were at loggerheads with each other, and that is where the game starts of actual economics of cancer care and delivery of cancer care. Now, let me, all my panelists have been already introduced to. This was just so that I can get everybody on board. We are running quite late. Let me present to you a case study. As I said, we will not be talking about any drugs. We'll not be talking about any drugs in details, because the first thing that will start is to teach everybody how to pronounce most of those drugs, which I don't want to do. I have a 60-year-old lady who walked into, who had a lump in the left breast since the past few months. A routine case which almost everybody encounters in his or her clinical practice, irrespective of whether you are an oncologist or not. I have with me Dr. Ajay Zadav, who is an oncosurgeon practicing with me in Nashik. Now, Ajay, who in your opinion does the patient usually see first? Hi, Ajay, are you there? Ajay?
Yeah, can you hear me?
Yes, Ajay.
Yeah.
We would like to see you also, if it is possible.
Yeah, I think I'm on.
Yes. Thank you.
Yeah. So, thank you for having me on this panel. But gone through everything now. Pertaining to your question, the patient usually goes to the first person he knows as a doctor. Then it can be a general practitioner, or most probably a surgeon or a gynecologist, especially in a breast case. So that is where the link of medical treatment starts. So I think it's very important that these people guide the patient well into the right person's hand, or do the right thing at their end. Hello?
Yes, Ajay.
Yeah. So that's what. So I feel the patient goes to the general practitioner or a surgeon first, but it's very important that these people who are the primary caregivers guide the patient in the right manner and to the right person and to the right aspect.
Ajay, does it really matter who the patient sees first? And would it have mattered if the patient would have seen you first?
Yeah. Sorry, I couldn't hear you a bit.
Does it really matter who the patient sees first? Would it matter if the patient sees you first rather than moving around? See, what happens is in our clinical practice, nobody thinks that I have cancer. Everybody thinks that I do not have cancer. That is the last diagnosis that is normally suspected. So, would it matter if the patient sees you first?
Yes, of course it matters a lot, because see the just I think there is a communication. Hello.
I think Ajay, you have a slightly weak network. You might prefer to shut down your video. Yes, thank you. I cannot hear Ajay. Can anybody else hear? Okay, let me get down to my second panelist here. Yes, Ajay, you're back.
Yeah. Can you? Hello.
Yes, Ajay. Yes,
Am I
Ajay, we
audible?
can hear you. Yes,
Yeah.
yes.
So as you said, it's extremely important that the patient sees a proper person, and if he's seen by a surgeon, then the patient can be managed very well, because malignancy, as you know, is very tricky in a way that we deal with it. So if you don't do the right things in the right sequence, it has a direct bearing on the prognosis of the patient and the way the patient is treated. Just to give an example, if the patient has done a biopsy directly, uh, and a mammography is not done, then we have lost the golden chance of having a mammography which has got important findings. Same way in if you consider bone tumors or say sarcomas, if the biopsy is not done the right way, and if the biopsy scar is not placed rightly, then the patient might actually lose the limb. I have seen patients having sarcomas having a wide transverse scar, and you end up excising the scar during your final surgeries, and the cosmetic outcomes or the plan of treatment has to be drastically changed. So it's extremely important that the patient is seen by the right person and guided well, right from the initial stages.
Right from the word go. Thank you so much, Ajay. Now, these were your views as a surgical oncologist. Now, let me get down to Dr. Kshitij Joshi. He is a medical oncologist who basically is from Nasik, and he loves to practice in Mumbai. As of now, he is based in our Mumbai Oncocare Center in Vile Parle. Kshitij, same question to you. Who, in your opinion, does the patient usually see first? Does it matter? Would it matter? Would it have mattered if the patient would have seen you first? Hello, Kshitij, are you there?
I can't see Dr. Kshitij in the panelists.
Okay, Vashisht, can you please take this question?
Yeah, sure. So I believe it would really not make a difference if an able oncosurgeon or an able oncophysician sees the patient. Just if I can also answer the question that you asked, that who does the patient see first? I believe it largely depends upon the graph of their practice. If you have a young oncosurgeon pitted against a very senior medical oncologist, then probably the patient would go to the senior medical oncologist first, simply because they've created a loco-regional repute in terms of being the person of first contact for any malignant purposes. So I believe it does not make a difference if the patient is seen by either a medical oncologist or a surgical oncologist. Very honestly, when we talk about a breast lump, we are assuming that both of them have the patient's interest at heart only, and it would not make a difference. I, however, still strongly believe that all breast cancer patients should be seen by a multidisciplinary team before any definitive treatment is planned.
Fantastic. Now this all happens because we have newer and newer data coming into picture, which needs to be implemented in clinical practice. Say there are few proponents who say that all patients who have got HER2 positive disease should first receive neoadjuvant chemotherapy. All patients who have got triple negative disease should first receive chemotherapy. But then ultimately it boils down to how well are we able to actually use those guidelines into clinical practice. I think we'll come back to it once again later on. So wonderful. Uh, we have our next panelist, Dr. Sonal Dande is a medical oncologist practicing in Nasik in Mumbai Onco Care Center. She practices with me. Sonal, what do you think are the steps in cancer management? You have a patient who is suspected, who has a breast lump and is suspected to have CA breast.
Uh, a very good afternoon to everyone, and I'm very happy to be a part of the Refreshercon now. And as Pete sir rightly said, ki after the cardiology lectures and even Dr. Patankar sir's wonderful lecture about diabetes mellitus, I want to make one statement first, and they'll answer your question, sir. Ki, even the cancer being the advanced development happening in our sector, I think the cancer should be treated as one of the chronic disease only, and not like a very dreaded disease, though the mortality is higher, still higher in our cancer setups. And still we are working towards that. The precision oncology also is in the coming field. Plus, we have lots of developments happening, as Dr. Shivprakash sir said, about pediatric and neonatal. So even medical oncology, we are having lots of developments happening in the pediatric oncology to have a better and better outcomes and better quality of life for these patients. So pertaining to my per se question regarding the cancer management, as in any cancer, as we diagnose first, there are the four pillars of like cancer care in the oncology. So the foremost pillar will be a surgical oncology, medical oncology, radiation oncology, and interventional oncology. So even in the breast cancer, as we encountered that the patient has came with a breast lump, so our the diagnosis will hinder with the three pioneer steps, that it will be definitely assisted clinically first, whether it was a surgical oncologist or the radiation or the medical oncologist per se, pertinent to, because not only the lump, we have to assess about the patient's axilla as well to look for any clinical nodes palpable over there. Besides that, even the radiation or the diagnostics comes in the picture. Before diagnosing, we require a good radiation modality, so that we should have a good mammograph for this patient. So clinical plus mammography plus the histopathological diagnosis. So that's how we come to the diagnosis of the breast cancer patients. So definitely first come to the suspicion. After that, the confirmation of the diagnosis with the triple modality, because it gives about the 99% of the correct diagnosis of the breast cancers. And definitely the next step coming to the staging of the any cancer, because before planning our any line of management, as I said, triple modality, like three things, like the surgery, whether we have to, this patient should go to the undergo surgery first. So staging is foremost important, whether our breast lump is lying into a early breast cancer, whether it is a locally advanced with a bulky nodes available with sitting in the axillas or supraclavicular regions, or it is already spread, because in oncology, the size doesn't matter as such, even we are diagnosing. Not always, because we can see many variations in breast lumps also. Very small lump, it can be spread all over. So there are some subtle other pointers which I'm not going to detail, because it. So these are the four most important pointers. That then next comes to the staging. So after staging, then as rightly been said, as we go through the case, we'll come to know what is the importance of the multidisciplinary action. Because if the very small lump is there, definitely if the no axillary nodes, possibly this patient will undergo the surgery. And as Pete sir rightly said, depending upon the ERPR HER2 status, then if there are 2-3 lumps in the breast, or according to the situation of the patient, or if patient is already having any other associated comorbidities, if the patient is young, then according to that multidisciplinary like interaction that we call as a multidisciplinary tumor board, and followed by a accurate planning for this patient. Because besides surgery, if we plan for the chemotherapy for this patient, we have a different types of it. We can, if the tumor is on a larger in size, we plan as a neoadjuvant chemotherapy to shrink the tumor in size, and then it can undergo a perfect surgery. So that, because surgery also matters in cancer treatment, especially in the breast, because we want or R0 resection. That means there should not be any disease. Not only matters why we are talking about it, the breast lump should be seen by a surgeon as well when planning for the surgery, because as all of us we can agree, sometimes patient get operated and comes to us like an excision biopsy, And we are, as Ajay sir rightly said, then we don't know about what was the prior dimension, because it has sometimes the tumor has been removed with bits and bits, so exact size can be missed. Sometimes it is very microscopic disease which can really change our further plan. The margins can be missed, so according to that, henceforth, like that way.
As rightly said by Sonal, Sonal, I'll just summarize whatever you said. Uh, First is we need to have a very high degree of suspicion. We cannot do without suspicion, and we have to have a very high degree of suspicion because in my experience of last 15, say 15 years, most of the patients are diagnosed late because the degree of suspicion or the index of suspicion was very low. People did not think it could be malignancy, and that is the main reason why the diagnosis was missed, especially in the early stages. After we suspect, we confirm it by sitting with the oncosurgeon whether he wants to do an FNAC or a biopsy. Let us not go into details of that because our talk go into intricacies of cancer care. We stage it after we suspect and confirm. We stage it, and then we discuss with our team members, with the surgical oncologist, medical oncologist, radiation oncologist, and many other people involved in our team to finally plan the actual cancer care. Now, this is one particular patient which Ajay had seen. He thought it is malignant. To him, it seemed to be operable. Orders an FNAC, not excision of lump, because it's an operable breast cancer. There is no role of biopsy. We went ahead. He went ahead with an FNAC, confirmed the diagnosis, and the final histopath turned out to be a T2N1 disease. Now, what next, Sonal? The Ajay now refers the patient to you for opinion. Do you need anything more to plan treatment? We have the final histopath in our hands. And as used to happen in my initial days, a few surgeons used to refer the patients to me, यार की chemotherapy चालू करून दे. आणि मी म्हणायचो की नाही मला मला अजून काहीतरी टेस्ट पाहिजे. पेशंट अफोर्डिंग नाही असं मला नेहमी उत्तर दिलं जायचं. And then, yes, Ajay, you wanted to say something.
I just want to make up a point, especially in this case, that I would always prefer a core biopsy over a FNAC, unless that I'm nearly sure that it is malignant. So wherever possible, it would be a core biopsy, not an open biopsy, but a core biopsy at least. Yeah.
Fair enough. Yes, Sonal, how would you go about planning the patient's treatment? Do you need any more tests to plan treatment to prevent a relapse?
Sir, definitely. After like getting a operated patient, we like to see a detailed histopathology report. So the exact size of the tumor, followed by the amount of lymph nodes negative, because N1 suggestive of there will be only 3 nodes will be positive. So that also matters while planning the treatment. Then, not only that, there'll be any other adverse features like the IDC grade, then the lymphovascular margins, basically the detailed histopathology report. And top of that, till our treatment, definitely we require the IHC for this patient, which comprises HER2 and as well as Ki67 for this patient. Sir.
So, as pointed out by Sonal, she would order an ER, PR, and HER2 reports. I think we have Kshitish back on panel. Hi, Kshitish. I'll come back to you once again later on. Pritam, are you there?
Yes, sir.
Yes. Pritam, now we have got a T2N1 disease, and Sonal ordered an ER-PR status, and I have the report in my hand as ER-PR is negative. HER2 is positive. Ki67 was not ordered because she was already node positive. So, what is the recommended therapy?
So, hi, good morning all.
Good morning, Pritam.
So this is a T2 lesion with node positive clinically, and patient is HER2 positive, right?
Right.
So as per the literature, anything more than 2 centimeters, which is HER2 positive, one should offer them chemotherapy first, and then I would later on see how is the response after the 6 cycles of therapy, and accordingly then I'll like to offer a surgery to see the path.
Fair enough. But Pritam, the patient has come to you post-op, and now we have got a T2N1 disease, ER-PR negative, HER2 positive in our hands. So how would you go about it?
Surgery has already been done. Okay.
Yes.
So yeah, definitely then the patient deserves with HER2 positive both anthracycline and taxane based regime. But there is strong data here. What is the age of? Hi sir, what is the age of the patient?
She's 60-year-old.
60-year-old. So at 60, I would prefer avoiding anthracycline and I would give her 6 cycles of PCH, followed by trastuzumab maintenance and also radiation opinion after 6 cycles of chemotherapy.
Okay. Now, just to summarize, Preetham, what you said for the purpose of all non-oncologists who are there with us, is that she requires chemotherapy of your choice. Somebody else might have a different opinion, that is acceptable. But then, what is the bottom line is that she has to receive anti-HER2 therapy. Am I right?
Yes, yes, definitely. Yes.
Okay, okay, fantastic. Kshitij, hi Kshitij. Kshitij
Hello,
is
sir.
our uh, now. How do you talk to patient about expenses? Uh, I think these are the three heads that we normally talk to patients about. One is drug expenses, hospital expenses, professional fees, and something more. I would suggest that you comment on this, please.
Yeah. So sorry, I was not there initially when the question was asked, and after this accident, but I was there as a part, so I have listened to everybody's talk. So the question here is, how you will explain the expenses? So when this is a HER2 positive disease, so for that, because of that, the involvement of trastuzumab, which is anti-HER2 drug, is very, very, very essential when you address a cure. So in that case, we have to explain that patient in that sense that entire cost of 1 year of treatment should be covered upfront. Because many times what we observe that in a part and parcel, if you explain them, then there is a possibility that the person will discontinue treatment in between and will not get the advantage of the entire therapy. So if this patient comes to me with T2N1 ERPR negative HER2 positive, suppose as per Dr. Preetham, I have planned TCH. The regime is 6 cycle. Even there is a 6 cycle of chemotherapy. The 1 year of maintenance total trastuzumab uh, has to be given. So as per the current evidence, so I have to explain that the total cost of the therapy for entire year, which includes drug expenses, which is a normal chemo drug expense for 6 cycle, then the drug expense for trastuzumab, which is expensive therapy for this 6 cycle, plus rest of the maintenance, plus hospital expenses, plus doctor's expense. So I will divide it into two part. First, I will give the option. So whenever there is a resource restricted patient is in front of me, I will give him that patient the three options. First is what is standard ideal, which includes 6 cycle of therapy with trastuzumab with 1 year of maintenance will cost almost this may be a 6 to 8 lakh as per our current even. Second
Kshitij,
option is that
yes.
suppose it is a very restricted setting and there is a new data which suggests that almost the 6 months of therapy is a little less effective than 1 year, then if you go ahead with chemotherapy with 6 months of therapy trastuzumab, then this will be the cost. And the third option, even if you don't have any other resources and if you just go ahead with the therapy, this is the third option. The cost of these three, like suppose first option is 6 to 8, second is around 4 to 5, and third option is just 2 to 3 lakhs, and the effectiveness that what they will get out of it. And then we will give that option to patient to decide. And usually, what is my observation? Patient come up with as per their financial this thing, and as per the whatever the response rate we have shared with them, they come up with the answer, and they usually our experience is that they take a treatment, and whatever treatment they start, they will complete. So that is.
Well said, Kshitij. But my own experience tells me that once you talk about expenses in multiple terms, initially I started my presentation with a thought that, boss, this is none of my business. My business is not to discuss expenses in detail. My business is to explain the patient that 1, 2, 3 things are required. Please do it. So that is where then the discussion goes on to cancer economics. Vashisht, can you shed more light on this?
Sure. So I agree that cancer economics unfortunately forms a big part of the discussion. In fact, in the previous talks, we have never discussed what is the cost of these interventional procedures when it comes to the cardiac embolization or TAVI or transarterial cutaneous pulmonary valvular procedures. But unfortunately, we're discussing the cost of chemotherapy, because unlike any surgical procedure, chemotherapy is not a one-time cost; it's often a recurring cost. However, I differ technically, in terms of that. Cancer economics nowadays plays a huge role, at least in metro cities like Bombay, in deciding and defining therapy. And I believe it's very essential to be very transparent in defining the entire course of treatment. The problem with HER2 positive breast cancer, has been reiterated by colleagues, is the fact that the treatment goes on for 1 year. It's very essential to be very transparent, define the cost. Now, these costs about a decade back were prohibitively expensive because we had only patented drugs available for these targeted therapies. Now, with the advent of generic drugs, the costs have come down to a third of them. And I believe nowadays it should not be the defining, the problem of defining the therapy should not be based on the economics, because majority of the standard treatment is now within the purview of the average Indian patient.
Rightly said, Vashish. But then what I found is that now I started my talk with different types of practices that we have. Suppose you're sitting in your Ghatko ProPD, and a patient comes to you with a HER2 positive disease report in hands. And then apart from this, you'll have to discuss something more. So do you think that the economics of cancer care changes in different setups, say multidisciplinary hospitals, corporate or dedicated under all one roof cancer hospitals, pure daycare centers, etc.?
So I believe all therapies across the board, not only cancer, changes in various different setups. When you go for a particular treatment in a small nursing home versus a large corporate hospital, the treatment in the large corporate hospital, we assume, is always going to be more expensive, and justifiably because of the overheads that come with the hospital. When we're talking specifically about cancer chemotherapy, similarly, if you're taking cancer chemotherapy in a corporate hospital, we expect the therapy to be more expensive simply because the overheads are more. Across the world, Dr. Pethe, chemotherapy is not standard of care in hospitals. Let us understand the fact that these patients are not sick people. These are the people whom you would probably walking in to a clinic who are physically as healthy as the doctor themselves. They are currently taking treatment to prevent the cancer from coming back. And hence, these should not, I believe, be treated along with sick patients in a tertiary care setup. There are certain treatments which need a tertiary care setup, long-term infusional therapies, but majority of the cancer care worldwide is provided on a day care basis, and it can be done in an outpatient setting without prolonged hospitalization or a multi-institutional setup. The economics obviously make a big difference, because if the same treatment is being offered in a bespoke oncology setup, the overheads are going to be significantly low without compromising on the quality of care.
Fantastic. Vashish, you very aptly and very rightly said that the patients that we treat, especially in the adjuvant setting, are not sick patients. They are just here to see that the disease does not relapse. Now, but then what happens is that over generations, Dr. Ashish, it has been touted that all under one roof cancer centers are needed in every patient. Many a times I get referrals की तुमच्याकडे सगळं असेल तरच आम्ही पेशंट तुमच्याकडे पाठवतो. How true is this, Ashish?
So I think I always like the word plural when we talk about anything in India, and when it specifically comes to cancer care, it is even more pertinent. We are a plural population, and our patient subset are also very plural. So there would be demands at every patient which needs to be met. But if you specifically look at the oncology and specifically look at the medical oncology, and if you actually start pointing down the percentage of patients who actually requires a domiciliary care vis-a-vis inpatient care, then the proportion is sky high in terms of the domiciliary care requirement rather than the admission requirement. So I believe multidisciplinary care is very, very important. But with the help of technology coming up, I think it need not necessarily be. It has to be in the big ivory tower. The same could be conceptualized and delivered in a small microeconomic sort of micro center concepts, wherein you get more flexibility, better coordination, better management techniques, and more effective cancer delivery. And that's what I believe it would be one of the ways of treating cancer care here.
Ashish, if I wanted to put say numbers to whatever you said, how much if you treat a patient, if you say plan a certain treatment to a certain patient, as a gross, I do not want to go into basics of every drug that we use, But then what is the rough percentage of patients which can easily be treated on a daycare basis? You suppose say prescribe chemotherapy to say 100 patients. Among these, what is the rough percentage of patients who can be easily treated on daycare basis?
So that's exactly what I mentioned before. I reiterate here, I think that number is quite conspicuous, and probably you could look at, if you want to put it in pure numbers, could be close to 60 to 70% at least.
Fantastic. So for rest 30 to 40% patients, we are probably just adding to their expenses by admitting a patient in a so-called all under one roof center, which Vashish pointed out have got huge overheads.
Absolutely, completely understand, completely agree.
Right. So will this actually interfere with your decision of administering cancer care?
Oh yeah, so I think that's what initially we had thought, that a daycare would be, sort of, you would compromise a care, or that is often been talked about. But that in fact is not the case, because you have such a big control and over the processes of drug delivery, that the dose reductions, the precision of giving the adequate chemo dosing, the drug mixing, and all that is actually far more optimal than what it actually happens in a big corporate hospitals. So hence the adequacy of the drug delivery is far better. Secondly, now we obviously have IV access devices in terms of either indwelling catheters, which is PICC line, which could be very easily put, and most of the infusions, especially the long chemos, which used to happen on an inpatient basis, is absolutely a bygone era. I would say that we have pumps now available with which a chemotherapy which is supposed to have been delivered for 3 days could happen in a day with a pump being delivered. So the cost of the treatment comes down, the patient convenience is huge, and that's where I think we've been able to deliver most of the chemo services in a daycare setup. And that's been the changing paradigm over last decade or so, and that has actually helped the patient with a better compliance, lesser cost, and more effective drug delivery.
Fantastic, Ashish. If I just put one more number to it, say you do a certain chemotherapy, say like Folfox, which ideally would have required admission for 3 days. You put in a port, you put in a pump. The same treatment of 3 days can be done on 4 hours on a daycare basis. The patient goes home, goes to work with a pump in his pocket. The cost of hospitalization goes down by 1/3. Am I right?
Absolutely, absolutely. Cost of hospitalization, the convenience, and even you also need to involve the cost of the caregivers, because once the patient is hospitalized, somebody has to be there with the patient. So that also adds to huge man hours being lost. So I think that also needs to be added up in terms of economics.
Absolutely. Now, this is something that which we probably in our residency would never be able to understand. How does it actually work? Vashish, we are coming to the opposite end of it. You practice in so-called super upper class Mumbai. Patients can easily fly to USA for an opinion of, say, which costs upwards of, say, $3,000. How do you manage this phenomenon? Patient walks into your OPD, can afford anything under the blue moon, and would you still recommend chemotherapy on daycare basis, or you would admit the patient in super deluxe rooms and then treat? How do you manage patients who would insist on, say, I will go to US and come back with an opinion, and then would prefer to get the treatment under you? How do you manage this phenomenon?
So I let them go to US if they want to go and take an opinion, because most likely there they are going to be given chemotherapy on daycare basis and not in the hospital to begin with. So I do cater to a lot of patients who strongly believe that because they have the resources, they should fly down, and we encourage them to do that occasionally. Nowadays, post COVID, what has happened is at MOC we have tie-ups with a large number of international group of oncophysicians, oncosurgeons, and experts in the field, wherein we create a Zoom platform for them and provide these opinions in-house. So if we have patients who is very keen at having an opinion for a specific type of a subset of cancer, say a recurrent ovarian cancer, we try and rope in the best experts in the business and provide them the same opinion. Yes, they can still fly to that country for a holiday, but nowadays we don't see many people flying for opinions because of the COVID era. As I mentioned previously when I said that chemotherapy worldwide is given on a daycare basis. By daycare, you do not mean having an OPD setup. By daycare, you mean that you have an ICU-like setup, but just do not need an overnight hospitalization. The concept is, as I mentioned, at the expense of reiterating myself, not to make a patient who is otherwise physically very fit and healthy feel that he is sick, And these are bespoke suits and not really OPD wherein you are lying in a chair and just taking chemotherapy and going home. So across the world, chemotherapy is given in daycare infusion centers, as we mentioned, with all the precautions, with all the bells and whistles. And in fact, just to very honestly answer your question, these super rich patients rather prefer taking chemotherapy in daycare centers rather than going to multi-speciality corporate hospitals because it gives them anonymity. They don't want to be seen walking into these large, multi-centric institutions. They rather prefer that privacy, that comfort, which comes with an infusional daycare center.
Fantastic. Now, how do you take care of the safety aspect when once you talk of something being done on a daycare basis? Because that is something that is always a big issue.
Can I take that?
Yes, Ashish.
Yes. So just to give you a parallel, so the people who do not know, these daycare centers, as I mentioned, are not small OPD clinics. They are bespoke 3,000, 4,000 square feet centers, which have every bed which looks or feels like an intensive care unit. At least for MOC, I can say that all of the MOC centers are manned by intensivists. All of them have a central oxygen supply. All of them have a central, patient monitoring system and a crash cart for any unforeseen eventuality. So these are actually walking, talking intensive care units. It's just that the patients are not admitted overnight, so as to not hamper their experience. And the patient in the next room is not a patient who's come with fever, diarrhea, suspected COVID, or a stroke or a cardiac event. They are all oncology specific centers. So just to clear the concept, these daycares are not outpatient clinics. They are bespoke walking, talking ICUs.
Fantastic. I believe that like happens in an ICU, most of MOC centers have an in-house team of intensivists who looks after the daycare also. Fantastic.
Absolutely. So every center is manned by an intensivist.
So I would say that this is probably what I could venture to call as a high dependency unit in terms of corporate hospitals, or a semi ICU, what the word that we very commonly use. Now, as happened, this lady had a daughter who is 40 years old and with 2 children. She feels that my mother was diagnosed in a slightly advanced stage, and now she feels the pinch of diagnosis for node-positive disease, and then would like to know her own risk of developing breast cancer and its prevention. So what normally happens is that we as medical oncos do talk about genetics, but then there are better people available. I have got an excellent geneticist on panel with me. Divya, what would you suggest? How do you deal with such issues and questions and matters?
Firstly, a very good afternoon to everybody. Coming back to your question, sir. As we know, our patient here
Divya,
is a 60-year-old. Hello, am I audible now?
Yes, yes.
Okay. So, firstly, a very good afternoon to everybody. Coming to your question, as we know, the patient here we have is a 60-year-old female. So considering the personal history, she is 60 years old, and in terms of her ER/PR and HER2 status, she is HER2 positive. So neither is she an early onset of a breast cancer case, nor is she a triple negative breast cancer case. Specifically, why I'm speaking about these two things here is because early onset breast cancers and triple negative breast cancers what are generally known to be hereditary in nature. Since the daughter's concern here was if it is hereditary and if she could be one of the probable carriers of a gene mutation which could put her into a high risk category for any of the cancers in the future. So since our patient's personal history is clear and she does not fall into a criteria wherein she requires any kind of genetic testing, it is important here to consider her family history firstly. So we'll be looking into 3-generation history of any kind of cancers in the family on both the maternal and paternal side. Since hereditary cancers, just giving you a bit of statistics here in comparison to the world, we as a country stand thrice at a higher risk of hereditary cancers than the world population. And that's typically because we are more of a close community marriage system wherein there is a lot of inbreeding, there's a lot of people getting married to people from the same geographical geoethnicities. So because of the same reason, there are a lot of hereditary cancers which run in are specific communities. So here again, another aspect could be taking her community into consideration, because there is data which says in certain communities there are certain mutations which are known to prevail. Taking both these things into consideration, if that seems clear, again, she's not an indication for any kind of genetic testing. But in case there is any indication on these two, on the family history or on the community specific side, then we might go ahead with, a panel, most probably, because again, we know BRCA1 and BRCA2 are two genes which we know are very popularly known to cause any kind of breast cancers. But then there are many other genes which there is data which gives us evidence about many other low penetrance genes also, which are not very popular because the management for them is a little complex. Here is where a genetic counselor comes into play, because it becomes very important to understand what these genes can do, what the risk could be in the future, and how exactly is this supposed to be managed. Again, another aspect to be addressed here is, of course, as you said, just since the daughter is concerned about herself, so she sure is going through some kind of, psychosocial issues. There might be anxiety. There's already this whole thing that she's dealing with the treatment of her mother. That itself is not easy. Plus, again, considering her risk for the future, and she has daughters, so she has to consider that for the future again. So again, here it becomes very important to counsel her right, even if the genetic testing is not indicated. That in itself becomes a very big assurance for the patient. They get very relieved by that specific kind of counseling being given, that there is no particular inherited cancer risk that you have. Again, just one last thing, it becomes very important to tell the patient specifically that herein we are talking only about hereditary and inherited cancers. So it's important for her to know that she is not free of the risk of population specific or age specific cancers. So it's important for us to give her maybe a general surveillance plan, which according to her age and according to the population risk could be the best suited plan for her.
Fantastic. Now, we as medical oncos do get questions on and off, because most of our work ultimately runs into palliative care. So people usually tend to ask questions to us, which we may not be the best people to talk about. But then, since we have you on our panel, we will always love to have the opinion of a geneticist once we go ahead and plan treatment of such patients. So I'll just try to summarize. We have got 10 more minutes to go. What we require for delivering optimum cancer care is strictly follow international standard guidelines, and wherever available national guidelines. We need a good team for medical oncology. Medical oncology is not only about chemotherapy. We need good medical oncologists. We need good oncosurgeons. We need good onconutritionists and a geneticist. Sometimes we need access to cancer caregivers in, say, USA, as Vashish rightly mentioned. At the same time, we have to do this at the best possible cost. I would say not at zero cost, but I would say we need to do it at optimum cost. Now, I've got one last question for Ashish and Vashish, if you both are here with us. You're pioneers and a source of inspiration for many of us medical oncologists in Maharashtra. I've got 3 questions for you. Ashish, I think you go first. Vashish, you help me later on. Can doctors become entrepreneurs? How does it actually help patients when doctors themselves become entrepreneurs? And how does it help the doctors themselves?
So it's a very important question which you answered, Dr. Pete, and it's been a wonderful moderation up until now. See, doctors is one service sector where you can be self-employed, and that's typically what actually happens. But what has changed over the past few decades or so is that there has been sudden inflow of non-medical practitioners entering into healthcare field purely because it's a lucrative field and a field which is not being damaged or changed by the noise around in terms of inflation, in terms of COVID, and so on and so forth. But I think what has happened is that there has been people are sort of holding a long end of the stick, or a wrong end of the stick, one would call that, and because of that, the inflow of the corporate hospitals and their model being only purely running on a business plan or a MIS, where the numbers actually run the roost. is what is actually damaging the healthcare services. So I think the time has changed. We are coming full circle. Initially, it was a very, very paternalistic doctor, a
I think
good
I'm
doctor
not.
being advising, but I think we need to come back to that. Can you hear me? Hello.
Yes, Ashish. Yes, Ashish.
Hello.
Yes,
So
Ashish,
I
we
think
can
it's a
hear you.
time that we need to come back. Yeah, I think it's a time that we need to come back, take the management of any medical delivery under the ambit of our own self, because as a doctors, we probably are the best managers in terms of any care delivery. Let it be cancer, let it be oncology, let it be cardiology, because we understand the patient cares need more than anybody else out into the practice. So yes, doctors have to be entrepreneurs. It's the time that we take the ambit and we take the responsibility of managing the healthcare services on our own. It will come with a lot of headaches. It will come with lot of issues which are probably not typically into the ambit of our services, but that's the way it goes. And that's where, if you see, typically all the businesses are flared. So we need to do that. It's a time that doctors become entrepreneur. Yes.
Vashish, your views, please.
Yes, I completely agree. I believe that's the need of the hour, as I think Dr. Joshi has very beautifully put it. I think being entrepreneurs is something that now is no more a choice, but a necessity to be relevant, at the same time ensure that you deliver quality care. When you're into private practice, you have certain aspiration of creating certain standards of care, the same standards which you would want to give to a patient which is in a corporate hospital. But when you're working as a pawn in a corporate hospital, what occasionally happens is that you lose control in terms of the patient finances, in terms of the quality that you would want to afford. There are multiple levels where you need permissions. So eventually, an ideal situation for a doctor would be where he wishes and is able to provide the quality of care that he has always dreamt of, at the same time at the economics that a patient can afford. Would be possible only if you are an entrepreneur, where you can control your costs, you can control your top line, you can control your overall quality of processes on SOPs. Yes, Dr. Peter. Shekhar bhai, we seem to have lost him. Am I audible?
Yes, Vashish, you're audible.
Okay. Yeah. Dr. Pete, any other questions that you would want us to answer on the same?
I think Shekhar had lost his audio, is it?
Yeah. Shekhar bhai? We seem to have lost him.
Shekhar?
Sir. Dr. Pritam here. Pritam Ahirrao here.
Yeah.
Hi, me.
Okay. So please continue.
Looks like his internet went down. He cannot hear us.
Yes,
Yeah,
sorry, I'm back. Sorry, I lost my audio connection.
Yeah.
Yes.
Thank you so much,
Thank you.
all my panelists here. We are a team of 9 medical oncologists practicing together as a group practice, not only in Nashik but spread across Mumbai. We, as a team, are really thankful to Nashik IMA for giving us the platform to express our views on the healthcare delivery in cancer care. Dr. Samir Chandratre has had a very, I would say, a very robust year managing COVID. He has done a fantastic job. Now he has moved on to the state management. Thank you so much, Samir sir, and the rest of the Nashik IMA team for letting us be a part of this August audience. Thank you so much. Pritam, I hand over the proceedings to you.
Yes. Thank you, sir, and congratulate all the consultants from Mumbai Onco Care Center. You have done a wonderful job, and you have guided us on cancer care. And as a physician, we face two basic problems. First is early diagnosis of the malignancy. And when the patient come with this complaint of persistent abdominal pain, and in spite of persistent abdominal pain, UHG abdomen is normal, UHG upper gyroscopy, colonoscopy is normal, and then patient lost to us and comes back again after 2 months with the report of some CA pancreas. And second problem is that when we try to biopsy a patient considering some malignancy, like say some lymphoma in the neck, and we doesn't get a good support from the histopathological person, and again we miss the person, and the same patient again come with the report of lymphoma and asking us on the ethical background that doctor, why you have missed our this main diagnosis, and we are losing a patient only because of late diagnosis and wrong histopathological diagnosis. And here a great guidance from medical legal person or a person like Dr. Utture sir, this guidance of Utture sir will be very important in such a scenario. And next discussion will be on ethical hearing and procedures and provisions under the MMC Act. And Dr. Shivkumar Utture sir doesn't need any introduction. Sir is eminent and a boss of our Maharashtra Medical Council. Sir is the president of Maharashtra Medical Council since 2017. Sir is also a member of National Medical Council. Sir is an honorary surgeon at St. George Hospital, Fortis Hospital. Sir is a professor of surgery at Grand Medical College, Mumbai. Sir is also boss in the telemedicine, and sir is being a forefront in fighting for modern medicine when government gives some order against modern medicines like mixopathy. Over to you, Utture sir.
Yeah, thank you, Dr. Pleasure to be there in any program of Nasik IMA. Can you see my slides, please?
Yes, sir. Yes, sir.
Yeah. So at the onset, I think I must thank Dr. Samir, my close friend and younger brother, and of course Dr. Raja and Satish Patil, and Madam Prajakta Lele for having invited me to talk on this important subject. What I feel is we have a lot of conferences on clinical subjects almost we are having about one a week nowadays on Zoom, and we learn a lot of our clinical medicine which we use in our day-to-day practice. But down the line, sometime or the other, as I tell all my younger generation colleagues, that tomorrow a case being filed against you is going to become a norm, not an exception. So we have to learn to live with our patients who are going to file cases against you. And that is why when Samir gave me a call and asked me to talk about something to do with medical legal, I thought the best way would be for everybody to know exactly how these proceedings are held in the Maharashtra Medical Council, and what you are supposed to do and what you are not supposed to do as far as these proceedings are concerned. So let me directly come to the topic. Basically, what we hear in the Maharashtra Medical Council is unethical acts and misconducts which are done or allegedly done by registered medical practitioners, and for which the patients or the relatives of the patients make an official complaint with the Maharashtra Medical Council. And then we hold an inquiry as it is held in any court of law, where you get an opportunity to come in front of the council in person. And after having held the inquiry, the decision is taken either to exonerate that RMP or give him punishments as per whatever is written in the acts and the rules and regulations. So these are the three words that you should know, because this is the most commonly used words, not only in front of the medical council, but even whenever there is a complaint against RMPs, say in a consumer court or a criminal court. So medical misconduct, that is basically violation of any doctor's duties, medical negligence, failure of the doctor to provide medical services with requisite skill and care, which gives rise to some hurt to the patient, for which he can be pulled up either in a criminal court, civil court, or consumer court. And of course, medical malpractice, where the treatment given was below the degree and skill expected of a competent doctor, and that the negligence proximately caused the injury or the death. So basically, if you see, there is not much of a difference between these, three words that are used over there: misconduct, negligence, and malpractice. But why I'm telling you is this is because basically when you come to the council and you come with a lawyer who is not well versed with the medical terminologies, he reads that in your Maharashtra Medical Council Act, it is written about medical misconduct. So when it is misconduct, you will not be able to hear what is negligence or what is malpractice. So that is not the case. So that is why I just gave you the definitions of all these three words, and they are interlinked with each other. And in my whole talk, I will be talking about basically giving you an overview of how we conduct the hearings in the Maharashtra Medical Council, so that when you have this knowledge, you will not have the fear tomorrow to come in front of the council and give your say. Many a times, and it is sometimes very, very sad, where I see my seniors, my teachers giving me a call and saying, Putture, I have got a call from Maharashtra Medical Council and I don't know what to do. So as I said, in the future, you will not be able to say, I don't know what to do, because this is going to be a norm like how it is in the Western countries. So let us all be prepared for these complaints coming against us in the future. And there is nothing to worry, nothing to get scared of if the council asks you for an explanation. If you have treated the patient ethically and in the proper manner, you can put it forward in the council, and I don't think the council will ever take any action against you. Many a times, the RMPs ask what are the powers of the medical council. So if you go to see which is what is written in the act, there are huge powers that are there as far as your practice is concerned. Remember, whenever it comes in front of the council, we can, if at all we find that there is anything wrong that you have done, or there has been a misconduct or malpractice which you have been done, the only thing that the council can do is as far as your registration is concerned. There is no way that the council can give monetary punishment to you, which basically is given by the consumer courts, or there is no jail or anything like that, because that is by the criminal court. So all these three courts have got their own jurisdiction in which they are supposed to be acting. So basically the powers are that we prescribe the code of ethics for regulating the professional conduct of a practitioner. And I think all of you must go and see the MCI Code of Ethics 2002 to exactly know what you are doing, what you should do, and what you should not do, basically, as far as your practice is concerned. I'm not going to go into the details of the ethics because that is a complete new chapter itself. I'll stick to only as far as the Maharashtra Medical Council hearings are concerned. And once it comes to us and we hear you out, and we find that there is something wrong, as I said, what can we do? Basically, we can reprimand you. That means we give you a warning. And or if your act is gross negligence, then we can suspend you for a few days to a few months to a few years. Or if it is absolutely gross, which of course very, very rarely ever council does, unless you are repeating the same malpractice, then you can be completely or permanently removed from the registry. So what you have to know that is, as far as your practice is concerned or your profession is concerned, it is a council which will be deciding if you should be allowed to practice in future or not. So as I said, all of us should know this code of ethics. And here I am just telling you, as far as the council is concerned, what are the powers? So 8.1, that is a section in the Code of Medical Ethics 2002 of MCI, they write that the instances of offenses and of professional misconduct which are given above, that means whatever 1 to 7 section has been given in the 2002 Code of Ethics, do not constitute, are not intended to constitute a complete list of the infamous acts which calls for disciplinary action. And the state medical councils are in no way precluded from considering and dealing with any other form of professional misconduct. That means this is again why I'm putting you forward is that we have, as a council, as far as your professional misconduct is concerned, the powers are quite a large powers which have been given under this act. And what we see is that whatever is written in the code of ethics, it is not violated in letter or in spirit, in both. And those are the powers, because that is not what a criminal court is allowed to do, to see that it is in spirit. It has to be in letter, whatever is written in the act and the law. But the council can go beyond that also in deciding the whatever punishment has to be given. So if you see that the Maharashtra Medical Council Act 1965, Section 22, it is under this section that we are supposed to, hear the hearings and give at all issue whatever punishments have to issue. And as I told you already, what can be done if we feel that whatever the misconduct is there, but if it's of a low caliber, then we only issue a letter of warning to that you should not be doing this, and henceforth if you do it, action again can be taken by the council. Then you can be removed for a specific period of time, or you can be removed for permanently. Now this is after the hearings are held, but there are some in some aspects where without holding hearings also the council can give you a punishment, and those are basically where you are convicted by a criminal court for your practice. That means if a criminal court, and classical example I will give you is the PCPNDT Act. The PCPNDT Act, if you are convicted by a criminal court, then we do not require to hold any hearings. We are supposed to take action against you as per the PCPNDT Act and the Maharashtra Medical Council Act. So any conduct which in the opinion of council is infamous in relation to the medical profession, and when I say any, again I say that there is a large sections which are there under the Maharashtra Medical Council. We can do the hearings in that. So what are the, as far as the powers are concerned, we are called a quasi-judicial body. The council is called a quasi-judicial body. And we have the same powers which are vested in a civil court. Under the civil code, Code of Civil Procedure 1908. That means we have the right to enforce the attendance of any person and examine him under oath. Now this I feel I should elaborate a little bit, because many a times when the patients come to us, we ask them that why do you feel what your doctor has done is negligent? At that time the patients tell us that after suffering at the hands of these doctors, we went to such a doctor, and that doctor told us that whatever treatment you have been given by your original doctor has not been proper, and because of that you have suffered, and because he said that, we have come to the council. That means this is what is classically called as a medical jousting. Be careful, because if we come to know that you have said this and we require more information under that, we can enforce the attendance of such a person who has made such a statement, and he has found that there is something fault, to find out exactly what is the fault. So you can be brought in front of the council. Then of course we can ask any and all documents. That means especially what happens is a doctor who's practicing in a corporate hospital, uh, all the paperwork and all the indoor papers are with the corporate hospitals. So many a times what happens, these corporate hospitals, because they are also pulled up in these medical negligence cases, they do not give these papers. So the council has a right to compel them to give these papers, so that we can go through these papers and decide if there has been negligence or not. And then of course we can have commissions, like how a court holds commissions for examination of witnesses, and that can be done even with witnesses who cannot travel to Mumbai. We can send a commission to the house of that witness, and we can take down the details of whatever the witness wants to give. So, and all these inquiries that we are holding are deemed to be judicial proceedings within the meaning of section 193, 219 and 288 of the Indian Penal Code, IPC. So there is a legal sanction even to whatever action the Maharashtra Medical Council takes. So if you come to the rules of the Maharashtra Medical Council, so basically it is given in these section, chapter 6, all these details have been given of how exactly we can hold these hearings whenever there is a complaint against any doctor. So what it says is that these complaints can be either made by a patient or his relative in writing, or this complaint the Maharashtra Medical Council can take up suo moto. That means the complainant against you is the council itself. Now, this is also in very rare cases, wherever the cases have been referred to us by the government, may it be the state government or the central government, or referred to us by a central body like what was the erstwhile MCI, but now the National Medical Commission. And of course, sometimes from the human rights also, we do get some complaints. So in such circumstances, the Maharashtra Medical Council themselves become a suo moto complainant against you. Any other complaint which is there, which comes from the patient or his relative, has to be in writing. Not only in writing, it has to be signed with the details of the complainant. And we do not take up any anonymous complaint from any person. Whenever, many hundreds of anonymous complaints we get which are not signed and we do not know the name, they just said that they say that such a doctor has done such a thing and the council should take action. We do not take action whenever it is anonymous. And then when the complaint is sent to the council, basically the registrar is the first person who acts on these complaints, and then all the papers are put in front of the president. So as soon as basically the registrar, whenever he gets a complaint from any patient or his relative, that complaint is immediately sent to the RMP to get the RMP say as far as whatever the complaint is concerned. So we collect documents, written documents from both the parties. Once the written documents come from both the parties, as per the act, it is to be kept in front of the president, and the powers of the president are there to continue with this complaint or to close this complaint or not. Now, these are huge powers which are given to the president. And at least when I took over as the president, I decided that one person should not be wielding so much powers, though I was the president. And therefore, we have made a committee of members, which we call as the ethical committees, where all these papers are placed in front of these ethical committees, and the preliminary hearings are held in front of these ethical committees. Now, what is the importance of the preliminary hearings? Importance of the preliminary hearings is that to find out per se if anything unethical has been done or not, and if it has been done, to charge sheet that person. And therefore, it becomes very, very important for you to answer to the Maharashtra Medical Council if you have received any letter of complaint from the Maharashtra Medical Council. If you do not really require in all cases to take up a legal person to prepare this document, if you feel whatever you have done is proper and that there has been a misunderstanding, you can answer it on your own. But if you feel that there is even one iota of something that you have done which is not right, please, I request all of you, take the help of now medical legal experts who are there, may it be from the association, from IMA, or from whichever association or you are a member, and then formulate the letter. Because if your letter is perfect and it goes to the council and the council finds that there is nothing wrong in that, your file gets closed there and there. If the council feels that we require to hear from you something, then of course, as I said, it goes to the ethical committee, and one preliminary hearing is held where both the patient or the complainant and the RMP are given a chance to talk, and accordingly we decide what to do further on. Then of course the council has always got a right that we can ask for any additional information also, and then decide if, when the registrar puts these papers in front of the council, we can decide that if there is no prima facie case made out against this medical council, we, as I said, we exonerate or we close this file. But if we find that there is something wrong, then the next step is taken, and these are also laid down in the rules and regulations between 66 and 73, how exactly this inquiry is supposed to be taken. So as I have told you, though the powers are there with the president to decide what to do and what not to do, what we have decided in the council now is there are a team of doctors will be deciding, and these powers will not be under one person. So once we find that yes, there is something wrong, that the RMP is done, then there is something called a charge sheet. Now remember, what is the difference between the original complaint and the charge sheet? To give you an example, it is the difference is that of an FIR and a charge sheet by a court of law. So in that complaint, it is like an FIR where he may give 10 complaints against that doctor. But amongst the 10 complaints, we find that 8, there is nothing wrong. There is only in these 2 complaints that there is something that the doctor has done which is unethical. Now these 2 complaints will form the charge sheets, and the hearings will be restricted to only those complaints itself. And that is the importance of, as I said, what I said is that you answering very properly to whenever you get the first notice from the MMC. Normally, as per the act, we give you around 7 days, but remember that there is a provision also where you can ask for extension of time to collect the papers and to give a proper answer. And invariably, the council gives you almost a month to give your written answer to whatever complaint has been given to you. And then we call for the relevant documents. Whatever documents have been submitted by the complainant is handed over, a copy is handed over to the RMP so that the RMP knows how to defend himself. And whatever documents are given by the RMP, if asked by the complainant, those documents are also handed over to the complainant, so that saves a lot of time whenever we are doing the hearing. In the reply, you can say if you want to physically come in front of the council, or you want the council to depend on whatever you have given in writing. But the very fact that there is a charge sheet which is filed against you, that means there is something wrong somewhere that the council also feels you have done. So I would suggest all of you, please do come physically and attend the hearings, because there you get a time, the time to refute whatever the complainant is saying against you. If you feel that you cannot come, you can always, the Maharashtra Medical Council is one of the few councils in India which allows you to be represented by a lawyer or by a colleague or by a family member also. So you can always give a wakalatnama to the lawyer, or you can give the powers to your legal person, your colleague. Many doctors now have done their LLB, so they can also represent you, but you require to give a written authority to them, so they can also come. So it's not necessary that you personally have to come every time. They can, just like in a court of law, your lawyer can represent you. So what happens, what is the procedure of inquiry whenever you come to the council and the hearing is taking place over there? So you can either, as I said, come personally or through your practitioner. So initially the registrar reads whatever the charge sheet is there against you. Then the complainant is invited to put forward his case. And if he has evidence in support of whatever he is saying, he can put forward that evidence. After that, the practitioner is invited to state his case and put forward his evidence, whatever he is there. Suppose he feels that whatever evidence that the complainant has given is incomplete, and you want to put forward some more evidence, you can put forward that also. After that, both the parties are also allowed to bring in some legal experts who, if they want to give evidence from their side also. So though that hearing also takes place, and at last the complainant is just given one more chance to refute whatever the RMP has said, but he cannot repeat the same thing, and he cannot bring any new evidences at this stage. So he is supposed to talk only on the evidence which the RMP brings forward. And after that, the case is closed, and the decision in a closed door, the council discusses amongst themselves, and the decision is taken. So as I said, you are allowed to get witnesses. These witnesses can be from both the sides, from the complainant side and from the RMP side also. So normally witnesses, suppose you have done a, say, oncology case, normally the witness is always some oncologist, senior person who wants to come and talk on your behalf, he can be called. But whenever that such a person comes, he is supposed to be first interrogated by the person who, that means the either the RMP or by the complainant, whoever has brought that witness. And then of course the other party is allowed to re-examine and re-examine this expert who has come forward to us. But remember, we allow only real experts to come over there. You cannot get any Tom, Dick, and Harry to talk about you. As I said, if it is a urology case, we always prefer having a qualified urologist to come and give evidence over there, and not any XY person. This is as far as the RMP is concerned. And so this is wherever the complaints, as far as the complaints are concerned. Where there is no complaints, that means whether it's a suo moto, as I said, where the powers of the council is there to charge sheet you suo moto. At that time, the registrar reads out whatever the charge sheet is against you, and then the practitioner is invited to state his case. But here, instead of the council being just a witness to what you, as we see whenever there is a complainant present, where the questions or the counter questions are asked by the complainant or his lawyer, this in these cases it is the council members who will be asking you the questions. So they act as if they are the complainants. And so this is basically whenever it is a suo moto case which is there against you. Then there is always the proceedings, just like in a court of law, how the record of the proceedings are kept. In the council also, the record of the proceedings are kept, this which is held under this section 71. And any complainant or a doctor also has got a right to ask for the records of the proceedings from the council. So that is your right, so that if you feel there is something adverse written against you, that can also be challenged in the future. And that is, as I said, once we hear out the complainant, then we hear out his witnesses, we hear out the RMP, we hear their witnesses. At the most, we allow one more opportunity for the complainant to refute whatever the RMP is said. Then we close down the cases. But if the council feels that we require to have some more evidences or some more papers or anything, a further opportunity can always be given to the practitioner. This is there in section 73, to make other statements or to bring in, because ultimately the practitioner has a full right to safeguard his rights and his practice. So he is given one more opportunity if the council feels it is right. So in short, to put whatever happens in the council, so we get a complaint. Once we get the complaint, before coming to the council, the complaint goes to the registrar. The registrar sends the complaint to the concerned RMP, and he asks the RMP within 7 days to give whatever his say is as far as the complainant is concerned. And here I would request all members, the complainants are in para-wise complaint, so your answer should be as per that para. That means you should also answer not in general terms. Don't do an essay writing whenever you send your answer, but it should be that para 1, this is the complaint and this is my answer. Para 2, so this is just like how it happens in the court of law. If you all have seen how the lawyers prepare this answer to whatever the complaint is. Once the registrar gets these, he puts it in front of the president, and then the president puts it in front of the ethical committee. It is discussed in the ethical committee, and if we feel that we require to call you for further finding out if really we should charge sheet you or not, we hold a small inquiry. It's a very short inquiry. Basically, it's called as a prima facie evidence collection, to find out if really there is something wrong and we require to charge sheet you. If we find that prima facie, yes, there is something wrong done, we charge sheet you, and then this charge sheet is sent to you. You can again in writing give your rebuttal to whatever the charge sheet is, which is again kept in front of the council, and then you are allowed to come in person to give your say or argue out your case of what you have done is right or wrong. So this is basically in short what exactly is done in the council. Now, as far as the implementation is concerned of the council, as I said, once we do the hearings, after that it is deliberated between the council members, and then we come to some decision, and whatever we pronounce, whatever the decision is taken. And this decision is sent to both the RMP and it is sent to the complainant also. So suppose we have punished you. These are the 74, 75 are the sections which are written in black and white in the rules and regulations. Suppose we have punished you, say for 6 months, we have removed your license. Then of course the question comes, how do you restart your practice after 6 months? Now that is also, the procedure also is laid down in the council under the re-entry of name of practitioner and registrar. Now there is a form 19 which you are, suppose your 6 months of punishment period is over, you're supposed to fill up the form 19. Not only fill up the form 19, but you require to give a certificate from a gazetted officer of the state government or from a justice of peace that within these 6 months you have had good character. This is there in the act and you're supposed to give it to the council. Once you do that, the council immediately restores your registration and you're allowed to practice. Remember, if your registration is suspended, you are not supposed to be practicing during that period. If you practice during that period and there is a complaint against you, it directly becomes a criminal case and it goes into a criminal court, not with the council. So be very careful. Please do not do that, because we find many a times when we say, that we give a punishment only of say 1 month or something, we find that that RMP does not really refrain from practicing for 1 month. Please do not do that. 1 month is not a big time, because next you will have to go not with to the council, but you will have to go to the criminal court. So what happens once we say that what you have done is wrong, but you feel that what you have done is still correct, just like how it is in the other court of law, you are allowed to go to an appellate court, and that appellate court, as far as the state council is concerned, is the National Medical Commission. And under National Medical Commission, it is the Ethics and Medical Registration Board, which is called as EMRB, under which you will have to apply and say that whatever this council has given me a punishment, I don't agree with that, and hence I would like to appeal in your jurisdiction to decide. Then again the decision is taken. Of course, this is in Delhi. You will have to travel to Delhi for this whenever you go to the appellate court. But if this EMRB or EMR as it is called finds that you are not guilty, they can pronounce you not guilty, and this decision, just like how the High Court decision is binding on the lower courts, or the Supreme Court decision is binding on the high courts, this decision is binding on the state medical councils, and we have to follow whatever decision has been given by this EMR, or the Ethics and Medical Registration Board. But if you find that the Ethics and Medical Registration Board also has punished you, and yet you are not convinced, or you feel that you require to go to a higher appellate body, then it goes to the full commission, that is a National Medical Commission. So you have got enough steps by which, if you feel that you have not done anything wrong, you can always go in appeal and try to exonerate or get your name cleared. Many a times the lawyers come to us saying that such a case which is there in front of the council, the same case is there in front of the criminal court, and the case is also filed in the CPA. Even our members ask, how can we be the same case be filed with the council, same case be filed with the CPA, that is the consumer protection, which is also a civil court, and same case be filed against the criminal court also. Remember, the jurisdictions of all these three courts are completely different and independent of each other. And there have been n number of decisions which have been given by the high courts and the Supreme Court also. I've just taken one example where it shows that there is no bar in the law to two types of proceedings, that is a criminal proceeding and a civil proceeding. And when we say civil proceeding, it is the proceeding in front of the state medical councils being held simultaneously in a given matter. So you cannot say that just because it is going on with the higher court, that is the high court, my case is going on, the council cannot hear me, because the council's jurisdiction and the council's punishment is completely different from what you get in a criminal court or a consumer court. So this is also a famous case which was there, which was filed against the council, and here it was filed in the consumer court and it was filed in the council, where it was challenged the rights of the state medical council to hear this case. But again the decision was given, no, the state medical councils look into only what is ethical in your practice or not, and nothing else. We are not supposed to go beyond that. Whereas the consumer protection, they basically find out if there is anything, if the patient has suffered because of your practice. See, remember, the patient can have a complication and suffer, but there is nothing unethical in what you have done. So your treatment has been as per standard treatment, then the State Medical Council will not punish you, but a consumer protection court can levy some monetary punishment on you in such circumstances. So we have both the cases can go on in both the consumer protection court and of course in the state councils. Now this is one of the latest cases which is there, where the High Court, what the High Court did was they encroached onto the rights of the medical council, the state medical council. Now it is written in law that if any body gives you the license to do something, it is in the powers of only in that body to revoke that license. Nobody else can do that. Unfortunately, in one case, the High Court gave an order to suspend the license of a doctor, and they sent that letter to the council. Now, this was challenged in the court of law. And what I'm saying over here, if you see the last line, where, in this whole, I've just given a short order that is given by that same court and the same judge. When it was brought to the notice of that judge, the judge agreed that it is the Maharashtra Medical Council which gives you the license to practice in the state of Maharashtra. So if there is anybody which can revoke your license, it has to be the Maharashtra Medical Council only, and not even the High Court. And therefore, the said order of the suspension of licenses is modified, and accordingly it is revoked or recalled, and it was sent or referred to the Maharashtra Medical Council to hold the inquiry as per whatever the rules and regulations of the Maharashtra Medical Council are, and accordingly we were asked to do the hearing. So even the High Court does not have a right to revoke your license. It is the Maharashtra Medical Council which has the right to revoke your counsel. So, and this is, I think, one of the last slides. There is something called suspension for holding, when your inquiry is taking place. If the council feels that whatever unethical act you have done is of such a nature that, because any inquiry takes some time, between 6 months to 2 years it takes time, that during that phase you do not have the right to continue your practice, what the council can do is that council can give an order that pending the inquiry there is a penalty or a punishment where you are asked not to practice. That is also in the powers of the council. So this is just a temporary suspension which is given by the council, because the council feels that you should not be allowed to practice because you are a threat to the patients and to the society. But remember, if at the end of that inquiry the council finds that there was nothing wrong in what you have done and this is automatically revoked, not only that, this does not go into your file saying that you have been punished, because this is not a punishment. This is just pending inquiry. There is a suspension of your license. It is an interim measure which is taken by the council if it feels that you should not be holding. And this is also was challenged, and it was held in the court of law also in this famous case of Ramineni, Venugopal, Somaya and others, and the Maharashtra Medical Council, where the council has got a right to do what is called as a suspension pending inquiry. So that is also the powers of the council is over there. So in short, before I end, I would say that just as I said in the beginning, that you should know what is the law and what you are under, what law you are governed with as far as your practice is concerned, so that you are not scared of the council. But at the same time, I would say that ignorance of law does not absolve you from the judicial action, may it be in the council, may it be in a civil court, or may it be in a criminal court. So thank you very much. I hope I have given you some information that tomorrow when you have to come in front of the council, you should not feel intimidated. You should not feel scared. The council is not there to punish you if nothing wrong if you have done. And I would not say you're welcome to the council, because that is not what even I want. But then I would say that when you come to the council, come with a clear mind and a brave heart. So thank you very much for giving me a patient hearing. And thank you, IMA Nasik, for inviting me for this talk.
Thank you, sir. Thank you for your lucid presentations. And we are really convinced that MMC is our high court, and it's a privilege to hear from the boss of council. Thank you, too, sir.
Thank you.
Coming to next topic, Dr. Sudhir Shetkar, sir. Sir is from Nasik and eminent cardiologist and young cardiologist from the Nasik. Sir is a practicing cardiologist in Apollo Hospital. Sir has done DM from eminent College of India, that is AIMS, and sir has presented many national and international paper. Sir also received many awards in the for presenting the scientific paper. Over to you, sir. Sir will be discussing on coronary artery interventions beyond angiography. Over to you, sir. Shetkar, sir.
Thank you. A very good afternoon to all of you. I'll just start sharing my slides. Hope it's visible to everyone.
No, sir, not yet.
It's okay?
Yes, now we can see.
Yeah. Again, a very good afternoon to all of you. I'm Dr. Sudhir Shetkar. I'm a cardiologist at Apollo Hospitals, Nashik. And as you can see, the topic I'm going to discuss about coronary intervention beyond angiography. We all know that till now, angiography was like the end stop of decision making, whether to go for intervention or not. But there is something far more than that, and that is the coronary intracoronary physiology, which I'm going to discuss, and how it's going to is helping us actually in making decision makings of whether to go for intervention or not, or which kind of intervention to do. This technique is there since long in the cardiology circle, but it was underutilized, and recently it's being very commonly used to help in decision making. Now, this is a simple 3 angiograms in front of you. You can see the first one, obviously there is a very critical lesion out there. The last one, again, you can see that decision making is very easy because the lesions are very simple. There are very less blockages, 20 to 40%. But the middle frame, you can see that the lesion is there, but it doesn't look like to be very tight. So whether it is significant, it's causing problems or not, this is the very important question before going for any intervention on this artery. Now, angiography has some caveats, like the angle with which you are viewing the coronary artery, that also tells us that how much is the stenosis. So a simple stenosis can look like 20%, or it might look 75%, depending on the angle of which you are viewing. So many of the times we are stuck whether this lesion is significant or not. So as I told, for coronary intervention, the first important step is decision making. So whether to intervene this block or not, and if yes, then how to intervene, whether to go for PTC or CABG. And the second is actually what is the performing the procedure. So if you know that you are doing right, then definitely the performing the procedure is not a big problem. So FFR, what is known as the physiological assessment of the lesion. So what is the meaning of physiological assessment? It means that whether the lesion is actually causing ischemia or not, how to assess that. That is the physiological assessment of the lesion. And fractional flow reserve is the recent modality which helps us in checking out that so as to go ahead with intervention. Now, another point I want to tell before going on the topic is that coronary interventions are done basically for 2 reasons. First one is for symptom relief from angina, and second one is to prevent acute coronary events like myocardial infarction, right? So for the first reason, that is for symptom relief, if you want to just relieve the symptoms of the patient, that the angina, then you have to be very sure that the lesion which you are going to put a stent in is actually causing the symptoms. So here is where the FFR or the physiological assessment comes into the picture. However, when you are doing an intervention to prevent acute coronary events like myocardial infarction, at that time our main aim is to assess the lesion morphology. Is there a plaque erosion? Is there a plaque rupture? Is there a thrombosis happening inside the coronary artery which might lead to an acute coronary event? And in that time, we do not go for physiological assessment. We actually go for intracoronary imaging, that is the OCT or optical coherence tomography or IVUS. This is it's not. I'm not going to discuss about that. I'm going to discuss about the physiological assessment in chronic stable angina patients, how it helps in decision making. Now, what is fractional flow reserve or FFR? It's a lesion specific. It's very specific. It is highly reproducible. If you do FFR in 10 cath labs properly, you will get the same readings. It's a physiological index of determining the hemodynamic severity of the lesions. It can accurately identify lesions which are responsible for ischemia, so that you can take your valid decision making whether to go for a PTC or CBG in this. And very important thing is it is measured at maximum hyperemia. What is maximum hyperemia? We all know that whether a coronary lesion is significant or not, it can be commented only at maximum exercise. And we can't do a maximum exercise at on cath lab table. So what we do is we give an intravenous or intracoronary adenosine to stimulate the exercise to increase the coronary blood flow. And at maximum coronary blood flow, we assess whether the lesion is actually causing significant drop in the pressures or flow into to that territory. So simply speaking, this is a simple diagram. You can see the coronary artery. There is a lesion in it. We measure the proximal coronary pressure, which we measure from the guiding catheter, which we have placed in the coronary ostium. And we pass a thin wire, which is a pressure wire. We cross it across the lesion and we measure the distal coronary pressure. So simply speaking, FFR is the ratio of distal coronary pressure divided by proximal coronary pressure during maximum hyperemia. This is very important. So we do maximum hyperemia, we induce it by giving intracoronary or IV adenosine. So what does it mean? What does FFR mean? If the lesion is not at all significant, the distal coronary pressure will be equal to the proximal coronary pressures, giving us a value of 1. And as the lesion increases, this value goes on decreasing. And a FFR of 0.6 technically means that due to this particular stenosis, maximum achievable blood flow to the myocardium supplied by that artery is only 60% of what it would have been had there been no lesion. So basically, this lesion is reducing the myocardial blood flow to that territory by 40%. So FFR is 0.6 means it is reducing the flow by 40%. FFR of 0.8 means it is reducing by only 20%. FFR of 0.9 means it is reducing by only 10%. So how we measure? We measure by this wire. This is a very thin 3 millimeter thickness wire, which has a pressure sensor inside it, which measures the intracoronary pressures. And this is the console, which is simultaneously giving us the proximal pressures. PA means proximal aortic pressures and PD means distal pressure, distal to the lesion. And both the tracings we can see simultaneously. And if there is any difference, we will get to see here. So in this particular image, the PD by PA ratio is 1. This means that both the pressures are equal. So how do we measure it? So there are standard steps. The first step is calibration. That is, we teach the system to zero pressure. That is basically zeroing the pressures, both of the systems. So we zero the pressures of both the catheter, which is measuring the aortic pressures or the before the stenosis pressures. And we also zero the system, which is the pressure wire, which is measuring the distal coronary pressures. After that, the second most important step is equalization of both these pressures. So basically, we are teaching the proximal pressure sensor and the distal pressure sensor to be first zero and equal to each other, so that it doesn't give us erroneous reading. So before crossing the lesion, we equalize both of these systems so that they are both synchronous with each other with no pressure difference, so that we can accurately measure the pressure difference only when we cross the lesion. So this is how equalization is done. You can see that both the aortic trace and the distal pressure sensor tip trace both are same and superimposed on each other. So this means that we have properly, adequately equalized the pressure and the ratio is 1. After that, the third step is the actual measurement. So we cross the distal sensor wire across the blockage and then we actually start measuring. So how we do it? We place that distal coronary sensor tip 2 to 3 centimeter distal to the stenosis and we induce maximal hyperemia by giving adenosine. And the lowest value which we get is what is the FFR. So this is one example. You can see that in this patient, the lesion was so significant that it has caused significant drop in the distal pressures. And you can see both the curves to be very widely separated and the ratio coming at 0.61. So basically this patient is having an FFR of 0.61. What does this mean? Which FFR you say that it is significant or should be intervened? So there have been very big trials, studies with a very robust data of 5 less than 0.8. They are the only lesions which are significant and they should be treated. However, those lesions which are having FFR equal to or more than 0.8, they are not significant and there is no need to intervene these lesions. These lesions remain stable and asymptomatic for a follow-up of 5 years also. So there are studies which have shown that till 5 years, these patients, they don't get any symptoms with these lesions. So currently, FFR is a class 1A indication in determining the hemodynamic significance of these lesions in chronic stable angina patients, and especially in multivessel PTCS. When we have coronary arteries with multiple lesions, multiple vessels are having multiple lesions, to which lesion to treat? Because just the symptoms of the patient are not going to tell us that which lesion is causing symptoms. So we do FFR of all these lesions and we determine that which is the significant lesion causing symptoms, and we can just treat them, and rest all lesions can go for medical management. So basically we use FFR to reduce the stent burden in these patients. So it's a gold standard investigation, which we had done, and how they really helped us in making decisions, and it actually changed the treatment of the patient also. So the first case is a young male, so 48-year-old male without any comorbidities, and he had class 2 atypical angina, and he underwent a stress test outside, which was reported as positive. But the thing here is that the test was positive at 11.9 METs. 11.9 METs means this patient has run through the 4th stage of the stress test. So it's basically a very mildly positive stress test. And on direct questioning of the patient, it was clear that he was asymptomatic. Like he used to climb 3 flights of stairs without any symptoms. So it was like this blockage, which was reported 80-90% in the LAD. We need to find out whether it is causing symptoms, because the patient is asymptomatic. So this is the angiogram. Left side, you can see the moving cine angio, and I have just freeze it in a frame so as to make you see the lesion. So this is the lesion which was reported outside like 80-90% and was advised angioplasty. But I felt that this lesion is not very significant. It's more of like 60-70% borderline lesion. So we decided that rather than directly saying to the patient that you don't need any intervention, we should prove it that he actually doesn't need any intervention. So we did FFR of this patient, and you can see at maximum hyperemia, his FFR came out to be 0.9. So this lesion was actually not causing any significant reduction in the coronary blood flow to the territory supplied by that artery. So doing angioplasty is not going to help this patient. So we say that you don't need an angioplasty, you can be managed on medical management. And he is now currently in the 3rd year of follow-up, and he's totally asymptomatic. He did not need an unnecessary stent. So whenever we have a discrepancy between symptoms and the coronary lesions, FFR is the tool which helps us in decision making. Now, another case is exactly opposite to this. This is yet more younger patient. It's a 34-year-old male. When a young patient comes to us, really we do not want to put an unnecessary stent in his body. But he was having class 2 typical symptoms, and his treadmill was also positive, and it was positive at just 7 minutes. That's a strongly positive stress test. Like it was just in 2nd stage it came positive. His angiogram was done, but it was reported as mild, mid for 50-60% lesion. Now you can actually see that this lesion actually doesn't look like to be very significant, right? But the patient was having typical symptoms. The patient was having a strongly positive TMT. So we have to prove that actually this lesion is causing symptoms or not. So we did FFR, and surprisingly, his FFR there was a significant drop in the pressure. You can see the separation of both these lines, the aortic pressure and the distal pressure, and the ratio was 0.61. And this patient underwent a successful angioplasty, and now he's asymptomatic. So in young patients, when we actually do not want to put unnecessary stent, many of the times some significant lesions might be left away because visually they are not looking tight, and we are not doing intervention in them. So FFR in another way also helps us to detect those lesions which are not looking significant and guide us whether to put a stent or not. So it's a gold standard modality in deciding need for intervention. And this patient actually needed an intervention, and we did a PTC of this vessel. Now, next case is about a multivessel disease. Now, this is a 73-year-old gentleman with the diabetes and hypertension. He had class 2 atypical angina, and he underwent an angiogram, and it was reported to be having ostial LAD disease and right PD disease, and was advised CABG. Now, when we reviewed the angio, we found that the lesions are not significant. The ostial LAD lesion is also not significant, and the right side PD lesion, which was reported as significant, since it was at the bend, so probably it was looking significant. But when you freeze the frame and see it, it doesn't look like to be significant. Now, a person who has been advised CABG at some another center, it's very difficult to convince them that you actually don't need to do anything. So here again, FFR is the modality which we advise him, and we documented that the LAD lesion FFR was 0.93, that is not significant. And the right side PDA lesion, also the FFR was like 0.92, it's not significant. So we could easily convince him by doing FFR that your both lesions are not significant, you don't need a CABG, and this patient was saved of major surgery. So we deferred the CABG. He is also on medical management and follow-up since past 2 years without any symptoms. Now, fourth case is again a multivessel disease. He was also advised CABG. Now, as I told you, whenever a person is having multivessel disease, now it's very important to find out whether the lesion is causing ischemia actually or not, so as to give him maximum revascularization benefit. So again, this is the angiogram, and we can see, of course, the OM lesion is highly significant. It's like tight. There is no doubt that this lesion is significant. But the LAD lesion, which was reported as significant, I felt that it is not significant. It is at the most 40-50%. Similarly, the RCA lesion, which was reported to be very critical, you can see that it is not critical. There is a gradual tapering of the vessel. So it's at the most borderline lesion, like 60-70%. But again, we have to prove that these two lesions are not causing any symptoms. So we did FFR of LAD, which was 0.88, that is not significant. As I had told you, FFR of more than 0.8 are not significant. They don't need any intervention. And the right-sided lesion, again, it was 0.88. So both the lesions were not significant, and the patient underwent just the PTCA to the OM. So his CABG was deferred and he could be managed. His symptoms were completely abolished by just doing PTCA to the OM. And the LAD and RC lesions both are now under medical management. The final case is again a case of triple vessel disease. Basically, it's a double vessel disease, but 3 lesions, and he was advised PTCA with 3 drug-eluting stents. Now, you see, when you are putting 3 long stents, you are giving the risk of instant restenosis to the patient, especially when the patient is a diabetic. So we really want to put the minimum length of the stent, minimum number of stents as much as possible. So we reviewed the angio. This is the angiogram of this patient. Of course, the proximal lesion is highly significant, it's critical, it needs intervention, there is no doubt about that. But the distal lesion, which was reported as significant, in another view, we felt that this is not significant. Also, the more distal you go in the coronary vasculature, less amount of myocardium is supplied by that territory. So more distal the lesion is, lesser the hemodynamic significance of that lesion is. So before putting a stent in a distal vessel, we have to be very sure that it's going to benefit him by reducing ischemia burden. So we decided that we'll do an FFR of this lesion. The RCA lesion, which was also mentioned as significant and was advised angioplasty, this was also not very significant since it was exactly at the bend, and during movements at the bends, sometimes erroneously we feel that the lesions are significant. So very simple discrete lesions, when they are at the bends, we have to take them with a pinch of the salt, whether they are significant or not. So we felt that this is not significant, but we documented both of them by doing an FFR. FFR of the distal OM lesion was like 0.89, so did not need any intervention. And the FFR of the RCA was also like 0.87. It was not significant. So this patient who was advised PTCA with 3 stents could be managed just with 1 stent in the proximal circumflex. Rest both of the OM and RC lesions whose FFR was negative, they are under medical management. Again, this patient is asymptomatic since past 1.5 to 2 years, I think she's on the follow-up. So with these cases and a brief description, I could just give a take-home message that decision-making before coronary interventions is the most important step. We have to actually make a decision whether to intervene or not, whether to put the metal in the patient's heart or not. And FFR is the single best reproducible modality. I am saying reproducible means no one can challenge the FFR. That, like angiographic lesions, they can be challenged. That someone is feeling it is 60%, someone might say it is 70%. But here we get a gold standard uniform value which is reproducible almost everywhere. So it's a single best reproducible modality, and it assesses the hemodynamic significance of the lesions, and it should be routinely used. In fact, we are routinely using it in multi-vessel setting to decide which vessel to be stented or not, multiple lesions to decide which lesion needs to be intervened. When the symptoms and coronary findings are discrepant, patient is having typical symptoms but coronary lesions are not significant, or patient is having no symptoms and the lesion looks to be significant, we need to really correlate both of them. We do an FFR and just close the topic there. So if you do an FFR, it's significant, then no doubt we have to do intervention. But if it is not significant, we keep on medical management. discrete lesions, simple lesions, very small lesions, especially at the bends, and those lesions which are very distally placed, they are the ones which are usually not hemodynamically significant. So rather than putting a stent on them, we can document and keep them on medical management. So thank you for patience listening.
Thank you, sir. Thank you for your good talk. The percentage of blockage is not the only indication for going angioplasty. Even we should look for the physiology in the coronaries. Thank you, sir. Thank you for your nice talk. Coming to a next topic from the same hospital, Apollo Hospital, Nashik. Dr. Dhaval Choksi, sir, is a consultant gastroenterologist. Sir has done DM from Lokmanya Tilak Medical College, Mumbai. Sir has presented national and international paper in the field of gastroenterology. Sir also received many awards in the field of gastroenterologist. And sir, over to you, sir. Dr. Choksi, sir.
Am I audible?
Yes, sir.
Yeah. My slides are seen, visible?
Not yet. Not yet.
Now?
No, sir.
Just give me a minute.
Yes, we can see now.
Visible? You can see?
Yes.
Yeah. A very good afternoon to one and all. At the outset, let me thank Samir sir and all the organizers of this conference for giving me an opportunity to present these cases. Actually, since morning, we've received very heavy doses from all the senior and successful consultants and practitioners. So I would like to keep things very light, and that will help you to digest these things, because as a gastroenterologist, that is what my job is. So all these cases are real-time cases. They've been pretty tricky and difficult at times. We had to take very tough calls, and we had to take tough decisions. As far as treatment planning was concerned, we tried to give our best, and fortunately we ended up managing all these cases successfully. So here I am presenting these 4 cases. These cases are from all subspecialty of gastroenterology. That includes liver, that is hepatology, luminology, advanced pancreaticobiliary system, and advanced endoscopy. So this is the first case. So we had a 61-year female resident of Dhule. She was mother of a police inspector. She was known hypertensive and hypothyroid. She was on metoprolol. She was referred to us in view of deep jaundice. Her history goes, she had yellowish discoloration of eyes and urine for last 2 weeks associated with prodrome. She did not have any history of chronic liver disease, any itching or clay stools. She denied any addictions. On examination, she had grade 2 obesity with BMI being 32.8. She had mild pallor, icterus was present, and she had 4 centimeters hepatomegaly. These are her labs before coming to us. As you can see, the total bilirubin was very high, almost in the range of mid-20s, with direct bilirubin being predominant, and her SGOT, SGPT were predominantly raised as compared to alkaline phosphatase. Also, her reports suggested that INR was elevated, 1.53, and liver synthetic function was also low, albumin of 2.8. So what is the diagnosis? From the labs and from the history, one thing we are sure about is this is a hepatocellular jaundice. There is no obvious evidence of biliary obstruction, neither in the symptoms nor in the labs. So this is hepatocellular jaundice. Now we have n number of causes of hepatocellular jaundice. So we need to find out the cause, because once we find out the cause, we are going to treat the patient. So one very important thing which is not given in the history is drug history. Now this lady was taking Ayurvedic Kada for last 1.5 months. This is in August when COVID was at its peak, and she was taking Ayurvedic Kada for last 1.5 months. Also being obese, she had osteoarthritis for which she used to pop up nimesulide intermittently. So we need to keep this history in mind. And then we went about with next investigations. The first being the viral hepatitis. So all viral hepatitis markers, including HAV, HBV, HCV, HEV, HIV were negative. Her ultrasound abdomen did not show any specific finding. There was no obvious evidence of chronic liver disease. Now we need to keep this in mind because her INR was deranged and her albumin was low, which gave a thought that she might be having some underlying liver disease, but imaging is not showing that. What next? So going to the next etiology after viral, after alcohol, what we need to rule out is autoimmune liver disease. So we did her autoimmune profile. Her ANA blot was negative, which sees for multiple antibodies. Her ASMA was negative. That is again a marker of autoimmune hepatitis. Her serum immunoglobulins were raised. Her anticore antibody for hepatitis B virus, HSV, EBV, CMV serology, everything was negative. Now, at the end of all the imaging and serological tests, we did not have any diagnosis. So eventually what option was left was liver biopsy. We need to understand that convincing a patient for liver biopsy is extremely tricky, extremely difficult, because what we are dealing with is a benign disease. That is first. And second, these patients do not have very troublesome symptoms. So they're not having itching. There is no pain. There is no severe anorexia, weight loss, which the patient would make feel that, okay, I'm suffering from any kind of malignancy. So convincing them to undergo a liver biopsy is not easy. Also, when you describe the side effects, then all the more they are reluctant to undergo liver biopsy. Fortunately, this lady agreed to liver biopsy. So this is the histopathology. I will read out the report. So the report goes like, she had chronic hepatitis with bridging fibrosis. So bridging fibrosis is F3 fibrosis, a stage short of cirrhosis. So meaning thereby the disease is long-standing and there is significant fibrosis. Also, the other description of interface hepatitis, rosetoid arrangement of hepatocytes is typically seen in autoimmune hepatitis. So now the impression from the histopathologist was this is classically autoimmune hepatitis. After the biopsy, we started her on treatment typically given for autoimmune hepatitis in the form of steroids in the tapering dose. And once the LFT is improved, we started her on azathioprine. And the steroids and azathioprine was started, there was gradual reduction in the improvement in LFTs. Eventually, the LFT is normalized after 1 month. On subsequent follow-ups, she's never had a flare. She's now only on azathioprine because we don't want to give her steroid considering the fact that she's a 61-year female with grade 2 obesity. And obviously, she's stopped all the CARDAs. So the final diagnosis was a female with hypothyroidism with seronegative autoimmune hepatitis, possibly some component of injury because of drugs, and it was steroid and immunosuppressive responsive. Case number 2, which is very much similar to case number 1, a 39-year gentleman working at HL with no prior medical or surgical illness, without any history of addictions, presented with 3 weeks of yellowish discoloration of eyes and urine associated with prodrome. This gentleman also did not have any history of chronic liver disease, no itching, no clay stool, no fever. He was not on any drugs because he didn't have any medical or surgical condition. On examination, except for icterus, he had nothing. On basic investigations, his CBC was normal, but the LFT pattern was again very, very similar to the first case, and the time gap between the case was about a couple of months. So total bilirubin was high, predominantly direct. Again, SGOT, SGPT predominantly elevated as compared to ALP and GGT. INR was normal. USG again was normal. So diagnosis was again hepatocellular jaundice in this patient, and then we had to go about finding the etiology of hepatocellular jaundice. His viral markers all were negative like the first case. Next was workup for autoimmune hepatitis. So in autoimmune hepatitis, ASMA antibodies were positive and her IgG levels were raised. Both suggest autoimmune hepatitis. Second, because he was 39 years old, he also needed to undergo testing for Wilson's disease. So his ceruloplasmin was low. The 24-hour urinary copper was borderly elevated. There was no KF ring. So now what, at the end of all these investigations, we had certain features being positive from all the systems. Autoimmune hepatitis because autoantibodies were present, IgG was elevated, it was hepatocellular jaundice. Wilson because of his age, because of the fact that ceruloplasmin was low, and something else. So a liver biopsy was done. I will show the images. So this is the histopathology image. So this arrow, the one in black is zone 1 or periportal. This area is zone 3, which is perivenular or zone 3. The liver biopsy classically describes presence of zone 3 congestion, hemorrhage, and liver cell necrosis, which is perivenular in distribution, right? And no obvious evidence of any fibrosis or cirrhosis. The possibility of venous outflow obstruction or drug-induced liver injury is suggested. We also did liver copper levels. The liver copper levels were pretty high, 111.7. Anything more than 45 we consider to be significant. And again, I want to add history here. There was history of consumption of Giloy for corona prevention for last 1 month. Now we need to know Giloy is called as Tinospora cordifolia. It contains various chemicals within, one of an important component of which is pyrrolizidine alkaloids. Now alkaloids are conventionally described as far as drug-induced liver injury is concerned in complementary and alternative medicine as causing zone 3 necrosis, perivenular congestion, perivenular necrosis. So this patient, once we did the biopsy, was empirically treated with low-dose steroids till we got the biopsy. Obviously, once we got the biopsy of drug-induced liver injury, his steroids were stopped. And his LFT started showing improving trend since admission. Actually, even before we gave any specific therapy, the LFTs had started showing a bit of improving trend. So the ultimate differential were drug-induced liver injury as from the history and biopsy, and from the fact that LFT is improved after stoppage of Giloy. Actually, he had stopped Giloy before he came to us 3-4 days back. So probably that was the reason. Second, autoimmune hepatitis, because his ASMA was positive, IgG was positive, and those 3-4 days wherein we give steroids, there was some improvement. And last but not the least was Wilson's, because everything was fitting, a low ceruloplasmin and high liver copper. So at the end of 4 weeks, we just kept on observing the patient. His LFTs returned to bang normal. He was off any medication. We have not given him any immunosuppression, and we've not advised him a copper-free diet as well. So our clinical diagnosis is drug-induced liver injury because of complementary and alternative medicine. So the important take-home messages from these two cases are: always take thorough drug history, because as a gastroenterologist, majority of the side effects of any drugs is what we see. Either it's luminal, constipation, diarrhea, vomiting, dyspepsia, or drug-induced liver injury. Second, always do detailed evaluation, because when you do detailed evaluation, you are going to pick up the exact cause. And it is very, very important as far as liver is concerned that you pick up the exact cause. One very important take-home message is absence of serology cannot rule out autoimmune hepatitis. The way we saw in the first case, all serology was negative, but biopsy was positive. And it's vice versa. The way in second case, where ASMA was positive, IgG was raised, but biopsy showed drug-induced liver injury. Also, when in doubt, get a liver biopsy done. Obviously, it needs due care and precautions. It needs a lot of counseling, but then sometimes liver biopsy is the only answer. And the final diagnosis has long-term implications on treatment and prognosis. Like these two cases, one patient is having actually fibrosis and has chronic liver disease and needs long-term immunosuppression. Other patient has got just drug-induced liver injury, no long-term sequelae. So final diagnosis has got a lot of meaning. Also, the dietary restrictions and medications are not there for somebody with drug-induced liver injury. Coming to third case, we had a 63-year gentleman with history of diabetes for last 3 years. He had ischemic heart disease for last 3 months. During the same episode, was diagnosed to have acute kidney injury on CKD. with creatinine hovering between 1.5 to 2. And 1 month post this event, he had acute left ventricular failure with ischemic cardiomyopathy, ejection fraction being only 30%. Now, he came to us in the ER with history of melena daily for last 4 days and hematochezia for one day, and history of intermittent black stools for last 3 months. This was obviously on inquiry. He didn't come up with this history. On examination, he was having hemorrhagic shock with BP of systolic. His HB was 4.5. After hemodynamic stabilization with PCV and IV fluids, we stopped his clopidogrel, continued on aspirin, and we went about finding out the cause of his hemorrhagic shock or GI bleed. So as per the guidelines, we went about, did upper GI scopy, which was normal till second part of duodenum. The next step was to do colonoscopy. Colonoscopy showed presence of altered blood right through the colon, extending up to terminal ileum. So obviously the blood was coming from proximal small intestine. And as a part of evaluation of GI bleed after upper GI and lower GI scopy, we do CT abdomen. In this patient, we couldn't do contrast study because his creatinine was raised. His CT abdomen was normal, the plain scan. So now we were left with the question, now what do we do? He has obvious bleed and we have not come to the diagnosis as yet. So the next step was a capsule endoscopy where we give a patient capsule to swallow. The capsule does all the recording right from mouth till the anal canal. And quite often, almost in 60 to 70% of the cases, we can localize the site of bleeding as well as the cause of bleeding. So these are the images from capsule endoscopy. These are the villi which are seen. And what you can see here is presence of bright blood. This is bright red, and this is altered or black blood here. So the finding was there was presence of fresh blood at around 2 minutes and 11 seconds after the capsule had crossed the pylorus. And rest of the small and large intestine had black blood. However, at that particular site, we could not find any lesion. But as the lesion was very close to the pylorus, it was thought that this is a proximal small intestinal bleed. So this patient we managed, I guess, somewhere around 15th of March, exactly a week before lockdown was announced. The patient was ex-principal of a school and the son stays at Netherlands. So he didn't want to go anywhere. The patient was very reluctant to undergo surgery also, and we were also not very keen because he had multiple comorbidities. So we decided that we would do a push enteroscopy. Push enteroscopy is something which helps us to visualize first 40 to 50 centimeters of duodenum and jejunum. So that is the maximum limit. We will not be able to study the further part of jejunum and ileum, but we just gave a chance that if the lesion is there, we might see endoscopically and maybe offer some treatment. And this is exactly what we got. At around 40 centimeter, once the scope passed across the DJ flexure, we saw a huge polyp, almost 3 by 3 centimeter, which had a thick pedunculated stalk and which had spontaneous bleeding over its surface. And these are the jejunal folds. So eventually we decided that we would manage this polyp endoscopically. Obviously, the risk of bleeding and perforation was explained to the family, and surgical backup was kept ready because if at all he develops any of these complications, we won't be able to, as in we could offer endoscopic management like clipping, but then he might need surgery. So with that, he consented, and we did endoscopic mucosal resection of the polyp. The whole polyp was removed en bloc. He did not develop any complication of bleeding or perforation, tolerated the procedure well. Melena stopped after 1 day, and he was discharged after 1 day of observation. This is the gross specimen, and this is the low power histology, high power. So you can very well see the smooth muscle tumor here. All these are muscular fibers suggestive of benign stromal tumor. Now this benign stromal tumor could be a GIST or it could be a leiomyoma. To differentiate between the two, we did his IHC. IHC was classically positive for smooth muscle actin and desmin as seen on the left side, and it was negative for c-KIT and DOG, which is classically seen for GIST. So the diagnosis was obscure because we didn't know the source, overt because it was visible, GI bleeding with hemorrhagic shock due to jejunal leiomyoma in a patient with multiple comorbidities managed with endoscopic mucosal resection. Coming to the last case, 17-year boy with long history since 2015, first episode of acute severe necrotizing pancreatitis with fluid collection, cause being unknown, started on PERT, that is pancreatic enzyme replacement therapy. Again, 2 years later, had one episode of mild acute pancreatitis. Etiological evaluation at that time did not reveal any cause, following which he started taking complementary and alternative medicines, which he took for almost a year. At the end of that, in March 2018, again he had acute pancreatitis. However, this time he had significantly deranged liver function tests. So from March onwards till August, if you have a look at his labs, his CBC was normal, but then he had started developing thrombocytopenia. His SGOT, SGPT were markedly deranged. So in September, he had episode of urinary tract infection, and this is the time where he decompensated for the first time from liver point of view. He developed ascites. At that time, he had low platelet count, bilirubin was high, enzymes were a bit deranged, albumin was low, and INR was high. So obviously, he had started developing synthetic dysfunction from liver point of view. And his imaging was suggestive of chronic liver disease with chronic pancreatitis. So in October 2018, this is the time where I saw him for the first time. Obviously, the main issue at that point of time was chronic liver disease and not chronic pancreatitis. So we started evaluation of CLD. His viral markers and autoimmune hepatitis markers were negative. His ceruloplasmin was low, and his 24-hour urinary copper was very, very high. He didn't have any KF range. So we went ahead and did liver biopsy once his ascites had settled, and the liver biopsy was classically Orsin positive for copper, and the copper content was very high. So we diagnosed him as having Wilson's disease. Now the interesting thing here is, see, Wilson's disease as a cause of chronic liver disease is very, very rare. That is one thing. Second, this boy also had chronic pancreatitis. Now we had evaluated him for chronic pancreatitis from all possible etiological point of view, and everything came to be negative. So idiopathic chronic pancreatitis is seen in 30% of cases. However, if you go through the literature, you will find that Wilson's disease is described as one of the rarest cause of recurrent acute pancreatitis. So when these patients develop recurrent acute pancreatitis, eventually they land up in chronic pancreatitis. So and the pathophysiology is excess copper deposition in pancreas, which stimulates the pancreatic enzymes, which cause pancreatic inflammation, causing acute pancreatitis. And repeated such episodes leads to chronic pancreatitis. Now, we were very happy that we had accidentally found with a single etiology the cause of both liver disease as well as chronic pancreatitis. Subsequently, this patient was started on pancreatic enzyme replacement therapy, chelation therapy in the form of D-penicillamine for Wilson's disease, and obviously supportive therapy for chronic liver disease, chronic pancreatitis, and analgesics. With this, he started improving in his lab, clinically as well as labs. But on and off, he used to have pain. So for the evaluation of pain, he underwent a repeat MRCP, and this time, to our surprise, what we found that he had developed florid chronic pancreatitis. So this is the pancreatic duct. As you can see, it is grossly dilated, and the side branches are also dilated. And there is one small black dot which you can see, that is nothing but a pancreatic duct stone. And from here till the ampulla, that is the head of pancreas, it is absolutely strictured. So then we had to take a call, what do we do with this stricture and what do we do with the stone? Obviously, we felt that it was the stricture which was leading to the pancreatic duct obstruction, and the whole of the pancreatic duct beyond the stricture was dilated. So we thought that we would go ahead with advanced pancreatic ductal endoscopy in the form of pancreatic ERCP. Pancreatic ERCP otherwise is extremely difficult and challenging process because the duct is very small in size, and if it is strictured, it could be anything, something like size of 1 mm to 2 mm. Fortunately, we could cannulate the pancreatic duct. The wire went across the stricture, crossing the stone. So you can very well see this is the stone here. This is the wire. This is the wire. The wire has gone right till the end of the tail of the pancreatic duct. So this is the filling defect of stone. This is the dilated pancreatic duct. And from here till here, it is strictured pancreatic duct. So we subsequently during ERCP, we dilated the pancreatic ductal stricture and put in a stent. So follow post ERCP with PD duct stenting, his pain obviously decreased significantly, and then he started eating. He had good weight gain, and eventually for some time we could make him free of pancreatic enzyme replacement because his gland otherwise was not that atrophied. In the meantime, he developed cutaneous side effects of D-penicillamine. So during maintenance, he was shifted only on zinc. He then underwent 3 sessions of ERCP with progressive pancreatic duct stricture dilatation every 3 monthly. And finally, after the stricture got dilated, he underwent ESWL for pancreatic ductal stone. The stone subsequently got completely fragmented. And at the end of that, one last ERCP was done for the fragments to come out. Now the plan is he is due stent removal and stent free trial. Currently, he is only on zinc and beta blockers for esophageal varices. He is never decompensated since October 2018. However, because he had one episode of decompensation and cirrhosis, he's been listed for liver transplant, though his liver synthetic function remains stable. And he's achieved good growth post-treatment for both chronic pancreatitis and chronic liver disease. I would like to thank my whole Apollo team, each and every member who has helped in successful management of all these 4 patients. Thank you very much.
Thank you, Dr. Dhaval, for such a lucid presentation. Moving on to our next talk. The talk will be delivered by transplant physician of Apollo Hospital, Nasik. He has been graduated from BJ Medical College, Pune, and has done his MD from Government Medical College, Nagpur. He has done his DM from BJ Medical College, Ahmedabad, and is having vast experience in interventional nephrology procedures, as well as expertise in managing dialysis modalities like CRRT and SLED. Besides this, he has many award-winning paper presentation in various national and international conferences. And owing to his academic excellence and innovations, he has been awarded Young Innovator Award by American Society of Transplantation. So let's talk regarding, let's hear from Dr. Mohan Patel regarding challenges of kidney transplantation in North Maharashtra. Over to you, Mohan.
Yeah. Thank you, Kiran. Am I audible?
Yes, yes.
Hello?
Yes, yes, you're audible.
Yeah. Just I am sharing my screen. It is showing that asking for the security and privacy to share the presentation.
Click on allow over there, sir. Can I help you with
Okay.
anything, sir?
Yeah, actually, whenever I'm going to share the screen, there is one is a desktop, then keynote presentation. Then if I select keynote, then there is nothing will come.
So I guess you can go with the desktop and you'll find an option of OK at the bottom. You're using a Windows PC or a MacBook?
It's a
MacBook.
Mac.
Mac.
Okay. So once you click on the share screen, you'll find an option of desktop, right, sir? So
Yeah, desktop.
yeah. So open up your presentation first and then click on share screen and then click on desktop.
Okay. First, I have to open the presentation.
Right, sir.
Okay. Then the next click is allow Zoom to share your screen and
Right,
open
sir.
system. If I open the system preferences, nothing is coming.
You need to click on the lock button at the bottom of system preferences, put in your password and click on allow for Zoom.
No, there is a share option. Then open system preferences, then nothing comes.
Yes, there's a lock icon at the bottom of that window.
No, there is no lock icon.
Sir, you have any sharing application like AnyDesk or TeamViewer installed?
No, it's not there.
You can just simply email your presentation and we will present it for you. Will that
Yeah,
be?
that's okay.
So
Immediately I will mail you.
yeah, I'll just ask Piyush to send you the email ID. Will that be okay?
Yeah.
You can just attach it in the chat.
Yeah, you can also attach in the chat.
You can attach in chat.
Yes, sir, you can.
Okay. Where is the option of attachment?
Chira, could you give your email ID to him?
Yeah, sure. Should I just write it in the chat box?
Yeah.
Sir, please let me know once you send the mail.
I have sent the mail.
Okay, just let me check. So can you resend it again? It's not showing yet. I checked for spams as well.
Okay.
Yeah, I received it. I just received it.
Okay. Thank you.
Give me a moment. So I'm just sharing my screen, and just you can just say for next to slide the screen, right?
Yeah. Okay.
Okay. Were you able to see the screen?
Yeah.
Okay.
Yeah, good afternoon, everyone, and thank you, IMA, for giving us the opportunity to share the our work on the kidney transplantation, mainly the challenges I'm going to talk in relation to our region, Nashik and North Maharashtra. Thank you, Kiran, for the introduction. Next. We all know that burden of disease, kidney disease in India is continuously growing, and if we see the this histogram, that whenever we are comparing the India with the rest of the world, the kidney diseases are growing in India like anything, and we are almost like having the very significant number of chronic kidney disease patients as compared to the rest of the world. Next. Looking at this, the burden of disease, how many patients are actually going for the right treatment for the chronic kidney disease? There are the options of hemodialysis, peritoneal dialysis, and the renal transplantation. If we see this graph, almost 60% patients are not taking any treatment. Only 30% patients are going for hemodialysis. 5% patients are doing peritoneal dialysis. While the most optimum treatment for the chronic kidney disease is the renal transplantation, but almost 2 or 3% patients are going for kidney transplantation. That is the scenario of renal replacement therapy in India. Next. Now we have to see the age-adjusted mortality or the mortality in the chronic kidney disease patient, and we have to see the comparisons with the general population, and then we will come to know why the transplant is important. And this histogram shows us that there are 4 groups of patients, like patients who are not on dialysis but the end stage, they have not opted for any treatment like dialysis, then the patients on dialysis, then patients who underwent kidney transplant, and the general population. If we see across all the age groups, from the younger population less than 20 to the elderly population more than 65 years old, across all the age groups, patients who are on dialysis and having the end stage renal disease, they are having significantly high mortality as compared to the general population. But once the patient undergoes kidney transplant, the mortality almost comes equals to the general population across all the age groups. And this is the importance of kidney transplantation. Next. Before we go, actually, the importance, we should have the approximate cost of renal replacement therapy in our region. And we all know that hemodialysis has been covered in some of our government-sponsored health insurance scheme. So the hemodialysis, it may be free in the government hospital and the hospitals where this government scheme is available. It may cost up to 3,000 rupees a session in a private hospital. So monthly expense may go up to 5,000 to 25,000, and yearly the patient has to pay approximately 1 to 3 lakhs to remain on dialysis. And this cost is recurring, and this doesn't include the out-of-pocket expenses of as well as the caregiver burden, who has to accompany always with him to the hospital, and the lost daily wages during the hospital this hemodialysis period. Going to the renal transplantation, the surgical cost for the transplant is approximately 5 lakhs to 10 lakhs from the trust hospital to a private hospital in Maharashtra. Next. So if we see the economic wise, if the patient remains on dialysis, then he has to spend and spend and spend. So over a period of years, we will, if we see the expenditure, obviously the kidney transplantation is much economical as compared to the dialysis. And we all know that patients who are having end-stage renal disease and they are on dialysis, most of the patients do not do well more than 5 years, so which is worse than malignancy as a prognosis in the as a long-term prognosis. But as I have discussed, that renal transplantation will gives approximate life expectancy of 16 to 20 years, and the graft life is on an average is 10 years. Along with this, the better quality of life, less morbidity and mortality, so specifically cardiovascular mortality, and the other advantages of bone health and nutrition as well. So it is the optimum form of renal replacement therapy when we compare other forms of treatments like dialysis or peritoneal dialysis. Next. So when we are taking daily rounds in dialysis, and there are some touching stories in dialysis which prompted us to start the kidney transplant program here in Nashik. And I will mention a couple of stories that I will start with the one case that this is a young male around 32 years, resident of Nashik. He was on maintenance dialysis. He was interested to go for kidney transplant. He has also donor from the family, that father willing to donate. I continuously stimulate most of the patients for the transplantation, and when I inquired whether he can do he inquired us that whether he will do transplant at our center or not. This is a story in 2015 when we are not having the license to do kidney transplants. So he also mentioned that he was willing to wait on dialysis till we start the kidney transplant. This is because most of the patient has to travel a long distance for the kidney transplant, and the transplant is not a one-time process. The patient has to remain in long-term follow-up with the transplant center, and this to and fro follow-up requirements is tedious, difficult to do in the long run. That's why he said he will wait on dialysis if we get early license for the transplant. Next. The next story is also from a young male college going student. Most of the time whenever I'm taking rounds, he looks depressed and dull. Whenever I asked him that why he is not interested in kidney transplant, then he replied that nobody in his family is fit to donate the kidney. Then I also mentioned him about the registering for the cadaver kidney transplant in other centers where he can do the cadaver kidney transplant. Then he back answered to me that whether it can be reality in Nashik. As we know that organ donation is we know that there is some miscommunication around 4-5 years back, and that has stopped most of the organ donation activities in Nashik. So this prompted us to start the kidney transplant program at Apollo Hospital. Next. So we had a meeting with the administrative team and the medical superintendent. We started making the SOPs, and this we were checking whether we can do transplant. And this is from 2015. Then we registered with the National Organ Tissue Transplant Organization, which is the nodal authority in India, and we started completing. We started our homework. Next. Luckily, we got the like-minded people who joined hands with us to form the kidney transplant team. Next. And we are the two nephrologists along with me, Dr. Google. We had the very good and dynamic surgeons from the Nashik, Dr. Nandan Velekar, who is senior most, and he ready to devote his time for the kidney transplant. Along with him, Dr. Kishore Vani, we all know he is master in kidney transplant. Apart from that, we got another gem, that is Dr. Praveen Gordane from Apollo Hospital, Hyderabad. He has been trained in one of the busiest transplant center in India, and he is joined us at Apollo Hospital. Along with that, the responsibility of vascular anastomosis was taken up by Dr. Abhay Singh Walia, who is a senior most vascular surgeon in Nashik. Along with that, Dr. Milin Shah is always with us in the donor nephrectomies, and we have the anesthetic team, Dr. Chetan and Bhupesh and Amita. Along with that, we have the coordinator Charushila Jadhav. So this team, with this team, we started the licensing process in 2016. Next. The main hindrances in the licensing process is, I need to mention here that because it's very difficult to communicate with the Directorate of Health Services in Mumbai, most of the time it is a time consuming process. The reply is not they are not coming in time. We have to repeatedly pursue the our licensing process. So we got the letter that the inspecting team will come from Government Medical College Dhule, but on that date nobody arrived, and that was a no-show. That depressed us. Then we again started pursuing to DHS. Then we talked with the civil surgeon. Then DHS communicated to the civil surgeon to form a new team, and finally we got the license in approximately of 9 months of efforts. Next. Then we worked on the other difficulties for the kidney transplant. That is the most important is the drug level monitoring in the initial part of the hospitalization. That we are starting our patients on the tacrolimus and the cyclosporine. So frequent monitoring of these drugs, it's not the pathology support is not available in Nashik. Then we have to outsource to the labs in Mumbai, and the real challenge is to get the report in time, because clinically it's very important to know the level while we are doing kidney transplant. Fortunately, we got the good support from our radiology team, Dr. Harshal and Dr. Tuplonde, who are having good exposure and training during their residency in Nair and the Sion Hospital during their residency time. For the renal pathology, we have outsourced the to the Deshpande Pathology Lab, Pune. We got the good support from the Arpan Blood Bank for the blood transfusion and the other supports. The next important thing is to train the nursing and the supporting staff for the transplantation care. And this has been taken up by our quality team and the nursing superintendent, and repeatedly training is very important, because this is the area where the attrition is common. And I proudly say that we have maintained a good trained nurses for the transplant program in Apollo Hospital. We made the 2 isolation suites for the transplant with double door barrier nursing, and this way we have prepared for the kidney transplant. Next. The next hurdle is the authorization committee, or the committee who approves the kidney transplant. As per the Directorate of Health Services Mumbai, the authorization committee can be formulated in the hospital if we are doing more than 25 transplants in a year, which is difficult in our initial part. So we have to depend on the government appointed transplant authorization committee, which is based at the Bhausaheb Hire Medical College, Dhule. So this delays the authorization process, and that leads to significant financial losses to the many patients, that increases their time on dialysis. And most of the time, we are not getting approvals very regularly. Next. The next important part is the economics of kidney transplant, and this is really challenging. We have 2 types of patient. One is the poor, or the from the middle income families, for where we have to convince our management, and we till now we got the good support from the management of Apollo Hospital. Fortunately, our coordinator Charushila, she has been very actively involving the NGOs, and she's getting good support from the CM Relief Fund to economize the cost of kidney transplant at Apollo Hospital. We have the difficulties to the other type of patients who are affordable, and they always wants to go to Mumbai and Pune. But as I said earlier, transplant is not a one-time process, and they have to depend on the transplant center for the long-term follow-up. And by providing these services in the Nashik, we can definitely convince many of the patients, affordable patients as well. Next. The next very important issue is the hurdles in the donor availability. If we see the need of kidney transplantation, the most important part is the donor availability. Most of the time, there is no fit or willing donor from the family, and that is very challenging, and sometimes it's difficult to convince them about the renal or kidney donation process, because there are so many misconceptions and fear about the kidney donation. Most of the time the fear is that they will become weak, or they will have some problem, or they may need dialysis in future. The misconceptions are like that, whether they will live their normal life or not after donation. So this needs a very good counseling, then meeting the other donors and convincing them and clearing their all doubts during the counseling phase, where we all the members of the transplant team are taking great efforts to convince the donor. And the other issue is that whenever whether donor is ready, most of the time donor is ready, but we have to take the permission from the donor's next of kin. That is a requirement by the organ transplant law. The other issue is of a distant relative as a donor, where the authorization process is very stringent and it may take time because of the documentation. Also, these distant relatives are difficult to convince, and they may flee away, or they will not be ready for the kidney donation. But fortunately, till now, around 59 kidney transplant, out of which 8 kidney transplants we have distant donor, and one of our donor is sister's husband, like that is the brother-in-law. Brother-in-law is a relation where most of the time it's not always easy to convince them for kidney donation, and we had done the kidney transplant with the brother-in-law as well. Next. With all this homework and the background, I will share our first story of our first cadaveric kidney transplant. That we got a call in the midnight in the month of September 2016 for one of the patient who was enlisted, and she was a middle-aged lady. She was a general practitioner. When we got the call, we discussed with our administrative team, which was quite apprehensive about the kidney transplant, but I convinced them that we will go ahead, and I convinced the patient. Consent was taken. Then I asked the patient to come emergency for the cross-match sample. The next headache was the getting this cross-matching done in time, and we have to transport the sample to Pune in the midnight. Next, for which we asked our administrative team to give the ambulance. Next. So the next challenge was to get the this kidney, that is the organ transport, in time. Next. For this, we got the support from ZTCC and the police commissioner for the green corridor arrangements, and we got this first cadaver kidney within 3 hours from the Pune. Everybody was excited during the transplant on the transplant day, but the administrative team was still under stress because of the medical legal issues. In the past, many a time, we all know that this kidney transplantation is not always easy. So, but I assured them that we are ready and we will take the responsibility and we will go ahead. Next. And I'm glad to share that we did the first cadaver kidney transplant. We had the happy ending. The patient did very well, and still 4.5 years, she is doing very well with 0.8 creatinine. Next. This boosted us. This first cadaver kidney transplant boosted us, and then we motivated many of our patients who are on dialysis to get enlisted for the cadaveric transplants, who are not having any fit donor in their family. Then we did work about the cross-matching arrangements. We have tied up with the NABL accredited labs who are doing the cross-match. Then regularly we are getting the help from the police and the other administrative team for the green corridors. We have outsourced the tacrolimus level monitoring and we have streamlined the process to get the report as soon as possible. Also, the graft biopsy transportation we are doing, and we are getting the reports in transplant within 48 hours. Next. The next challenge was preemptive kidney transplant. So what is preemptive kidney transplant? The preemptive means the kidney transplant that is to be done before the dialysis is actually started. So what are the advantages of this preemptive kidney transplant? If we see the decreased rejection rate, the rejection is low as compared to the patients who are on dialysis, that is significant, 25%. Another advantage is the long-term graft survival, better patient survival, less delayed graft function, and less repeated hospitalization. So these many advantages of the preemptive kidney transplant, which needs a very good counseling. So we have planned for this preemptive kidney transplant. Till now, we have done 5 cases of preemptive kidney transplant, but I will mention a story from one of our difficult case. Next. So this is a case of a young male, 35-year-old, who was planned for preemptive kidney transplant. His mother was willing as a renal donor. We have submitted all the documents to the transplant authorization committee, but we got the surprising reply from the transplant committee that some of the committee members were not convinced that patient is not still on dialysis, though this is not their domain, and the committee's work is to establish the relationship and avoid the commercial angle or the forceful donation. There was no such thing to deny the transplantation, but the committee said you ask the patient and donor to go to the take the second opinion, third opinion, your kidneys are not that bad, and that surprised us. That led to patient and relatives got confused, wasted time, and then the COVID-19 pandemic started, and then all the planned surgeries were on hold, we all know, and that gives more financial burden while the patient has to remain on dialysis. Next. So we also had the recipient related challenges that when I mentioned about the preemptive. The next is a patient who is already having the epilepsy on the epileptic drugs. So this is really challenging in terms of drug level monitoring, because most of the anti-epileptics are having the drug interactions with the immunosuppression drugs, so that for which we need to modify their anti-epileptic doses to evaluate thoroughly with the help of the neurologist, and there we did such patients. The next two challenging cases was recipients having the history of pulmonary COX. Similar to the epilepsy, the most of the drugs like rifampicin has a very significant drug interaction with the tacrolimus cyclosporine, and that needs to be modified. The anti-tubercular treatment needs to be modified, and the patient has to be treated first. But we have done such similar cases after the 6 weeks of anti-tubercular treatment, and patients are doing well. Then we had one patient with very low platelets, where surgically it may be difficult, as well as we need to evaluate thoroughly him about the why. We have involved the hematologist, done the bone marrow, and treated the megaloblastic picture, and then we have done the kidney transplant. Similarly, recently we have done one patient who underwent CABG. Ejection fraction was around 30%, and he underwent kidney transplant, and he is also doing well. Recently, we have done 2 pediatric kidney transplant, which is a surgically really challenging to do the vascular anastomosis, as well as keeping the graft, making the space for the graft in the pediatric patients. We also recently done one patient who had COVID infection, and after recovery from the COVID, after 2 months, we have done the kidney transplant. Next. The important part of donor nephrectomy is the cosmetic scar, because most of the time in India, the donors are female, and to convince them, because there is a fear about the scar, sutures, how many sutures, these are the questions while we are convincing the donors. When 3 years back, we started the laparoscopic donor nephrectomy, which is the standard of care in kidney transplant. This laparoscopic donor nephrectomy improved the donor outcome with less pain, shorter hospital stay, cosmetically minimal scar, and this is a one step ahead, which can boost the kidney donation in our region. But this needs a very good surgical expertise, and we all know that learning curve for the surgeon is there, but we got the good surgical team, and Dr. Kishore Wani is doing very a fantastic laparoscopic donor nephrectomy at our hospital. Next. Then coming to the general scenario about the cadaver and the living related transplant program. So for the cadaver transplant program, what are the main hurdles? If we see in general, then lack of awareness about the organ donation. We all know now government has taken many steps. Even the IMA has taken the step about the organ donation awareness. So slowly and slowly we are doing more and more awareness in our region, but still there is an absence of state or national level cadaver program which will support this organ transplantation in our region. Another is the physician's inertia when the patients are there in the ICU to make out the patients who are having brain death or close to the brain death and evaluating these patients. So that inertia, I think slowly it will go away, and in the near future we will see more and more number of organ donation in our region. Next. The main hurdles in the living donor transplant is the most important from the nephrologist perspective is the delayed referral to the nephrologist. So this delayed referral is most of the time leads to fear and misconception about the options of renal replacement therapy in these CKD patients. Another important is the donor safety, which I have already discussed about the donor safety issue. But we should have this rule of 30-20-10 for CKD patients. When the GFR is around 30, we should educate the patient and explain them about the renal replacement therapy. When the GFR goes down, we should prepare them for the dialysis with the fistula creation. We have to advise them. But when the GFR is 10, we have to give them the option of either dialysis or the kidney transplant. Next. How much time is remaining, or otherwise I will skip some slide.
5 minutes.
Okay. So before that, I will mention some of the important views of society about the diseased organ donation. This is the philanthropic activity by the society, for the society, through the hospital and the government infrastructure. Next. So we have carried out a survey, and I have presented this paper in the International Transplant Congress, that why there is a poor organ donation rate in our area, with a survey mainly focused on the way of thinking and the orientation among the health check attendees and the dialysis patients' relatives. Next. So I will summarize the from this paper. The most of the time, what is the society, or what this the survey showed us, that lack of awareness is the predominant problem. Then the next problem is the socio-cultural factors. Socially, they may not accept always, because whenever there is an organ donation, counseling is there. That time most of the family members are in grief, and it's very difficult to counsel them as well. Then there are some religious factor as well. Some people are having the faith in rebirth and all that, so we need to properly counsel them. We may need to get the support from the religious leaders sometimes. Then there is most of the time some of the participants in the survey, they have inquired about the organ allocation system, whether it is transparent or not, whether they will these organs will be properly used for the needy persons or not. Then about the awareness about the organ donation laws. What are the laws? Who can donate? And who will get the organs. So awareness about the law is also lacking in our region. Then brain death concept. Everybody is aware about the circulatory death concept, that is when the heart stops. But the brain death concept needs to be that needs to be, we need to work on it. We have to convince the relatives about the brain death concept before the heart stops. Next. Then what the patient think about this organ donation? I just mentioned that their main concern is the transparency in the organ allocation policies. Then organ quality is also important. Whether they will get a good kidney or not, that is also their concern. Then affordability is a right of every patient, that we should make this transplantation affordable, and we are continuously working on that with the help of NGOs as well as getting the funds from the government or the CM Relief Fund. Most of the time, donor surgery may not get the insurance coverage, and that we got such reply from the insurance team that the donor surgery is not covered, and so we have to increase the insurance coverage, or this is a scenario in India where most of the time this organ transplantation will get some difficulties because of the insurance coverages. Next. Then what the medical fraternity has in mind while starting the kidney transplant program, whether the program is viable versus the profitability, how much profit they will get. But definitely we have to balance the things. We have to, in transplant program, we need to devote more time, and I think profitability is less. Organ retrieval and maintenance is also, because this is the, if some brain dead donor is there in the ICU, once the consent has been given, this maintenance cost needs to be adjusted, and that needs to, we need to get support from the ZTCC to have this maintenance cost. Then the organ transportation is a new headache, because most of the time we are connected by roads only. Other means of transportation is not that available in India. So we need to continuously depend on the green corridors. Then infrastructure development, developing the isolation suite, training the staff, and the other legislation and the organ allocation policies. Next. Next. I will skip this. Next. Yeah, coming to the media, we know media is a double-edged sword, and the entire concept of organ donation is built on the trust into the system of about the organ donation and allocation. Any negative idea which breaks this trust have very negative impact on the whole process, and the media should be actively involved to increase the donation awareness regarding the concept of brain death among the general population. Next. This is a new concept, that is donation after cardiac death. This is gaining much interest in nowadays, but still in India, it has not been systematically implemented. Because donation after cardiac death is very easier concept to be accepted by the family members, that is the after circulatory arrest, and this can be a major source of organs if implemented correctly, because it involves a very timely process to retrieve the organs. Next. Another way to increase the transplant program is the living donor. Most of the time, ABO incompatibility is the most common reason to reject the living donor. Next. For which we have to give them the option of swap kidney transplant. By giving them the kidney pair donation, we can increase the possibility of kidney donation by 35%. Next. That if we are having one pair having blood group A and the donor is B, then we can exchange these organs between these two pair, that is called as swap kidney transplant. Next. I am glad to share that in the last 4 years we have done 50 kidney transplant. Next. Out of which around 16 are cadaveric kidney transplant and 43 are live kidney transplants. Next. This has some issue, but renal donors, this is gender wise donation. 80% donors are female. This is the our society's view that most of the time either mother, sister, auntie, or somebody from the family. That is, females are always coming first for the kidney donation, and for that our ZTCC has taken a very good step to giving one more point to the recipients who are on dialysis and they are female recipients. Next.
Mohan, 1 minute, please.
Yeah, I am close to near to close. Next. So I'm also glad to share that we have done the fastest first 50 in the last 4 years about the kidney transplant. Next. We have done first successful pediatric kidney transplant as well. Next. This is our team with the 9-year-old child who was suffering from IgA nephropathy, and then father was not fit to donate. Then the grandmother came forward to donate the kidney. He has completed 6 months and he is doing very well. Next. These are the our post at the celebration, that is post transplant discharge celebration. Next. This is the organ donation awareness activities which we have taken and actively participated in Nasik. Next. We have celebrated the World Kidney Day with the Namita Kohak, who is Mrs. International. We are continuously taking such activities to increase the donation in our region. Next. So we have pioneered the cadaver and live kidney transplant program successfully in our region. We have good results, least complications, and we have also started the laparoscopic donor nephrectomy. And now next challenge is the new challenge is that we are looking ahead with the ABO incompatible kidney transplant here in Nasik. We are doing actively registration for this swap kidney transplant program. We are talking with one of the genetic lab here in Nasik to start the HLA and CDC cross match. We are also asking our pathologist and whoever from the Nasik who is ready to devote time. There is a good program from International Society of Nephrology for the renal pathology training, which will boost our program. Then along with my colleagues, Nephrology Society of Nashik, we are talking with the Directorate of Health Services to form ZTCC for Nashik and North Maharashtra to reduce the time to get the organs, as well as to increase the more awareness about the organ donation in our city. Thank you for your patient listening, and I think the session is open for discussion. At the end, I will. This is my mentor, Professor H.L. Trivedi, who is popularly known in India as a father of kidney transplant. He is continuously stimulated us to start the transplant program here in Nasik. Thank you.
Thank you, Mohan, for such an elaborative talk. Thanks a lot.
Yeah, thank you.
Moving to our next topic, which will be delivered by my friend and colleague, Dr. Dinesh Wak. He is Senior Consultant in Critical Care and Chest Medicine, Sahyadri Hospital, Nasik. He has done MBBS from Dhule and did DTCD from BJ Medical College, Pune. And later on, he did IDCCM from Dinanath Mangeshkar Hospital, Pune. He has 12-year experience in critical care with special interest in ARDS, sepsis, and sleep medicine. He is also a recognized guide for ISCCM. Over to you, Dinesh.
Thank you, Kiran, for such a nice introduction. And on outset, I must thank IMA Nashik for giving me this opportunity to deliver the talk in this Refreshercon. Yeah, the nutrition in ICU. always neglected topic, but so important. As we are going through the tough time of COVID, and this tough time, always we had the question in our mind that what can we do for these patients? When COVID started, the most important question, what are the treatment modalities which are available with us? And ultimately, we came across the only two answers, that those were, one is, first important is rest, second is adequate nutrition, so that we can have a better immunity to fight with this virus. Today morning's today morning's experience with me, I had a patient in my ICU who was on ventilator after COVID since last almost after 20 days, and he had a bad ARDS and he was about to sink. He was in sepsis, and relatives asked me, "Sir, what can we feed to our patient?" Yes, really nutrition matters that much. डेली आपण बघतो आपल्या आयसीयूज मध्ये किंवा आपल्या ओपीडीज मध्ये, एव्हरी टाइम पेशंट्स रिलेटिव्ह हॅव दिस कन्सर्न हाऊ अँड व्हॉट दे शुड फीड टू their patients. Yes, this is very important. In this practice of medicine has never been so complex. We are flooded with technology, information, conflicting views and opinions. Evidence-based medicine is the current cataphrase, as evidence is so conflicting and confusing. A patient-centric approach is clearly needed for optimal investigation and cost-effective management of the patient. We all know that this is this mnemonic for hello. We all are aware of this mnemonic, fast hug BID. This is the first thing which we do in our ICU while giving care to the patient. What I mean by fast hug BID: feeding, analgesia, sedation, T for thrombosis prevention, head inhalation, gastric ulcer prevention, glucose, bowel whether it is opened or not, de-escalation of antibiotics and invasive lines. So what comes first when you are giving care to your patient is feeding. So one must be aware of what kind of feeding they are giving to their patient and how much feeding they are giving to the patient, and whether that feeding is adequate for their nutrition. Usually when patient comes to you, he had symptoms. This is a classical story. He goes to clinic, he's been investigated, diagnosed, he gets admitted into ICU, where he gets admitted in a hypercatabolic state, and ultimately in due course of time he recovers and get discharged. So this is a phase of hypercatabolic state which is very important, wherein we provide everything to the patient, but usually most of times people do neglect about the nutrition of the patient. So we will go with this 5 W's, 5 questions to our mind. Really, who should be nourished, who needs the nutrition, why he needs the nutrition, how much someone will need the nutrition, what kind of nutrition we should provide them, and where we should provide them. Okay, so whether this fellow who is young and quite healthy looking patient, if he gets a trauma, or if he gets some surgical intervention and he gets admitted inside the ICU, whether he will need the nutrition, or this cachectic person who is already on a bed, obviously looking malnourished, whether he needs the nutrition. Yes, surely everyone, all patients who gets admitted into critical care environment needs the nutrition. Around 30 to 60% of patients have some degree of malnutrition on admission to the hospital. Around 20 to 25% patients who are severe, out of which 20 to 25% are severely malnourished. Nutritional status usually worsens after hospitalization. Around a patient, if we see a patient who is admitted inside the ICU, will lose around 1 kg lean body mass per ICU day, and will end up in losing around 20 kg lean body mass in next 23 days. So that much it is important. What are the consequences of the starvation? Usually the starvation, it causes reduction in the organ mass except brain. Catabolism of the stress causes acceleration of breakdown of lean body mass, release of amino acid for gluconeogenesis and vital protein synthesis, depletion of visceral protein, reduction in the capacity to endure the stress, and ultimately reduction in the immunity and reduction to the resistance of the infection, and ultimately secondary infection and death. Pure starvation will make the patient to survive for 2 to 3 months. While if starvation is combined with the stress or injury or critical illness, survival time is almost halved. So it is very important to understand that whether patient is adequately been nourished or not inside the ICU. It has negative effect on mental as well as physical health. It is associated with increased complication of illness, increased mortality, increased hospital stay, as well as increased healthcare cost. What are the specific metabolic complication changes which happens during starvation? During starvation, your glucose metabolism gets disturbed, wherein your insulin resistance increases. That's why along with the increase in glucose synthesis, which ultimately leads to the hyperglycemia. As we don't have the energy to provide, so ultimately body finds out its way for the energy. It causes the proteolysis, which will ultimately causes gluconeogenesis and rise in the cytokine. Fats, which are the store of our energy, will get into lipolysis. Glucose replaced by the fatty acids and oxidative fuel, and ultimately patient will develop the ketosis. Malnutrition will also impact our mucosal barrier, gastric GI mucosal barrier. It will reduce your local immunity. It will reduce your absorption and ultimately propose your patient for the microbial translocation and secondary bacterial infection. Most of time, it is very important to distinguish between the effect of improper nourishment and the effect of catabolic disease when a patient is when we are assessing the nutritional status of the patient. Why patient needs the nutrition? There are a lot of studies which are actually supporting this. Why? Length of stay is increased when patients are malnourished, whether they are in ICU or whether they are in wards. So length of stay will increase. Length of stay as well as mortality will also be increased. There are multiple multi-center cluster randomized trial which were organized, which are supportive of this, that length of stay as well as mortality will increase if you don't have the adequate nutrition. This is a famous study in 2005 Europe studies, wherein they have observed that all non-infectious complications, infectious complication, as well as death and median length of stay are more in a patient who are at risk of hyponutrition. How much? So we came to know that whether it is really necessary. Yes, it is necessary because it has a lot of impact on patient outcome. It will increase the infectious complication. It will increase the death in the patient. It will also increase the length of stay of the patient inside the ICU. Then how much nutrition should be provided to the patient? This big elephant will need just 14 kilocalories per kg per day, while this little mouse will need around 170 kilocalories per kg per day. Similarly, a young newborn baby will need around 120 kilocalories per day, while a young male will need around 25 kilocalories per kg per day. So how much for this fellow who is already cachexic, who is in a hypermetabolic state because he's been admitted in the ICU. So how much he will need? He is a so malnutrition occurs almost up to 40% of hospitalized patient. How to calculate this? First of all, we will have to do the nutritional assessment of all the patients who are admitted inside the hospital. It should provide the picture of the patient's current nutritional status as well as what and how the present clinical condition is going to add on to their outcome. So history is very important. Physical examination, anthropometric measurements, and biochemical data are useful for the nutritional assessment. There are no single tests which are available which can provide the enough information to assess the patient nutritional status adequately. So from information obtained, a plan for the patient is formulated. The plan must be individualized to meet the patient's requirement for protein, energy, and nutrients. It should also include the goal for nutrition intake and most appropriate route of feeding, formula composition to achieve these goals. In stress patient, the goal is usually to prevent the further depletion. So nutritional assessment, as we discussed, it should be with the history. Dietary history is important. How much weight loss is there in last 6 months? If more than 15% of bodily loss of body weight, then it is significant. Then physical examination is very important. Depletion of subcutaneous tissue, then peripheral edema or ascites showing hypoproteinemia, signs of hypoproteinemia, some signs of vitamin deficiency one has to see. Then anthropometric examination, wherein BMI calculation, tricep skin fold measurement, then mid-arm circumference, bioelectric impedance, all these will add on to the nutritional assessment. While to support this, we will have the lab investigation like albumin, pre-albumin, transferrin, and total lymphocyte count. Body mass index, we can calculate with the height along with the weight of the patient. If someone has, we all are aware of this criteria of obesity to mild to severe malnutrition. If your BMI is less than 16, it is severe malnutrition. So once we are aware of this, how much patient is malnourished, whether patient is obese, then one has to categorize this patient into a 5-step screening tool, so that we can plan how we should monitor this patient. This is a malnutrition universal screening tool which was designed by the Malnutrition Advisory Group of British Association of the of Parental and Enteral Society, wherein they have devised this core into 5 steps, where one is BMI. If patient's BMI is more than if less than 20, if it is between 20 to 30, then it is 0. If it is less than 18.5, then it is 1, 2, and 18.5 to 20 is 2. Similarly, weight loss score, if it is more than 5% of weight loss is there, then it is around 1. And if along with the acute severity disease score, if it is acute severity is there, then it should be around 2. Add scores together, calculate the overall risk of malnutrition. If it is score 0, then low risk. If score 1, then medium risk, and score 2 is more at risk. It means almost moderate risk. So those patients who are at low risk will need repeat screening on weekly basis if patient is hospitalized. Mild, medium risk, then patient will need a reassessment on day 3rd of the admission. This reassessment has to be done by the dietitian. If patient is at high risk, then patient should be obviously deferred to the dietitian, and along with the consultation of dietitian, one should implement the local policy. How to calculate? We know that now we came to know that who are at low risk, who are at medium risk, who are at high risk of malnourishment. Then how to feed these patients? So caloric requirement can be calculated, means nutritional goal can be calculated according to the patient's weight. So simple formula, that is Harris-Benedict equation, is very important, which will give us the Harris-Benedict equation will give us the basal energy expenditure by the person. This basal energy expenditure is a resting energy required for a person who is admitted inside the hospital. On top of that, if person has some activity factor, then that factor we will have to calculate and add on to this basal energy expenditure. On top of that, if someone has some major health issues like surgery, infection, trauma, ICU care, then one has to add on that factor. And accordingly, we can calculate the total energy expenditure which is there for one patient. So if we came to know that what is a basal energy expenditure, then we can plan patients' caloric intake by the different foods. How much is the fluid requirement? According to the calculation, around 30 to 35 ml of fluid per kg body weight is required. Protein requirement for maintenance is around 0.5 to 1 gram per kg, while moderate stress it is around 1 to 1.2 gram per kg, while in severe stress it is 1.2 to 2 gram per kg body weight. In critically ill patients, the caloric expectation out of 1 gram nitrogen is around 80 to 100, while in non-critical it is 150 kilocalorie. So on roughly, a patient who is admitted inside the ICU will need around 30 kilocalorie per kg per day, with protein requirement of 1 to 2 gram protein per kg per day. So what? So adequate nutrition is required to the patient. How to feed this patient? how to give the feeding to this patient. Energy supplying nutrients are again divided into macronutrients and micronutrients. Micronutrients will not supply the energy, while macronutrients like fat will provide around 9 kilocalories per kg per gram. Proteins will provide around 4, and carbohydrate will provide around 4 kilocalorie per gram. And water and electrolytes are important. Okay, so we came to know that for this person who is bedridden, 30 kilocalorie per kg per day is needed. And okay, so roughly around 25 to 30 kilocalorie per kg per day is a need of nutrition to a person who is admitted inside the hospital or ICU. Nutrition. So how we will provide this nutrition? Means there are ways to provide this nutrition. Patient may eat through the mouth. We might have to put in the nasogastric oral feed, or patient may at times his GI may not be working, so we will have to provide them this nutrition by parenteral route. So enteral route for the nutrition, and second is the parenteral route for the nutrition. Enteral route is one wherein we use the gastrointestinal tract for providing the nutrition. Parenteral is one wherein we use the non-gastrointestinal tract, that is IV IV nutrition. So, okay. So what are the indications of enteral nutrition? When your gut works, always use it. So all those contraindications for parenteral nutrition are the indications for the enteral nutrition. So whenever we get a chance, in all ICU patients, we should see to it that they should receive their nutrition only as much as possible through the enteral route, unless and until there is any contraindication for the enteral feeding. So how we can achieve this? There are different ways. Either patient can eat directly from mouth, or some patient may need the nasal tube, which can go into the gastric or duodenal area, and some patients might be on long-term basis for enteral nutrition, wherein we can find out the way by percutaneous enterogastrostomy or percutaneous enterojejunostomy or jejunal feeding may be adequate for these patients who have these long-term access. So when it works, use the enteral access, but yes, it has also some potential complication like clogging, bending, dislodgement, tube damage or migration, at times stomal leakage, wound infection, and volvulus. So at these, when it is not possible to give the enteral nutrition, then maybe we can feed this patient with parenteral nutrition. So what is mean by parenteral nutrition? Delivery of nutrients intravenously via the bloodstream. Either it can be given by central venous access or peripheral venous access. So when it is given through central venous access, complete nutrition is provided, then it is called as a total parenteral nutrition. Okay. So what are the advantages of peripheral venous access for nutrition? So there are advantages like benefits, like it doesn't need any kind of central access, which has a lot of other risk. It is simpler and quicker. It doesn't need any central venous access. It doesn't need any chest X-ray. There is no need of the catheter related. There is no risk of catheter related sepsis. It also lowers the risk of complication, and it is more cost effective. While the disadvantage is that we cannot go beyond 800 to 900 milliosmol osmolarity of the fluid, so that there might be some limitations while feeding these patients through the peripheral venous access. While central venous access, which can be access can be taken via subclavian vein, or it can be taken from this cephalic vein or through the brachial vein, or at times we might have to get the tunnel catheter for long-term parenteral nutrition. So common indication of parenteral nutrition: patient who has failed in enteral nutrition with appropriate tube placement, severe acute pancreatitis, severe short bowel syndrome, mesenteric ischemia, paralytic ileus, small bowel obstruction, GI fistula unless enteral access can be placed distal to the fistula, or where volume of output warrants the trial of enteral nutrition. What are the complications of parental nutrition? Yes, access related. So it is central catheter which is needed. It can cause thrombophlebitis, catheter occlusion, or maybe it may cause access related pneumothorax. Okay, metabolic like hyperglycemia, it can cause the alteration in the LFTs, fluid retention, or sometimes excessive CO2 production also can be caused. Which means both have got their own merits or benefit. It is not, it is really a meaning, whether it is a meaningless debate whether we should go for enteral, it is preferred over parental. Yes, it has got every means enteral and parental should have been complementary tool to the each other. So there are problems with the enteral nutrition in ICU. Patients may develop the vomiting, or they may have the increased gastric residual volumes. They may develop these are the common problems which we see in our ICU: vomiting, increased gastric residual volumes, severe diarrhea, fear to induce the intestinal complication like perforation, sometimes poor protocol implementation, and ultimately this will cause the undernourishment of the patient and inadequate nutrition. Yeah, I can. Sachin. So problems in with achieving enteral nutrition goal, as we see it, as we saw that these are the various problems, and ultimately, Sachin, next slide new. Ultimately, it leads to inadequate delivery of enteral nutrition, which is very common. And frequent problems are associated with this delivery and tolerance of enteral nutrition. And discrepancy exists between the targeted calories and actually received calorie. So that's why the issues which happens, adequate nutrition is not possible, and this adequate nutrition which might get you home early, which has lot of effects on the patient outcome. Nutritional adequacy is associated with improved outcomes. There are a lot of studies which support this. Adequate energy and proteins are associated with decreased mortality in critical illness. So adequate nutrition is important, and which may be lacking while patients are completely given enteral nutrition in certain patients, where a lot of issues may arise in due course of time, and ultimately patient end up with poor nutrition. Nutrition is preferred route, but is often poorly tolerated in ICU patients with GI dysfunction. Therefore, early supplementation of parenteral nutrition must be promptly initiated so as to prevent the underfeeding effects, the resulting energy protein gap associated with the complication. So this was the Lancet paper which I found, how we can actually decide whether patient will need addition of parenteral nutrition for their to meet their residual energy expenditure. So if someone who is able to match with their residual energy expenditure more than 50%, if yes, then there is no problem, continue with it, and gradually we can increase the nutrition which is supplied with the enteral route. If patient is not meeting to around, if the able to match with the 50% of energy caloric requirement which is there, then yes, then one has to see whether there are any contraindication to the enteral nutrition. If no contraindication, and if then one has to see whether they are high risk for malnourishment. If yes, then watch them for next 3 to 4 days. If still there are contraindication for enteral nutrition, then one has to add on the parenteral nutrition. If somebody has no contraindication for malnourishment, then one can wait for again 5 to 7 days, reassess the patient. If we are able to achieve the goal of more than 50% of residual energy expenditure, then one need not to be thinking about the parenteral nutrition. This is about when there are no contraindication. There are contraindication to enteral nutrition. If there are no contraindication to the enteral nutrition, then start enteral nutrition. Gradually increase the infusion rate to target the 25 kilocalorie per kg per day, and optimize the delivery of agent post pyloric tube. If patient is malnourished and you are not able to meet the more than 50% of residual energy expenditure, if he is malnourished, then one has to think over the addition of the parental nutrition. Okay, so in certain situation, one has to think over what and how we should modify our nutrition. In patients who have the renal complication, one has to reduce the fluid and use the high essential amino acid solution. Adjust the glucose for the dialysis, because most of the patients who are on dialysis, they may develop the hypoglycemic events more frequently, and that will be very hazardous for the critically ill patients. If patient is having hepatic involvement or hepatic failure, and one has to see that they should receive at least 150 gram of glucose per day, that is around 600 kilocalories per day by the glucose only. Use cautious use of amino acid, use high branch chain amino acid, so that we can have the better hepatic protection and we can treat the hepatic dysfunction also. While in cardiac patients, restrict the volume as much as possible if they have the failure component. Reduce the sodium component inside the diet. Add potassium, because potassium and magnesium are usually get excreted because of excessive use of diuretic while in patients who are on failure. Monitor potassium if potassium is low, because most of the patients are on life-saving drugs like digoxin. So one has to see that also. If patient is a pulmonary patient, then this is specific certain modification which we will have to do. Many times these modifications, many patients, many intensivists may not get the time to see all these modifications. So one has to always have, this is my request to all of the doctors, that whenever we are seeing a critical patients or whenever we are running ICU, one has to have a dietitian on panel, so that we can get this proper scientific backup from the dietitian and we can concentrate on the other part of patient care, because diet and nutrition is very important part of the patient care while patients are in ICU. Those patients who are diabetic, add insulin, because hyperglycemia will again increase the risk of infection. And there are certain new substitutes which we can actually use, like arginine, which promotes the urea cycle and stimulates the anabolic hormone secretion, which increases the T cell activity, which will help to increase the certain amount of immunity. Glutamine for the gut mucosal integrity as well as better nitrogen balance and fuel for the cell of immunity. Omega-3 fatty acids balances the pro-inflammatory and anti-inflammatory balance, so that it can help us in treating this patient. Nutrition is a continuous process. One has to see that every patient should get the adequate nutrition. So whenever patient is admitted, first step is to assess the nutritional status, analyze the patient's assessment data to determine the nutritional requirement, as we saw there, where we will have to categorize the patient whether they are at a high risk, moderate risk, or they are at zero risk of malnutrition. Analyze this data and determine the nutrient requirement according to their body weight and all those formulas which we discussed. Develop a proper nutrition care plan according to the disease and disease process. Implement this plan, care plan, and evaluate this plan on regular basis. And this is a regular process wherein one has to do this on regular basis. Daily, every third day, we have to assess this plan, again modulate this plan and reevaluate this plan and adjust this plan. There are how much time we have? Yeah. So there are certain bullet points which I want to give you in a short. These are SPEN guidelines, European Society of Parental Enteral Nutrition guidelines 2018, wherein they have mentioned very specific points which we have to take it as a take home points. There are 5 to 6 slides, but they are quite congested, but I will try to make them as simplified as possible. Okay. Okay. In general, all patient needs the clinical assessment. Every critically ill patient staying for more than 48 hours inside the ICU should be considered to be at risk of malnutrition, and they should be Sachin, याला थोडं बाजूला काढ ना. Every critically ill patient staying for more than 48 hours inside the ICU should be considered at risk of malnutrition. Early and progressive parenteral nutrition can be provided instead of no nutrition in case of contraindication to the enteral nutrition in severely malnourished patient. See, I'm saying this is for severely malnourished patient, not for routinely parenteral nutrition is indicated unless and until 5 to 7 days are there over. Okay, to avoid overfeeding, early full enteral nutrition and parenteral nutrition shall not be used in critically ill patient, but shall be prescribed within 3 to 7 days. Continuous feeding rather than bolus enteral feeding should be used. Means there are bottles which are commercially available. Again, there are questions about whether we should use the kitchen feeds or commercially available feeds. Each one has got their own advantages and disadvantages. Commercially available feeds have got the better infection control properties, while kitchen feeds might have that, might be losing that. While kitchen feed are well tolerated by the patient, sometimes commercially available feeds are not tolerated by the patients. During critical illness, around 1.3 gram per kg protein is equivalent to the equivalent per day can be delivered progressively. IV lipids should not exceed more than 1.5 gram lipids per kg per day and should not be accepted to the individual. It should be accepted, adapted to the individual tolerance. Amount of parenteral glucose or carbohydrate administered to the ICU patient should not exceed 5 milligram per kg per minute. Then in non-intubated patients with dysphagia and very high aspiration risk of post-pyroric enteral feed, if possible, temporary parenteral nutrition during swallowing training with removal of nasoenteral tube can be performed. In case of an unrepaired anastomotic leak or internal or external fistulas, if distal feeding access is not achieved, then enteral nutrition should be withheld and parenteral nutrition should be commenced. Okay. So guidelines for the parenteral nutrition in surgical patient, just hold on. So post-operative, pre-operative parenteral nutrition is indicated in severely undernourished patients who cannot be adequately orally or enterally fed. So grade A evidence, post-operative parenteral nutrition is indicated in undernourished patients and patients with complications when oral and enteral feeding is not possible for at least 7 days. Combined enteral and parenteral nutrition is recommended if enteral nutrition cannot provide more than 60% of energy needs. 3-chamber bag are recommended in order to provide the parenteral nutrition mix simultaneously over 24 hours and are suitable for the majority of the patients. It will reduce the handling of the central line, as well as it will reduce the infection rate. The optimal parenteral nutrition regimen for critically ill patients should include the supplementation of N3 fatty acids. When total or near total parenteral nutrition is required, micronutrients should be provided separately. Thank you. I think I have covered most of the things in my talk. If someone has any questions, so my request, my experience is that dietitian and nutrition makes an important part of critical care, and one has never to look over this part of nutrition whenever we are treating this patient in critical care areas. Thank you.
Thank you, Dinesh.
Yes.
Thank you for such nice, informative, and elaborative talk on this complex issue of nutrition in critically ill patients. I invite Dr. Abhishek Pimparalekar for next talk. He has done his MBBS from Pravara Medical College, Loni, and post-graduation MD from Municipal Corporation Hospital, Rajawadi, Mumbai. So he is presently senior consulting physician at Sahyadri Hospital, Nasik. We will be talking on infection and glycemic variability. Over to you, Abhishek.
Good afternoon, everyone.
सर तुमच्या इथे अजून एक डिव्हाइस लॉग्ड इन आहे झूमला, तो म्यूटवर टाका प्लीज.
Am I audible?
Yes sir, you'll have to mute the audio from the other device, not just the mic, the speaker audio as well.
No.
No, we can still hear an echo. This is better. Okay.
Good evening, everyone, and I would really like to take this opportunity to say thanks to IMA President Sir and Sahyadri Hospital for giving me this platform to share my views on a very important topic. Earlier, I was thinking to share the views, or rather than having a good topic like glycemic variability only in COVID zone. But then given a deeper thought that glycemic variability is something we as physicians face almost on the daily basis, like if we are treating a critical patient in ICUs, like if we are treating a patient of uncontrolled diabetes mellitus on OPD basis, and not only in COVID situations. So otherwise a very vast topic, and not much of a case-based approach, because it's something that we face on the daily basis. So so my perspective was about the glycemic variability is like to keep it about the infections. If we talk about the infections, then we have various sorts of infections that come across our ways on daily basis. Like in respiratory, we like go through the streptococcus pneumoniae infections, H1N1, tuberculosis. In urinary infections like asymptomatic bacteriuria, fungal cystitis, perinephric abscess, bacterial pyelonephritis, whereas in gastrointestinal it has to be H. pylori infections, invasive esophageal candidiasis, hepatitis C, hepatitis B. Where are other skin infections like cellulitis, necrotizing fasciitis, and of course is like invasive fungal mucormycosis infections, and external otitis media, and other infections might include human immunodeficiency viruses as well. So to begin my talk on as per the glycemic, so as we go through all these infections, my perspective is like most of the times the approach remains the same while we are treating it. So as we go through the glycemic variability aspect of these topics, the basic focus is on the management. So next slide. Yeah. So as far as the management is concerned, so various severe pathological, let's go through the definition. Yeah, so glycemic variation, the definition includes that the postprandial hyperglycemic excursion, it contributes to glycemic variabilities and various occurrences of various, the occurrences of various microvascular and macrovascular complications in diabetes has been attributed by various studies to hyperglycemia and dysglycemia. Whereas several pathophysiological mechanisms were put forth in unifying the two mechanisms as far as the pathophysiology of the glycemic variability is concerned, that excessive protein glycation end products and activation of oxidative stress in the causation of vascular complication respectively. So in vitro and in vivo data, both sorts of data have present the same mechanisms that are the basis of adverse cardiovascular effects of glycemic variability, which are mainly associated with oxidative stress. And definitely is like the significant association between the glycemic variability and the increased incidence of the hypoglycemia has already been noted. Pathophysiologically, again, another aspect is that sympathoadrenal response during hypoglycemia and adrenaline secretion may induce the arrhythmias and increase the cardiac workload, producing the many catastrophic conditions across the hospitals and in any other setups. So underlying endothelial dysfunction also leads to the contribute to the cardiovascular risk. So evidence appears to be highly suggestive of glycemic variability being an important key determinant of vascular damage. So as far as the management part is concerned, so in hospital setups we deal with many things, is like, but insulin is the only thing that is been of not of any concern when we talk about the glycemic variability is concerned, because as far oral antidiabetics are not to be considered in this kind of scenario, particularly in critical infections, because if we talk about the various compounds, or if we talk about various oral antidiabetic agents, then metformin is something causes the lactic acidosis and worsens the hypoxia. SGLT2 inhibitors like increases the dehydration and can worsen the acute kidney injury in case of multi-organ dysfunction syndrome. Sulfonylureas cannot be used because it's like hypoglycemia, the risk of hypoglycemia is more. Pioglitazone is responsible for worsening of the infections, especially in COVID-19 through the expression of ACE inhibitors. GLP-1, because of its gastrointestinal side effects, might lead to the catastrophic effects like aspiration pneumonia, and definitely considering these more side effects. So when it comes to the glycemic variability in infectious disease in critical care setup, so the only last resort that remains is insulin. Now again, in insulin there are various factors like basal insulin and bolus insulin. So in so short-acting insulins like bolus insulins are very rapid in glycemic control, as we all know, and most preferred since past so many years. And a lot of things have been said and researched about it. So the focus is more on the use of basal insulin and particularly combined with the bolus in managing critical patients with glycemic variability. So this is what we've been observed throughout the 8 months while we treated COVID as well, and also in the difficult case scenario like septic shocks and other infections while we treated them in the ICU. So we will be talking on aspects of addressing glycemic variability and time in range with insulin therapy, second generation basal insulin as suitable option to address glycemic variability and time in range, comparing second generation basal insulin in the light of glycemic variability and time in range. So as this talk will be more on the research base rather than a little bit of practical things, and is more of a theoretical aspect of the topic given. So can basal insulin effectively address glycemic variability? As you say, the glycemic variability is the various peaks and the troughs throughout the day in 24 hours that happens in type 1 and type 2 diabetic patients. So definitely the main target while we treat is glycemic variability is to minimize the importance of minimizing the variability by noting the peak of the blood sugar levels and the trough in the blood sugar levels by using continuous glucose monitoring. So through the peaks that are caused by glycemic excursion in post-meal, basal insulin, glargine particularly, effectively controls postprandial glycemic excursion by hitting the base of fasting and offers the flexibility of using postprandial glycemic targeting oral antidiabetics. So as far as troughs are concerned, is like we need to be a little careful about the hypoglycemia, the nocturnal hypoglycemia, considering the endothelial damage and various kind of cardiovascular involvements. So we so with the help of glargine on any sort of basal insulin, the risk is a little bit on the lower on side. So keeping apart the more critical and the infectious part, the basal insulin, the second after metformin and control type 2 diabetes, is like as per the protocols. Apart from lifestyle modifications, and when we talk about the routine patients or the routine OPD based patients or patients who are non-critical, as far as based on the HbA1c, we always consider the basal insulin along with the oral antidiabetics, whereas anything HbA1c less than 9, along with basal insulin, we can consider the second line therapies after the metformin. There are two aspects in managing these treatments as well. One is established coronary vascular disease, heart failure, and CKD patients, and one is non-established. So, if the cardiovascular disease is predominant, then in today's times we prefer GLP-1 analogs, or if there is heart failure or CKD, then with the due concerns and with the due investigation, SGLT2 inhibitors are being given with careful monitoring. If the heart failure or cardiovascular disease or CKD is not been established, and and if there is a high risk of hypoglycemia, then of course the drugs that minimize the risk of hypoglycemia should be preferred, and along with weight management and various cost concerns can also be considered. So what are the advantages of basal insulin while we in current situation, while we treat so many patients? Through the various research aspects, it shows that simple and convenient to initiate. They are very easy and safer to titrate. Smooth maintenance period following active titration phase. Effective in real practice. Less glycemic variability and more time in range. Less hypoglycemia, less weight gain, ease of training, requirement of less monitoring, flexibility of using oral antidiabetics, improved quality of life and patient satisfaction, ease of remote management, improved adherence, ease of switch from other regimens. Because because the basal insulin is something that you can even continue on discharge, and like the rest of the patients can be treated on it, and it is easily administered by patient himself with the comfort, and plus once a daily dose is obviously very comfortable for the patient to be taken, rather than preferring short acting or moderate acting insulins to be taken thrice a day or twice a day. Over the period of time, the insulin is an entity that has been developed since 1950, right from like end-page insulin, who are very variable in absorption and longer duration of action. But after the 12 to 14 hours of action, is like the cause of hypoglycemia, the risk of hypoglycemia was more. So over the period of time, by the time the glargine insulins or the basal insulins were evaluated since 1992, if you look at the graphs alongside, the level of blood sugar levels have been maintained throughout the 24. The entire focus was in the lower hypoglycemia, and like not more of a hyperglycemic spikes, and more of an absorption and more prolonged duration of action, that is more than 24 hours. I'll be discussing various trials that have been conducted across the world for the same point, and considering putting the glycemic variability in the focus. So glargine insulin is and long-acting insulin is like another with the endpoints measured, that metrics, mean glucose levels, mean change in HbA1c levels. So definitely 24-hour glucose, it has always a smoother profile if you look at the glargine line, and irrespective of morning or evening injection, it maintained its excursion, and there were no too much of hypoglycemia, improved glycemic controls with less of fluctuation across. Whereas the nocturnal hypoglycemia, particularly noted very low in as far as glargine 300 group is concerned, rather than 100 group is concerned. It may allow some flexibility in timing injections to deal with situational variability experienced in daily life, unlike NPH insulin or other moderate acting insulin that you have to be given or administered in hospital patients or OP patients before their meals. So fixed dosing timing is not and the flexibility of the timing of the insulin is a boon for glargine insulin and all sorts of basal insulin. So if you compare the second generation basal insulin like Glargine and Degludec, so definitely Glargine or basal insulin it's like almost maintain the same level, but 20% latent within a day in variability with Glargine 300 versus Degludec 100. So of course there is less fluctuation which has been noted, evenly distributed PK versus Degludec 100 in OD morning dose of 0.4 unit kg per day. So definitely fixed once daily morning dose regimens is effective in this kind of scenario. In another trial, which was the efficacy and safety of basal insulin Glargine 300 and Degludec on glycemic control using continuous glucose monitoring with 30 patients and once daily Glargine and Degludec, mean percentage of time within the target glucose range was around 7 to 180. So that was the efficacy endpoint, and it was comparable TR for Glargine 300 versus Degludec, markedly lower for Glargine 300 across categories of hypoglycemia. There are various trials that says there's a percentage of time in nocturnal hypoglycemia Glargine was significantly lower than that of Degludec treatment. So as far as this graph is concerned, so if you look at the nocturnal, the various excursion, the risk of nocturnal hypoglycemia has been definitely seen on the lower side of the. So as far as after all these trials, what inference we comes on is like the basal insulin, that is Glargine or basal plus demonstrated is like time in range is 14% higher, whereas the risk of day hypoglycemia or in meal hypoglycemia is 7 times lower, and nocturnal hypoglycemia, which is very important entity while treating a diabetes or critical patients, is 18 times lower. So to summarize my talk, I would like to say that good glycemic control is absolutely important, particularly in COVID-19 infection, apart from all sorts of infectious diseases or critical patients we treat in our daily lives and in day-to-day basis. Patients with diabetes are at risk of more severe cases of COVID-19 and other infections. Good glycemic control prevents diabetic complications, obviously. Lack of glycemic control is associated with more severe outcomes of infections in general. Even though we know glycemic control is important, there is a delay in treatment intensification. So after summarizing this, I am of the opinion that glycemic control is something I would call a game changer in the management of not only COVID, but any sort of multi-organ dysfunction syndrome that we are treating. So even if we have to use the steroids like methylprednisolone or dexamethasone in sometimes catastrophic conditions apart from fungal infections, we need to be obviously very aggressive in treating insulin, not only with basal but also with the help of bolus. So it's like I think I would end my talk here. So over to you, Kiran sir. So in case any questions or something, I can address it in the Q&A session. Thank you.
Thank you, Abhishek, for such an excellent talk. Thank you very much. Moving to our next talk, it is what which we are eagerly awaiting this morning, Dr. Upendra Gupta oration. I invite Dr. Prasad Kulkarni.
Hello, good afternoon, Dr. Birari.
Yes, sir. Good afternoon. Dr. Prasad Kulkarni doesn't need much introduction. He's a graduate and postgraduate of BJ Medical College, Pune, with specialization in clinical pharmacology. He joined Serum Institute of India Limited in 2000 and is now its executive director. Today, Serum Institute is the largest manufacturer of vaccines in the world. Dr. Kulkarni has several years' experience in clinical research, medical advice, and pharmacovigilance. His special focus has been on clinical development of new vaccines and therapeutic large molecular serum. Several of these products are also WHO pre-qualified. He has more than 70 publications in international journals like New England Journal of Medicine, Lancet, Infectious Diseases, Clinical Infectious Diseases, etc. Many book chapters and poster presentations. He has delivered several lectures in many national and international conferences, workshops, and seminars. Dr. Kulkarni has been a faculty to the annual Indian Vaccinology course at Christian Medical College since 2000 till date. He has been a referee to many international medical journals. He has guided many students in clinical research. And he is also a fellow of American College of Clinical Pharmacology. Over to you, sir. Sir, your friend and our beloved IMA President, Dr. Samir Chandratri, is sitting beside me.
Excellent. Please give my regards to him. Hello, Samir.
Hello, hi, Prasad. Thanks so much to be our main orator, and a lot of questions, a lot of doubts will be cleared because of your talk. You are giving the very prestigious Vasundhara Gupta oration. Dr. Vasundhara Gupta is the father of Indian Medical Association Nashik, and he is a very well-reputed and past Nagaradhyaksha of Nashik. So on his name, we carry out this oration every year. And I'm really feeling proud and happy that one of my friend and the person who is called the vaccine man of India is now going to actually tell us the story behind the vaccine till the vaccination. Please go ahead, sir. Thank you.
Thank you so much, Samir, and I really feel honored to give this prestigious oration. Really feel humbled. So I don't know about being a vaccine man, but yes, I will try to do justice to the topic that we have today, and I'm sure all of you are more keen to hear about this. So we'll start with little bit of virology, very limited. So as you must be aware that the SARS-CoV-2 virus is a spherical single-stranded RNA virus, and it has multiple proteins. And the most important of them is the spike protein, which is present on the surface. There are others like envelope, membrane, nucleocapsid, etc. They are required for virion assembly. But spike protein is the one which actually binds to the ACE2 receptors. And then through this receptor binding, the virus gets into our cells and then finally starts doing all the damage that we are all aware about. So this particular protein, it has two subunits. One is the S1 part. This is the S1 part, and then there is a stem like S2 part. So this S1, S2, and then at the end of the S1, there is something called as RBD, which is receptor binding domain. So with this receptor binding domain, once it unfolds, once it comes to the close to the receptors, it becomes like a flower, blooming of a flower, and then it gets attached to the receptors, and then this is a tight binding, and then the virus can get into the cells. So that's why, as you can imagine, that this spike protein is the one which is really responsible for the pathogenesis of the disease. And naturally, that's why it makes the spike protein as an ideal target for vaccine development, right? Because the neutralizing antibodies that are targeted against spike protein are the ones which are going to neutralize the virus and are going to give us protection, right? So all the efforts that are there today or that have been there since last year is to deliver somehow the spike protein to your body. So there are various approaches people have taken. So usually all vaccines aim to expose the body to an antigen of the virus or the bacteria so that it won't cause disease, but at the same time it will provoke an immune response to the antigen, and which will be protective in nature. So there are different types, different approaches that are being tried. One is the virus, which means the actual SARS-CoV-2 virus, either as a weak virus or as a killed virus, like the Bharat vaccine, the Covaxin. Then there is another approach, is the viral vector, where you take another virus, which is not SARS-CoV-2, and that virus acts like a vector or a carrier to the genetic material of the spike protein. So that's one. Then there is, of course, you must be aware, DNA and mRNA approaches, where those genetic materials they go into the body, and then finally they express the spike protein, and then using spike protein as such as the vaccine. So these are various approaches. As you can see, the common theme among all of them is to deliver the spike protein. And there are multiple vaccine candidates in the development, more than 100. Some of them are now licensed, some of them are still in clinical trials. So all that is being tried. The data so far with many of the vaccines shows good response. So let's talk about a little bit about the viral vector vaccine, because Covishield is a viral vector vaccine. There also we have two types: replicating viral vector and non-replicating. So Covishield is the non-replicating. So what generally it does is that we're using a vaccine virus like adenovirus, which, and in this case it is the chimpanzee adenovirus. So very species-specific virus. So it is pathogenic only in chimpanzees, not in humans. So that makes it safer. Moreover, it is made genetically, it is made as non-replicating. So it's not going to replicate in your body and cause disease, even though it is not really meant for humans. So this viral vector, it has the genetic material for the spike protein of the SARS-CoV-2 virus, right? So this virus, either replicating or non-replicating, once you inject into your body, it may replicate, it may not replicate, but it will go to the antigen presenting cells. The genetic material of the spike protein will be read by our cells, and then it will express the spike protein on its surface. Once this spike protein is expressed on the surface, your immune system will come into play. It will recognize it as a foreign antigen and will start producing antibodies and also cellular immunity. Right. So this is what the mechanism of action of Covishield is. Right. So coming specifically to the Oxford vaccine, as I said, it's a chimpanzee adenovirus. It's a platform, and that's another thing that why Oxford could do this so quickly. Right. So Oxford has developed this platform since almost 2 decades, right? And so this platform, they developed for various other diseases like MERS, Middle East Respiratory Syndrome, Ebola, malaria, chikungunya, and so that platform has been tested in animals, in humans, and in clinical trials, and it has been found very safe, highly immunogenic. No issues with giving excellent protection, at least producing neutralizing antibodies. So safety was never an issue. Platform was ready, and once the pandemic broke out, they could immediately translate that platform for SARS-CoV-2. So that's the reason why the development was so fast. Now, and this vaccine, as I said, it expresses the sequence for spike protein and replication deficient, as I said. So our journey with Oxford started long back. We have been working with them on many other projects. The first one was, of course, malaria vaccine. As you must be aware that malaria is a big problem and we still don't have a good vaccine. And the RTSS vaccine that is developed by GSK also has huge efficacy issues. So by using this platform, Oxford University developed malaria vaccine, and which is where we have collaborated already. And this vaccine has shown excellent results in phase 1, phase 2 trials. And we are now, in fact, going to start a large phase 3 trial in Africa very soon. So that, and we are very hopeful that this will be the answer to the big public health problem of malaria. So in any case, so we had already joined hands with them. So when the pandemic broke out and when they had that ready-made technology, they approached us and explore whether we'll be interested. And then, of course, we were more than willing. So this journey started maybe in March last year, and then culminated into agreements, commercial agreements between them, us, AstraZeneca, and finally we could get a master seed, and then we started making vaccine. Remember, this happened during a very, very stringent lockdown that the country was having. It was a tough journey, very tough journey. People had a lot of difficulties even reaching to the offices, and but still people very dedicatedly came to the offices and worked very hard, sincerely, spending a lot of man hours, sometimes even till midnight. And so that's the reason why even Serum could make huge amount of doses in a very short span of time. We also compared our vaccine with their vaccine, and then it was found to be absolutely same. There was no difference at all. So it's the same vaccine. And in fact, that's the reason why even the UK regulatory authority, MHRA, they allowed to use our vaccine, which is made in Serum, in the Oxford trial in UK. So that has already been done there. So this has been a very, you can say, very exciting journey for last 1 year, I would say, and maybe shortest possible time where you could actually have a vaccine out of preclinical studies, clinical studies, and then finally getting injected into millions and millions of people, and having, showing impact on the disease burden. So that's been journey. In any case, so this vaccine is a ready-to-use liquid, as I'm sure all of you have seen that. It's to be given intramuscularly in deltoid muscle, and 0.5 ml is the dose, and 2 doses are required to be given 4 to 6 weeks apart. But we also have data from other trials where it can be given up to 12 weeks, and that has become a little bit of a contentious issues these days, and we'll talk about that a little while. So in terms of clinical trials, phase 1-2 was done in UK in 1,000 people, then phase 2-3 in 11,000 people, phase 1-2 in South Africa in 2,000 people, phase 3 in Brazil, 12,000 people, phase 2-3 in India in 1,600 people. So these trials results, at least most of the critical results from all these 5 trials are available now. And that's the reason why we have the vaccine in the market. There are 2 studies that are going on. One is in USA and 30,000 people looking for clinical efficacy, and also in Japan, and then there is one more small study in Russia. So this is about the clinical development plan with this vaccine. We'll see a little bit about each of those studies. So the first study, which was the phase 1-2 study, this started way back in late March, early April last year. So when actually we had just started the lockdown. So this was a single blind randomized study in 1,000 people, 18 to 55 years old. And there were some local and systemic reactions that were seen, like pain, fever, chills, muscle ache, headache. I'm sure many of you might have even experienced these reactions. But most importantly, there was no serious adverse event that was caused by the vaccine, and there was excellent immune response, which is what we were looking for. So there have been at least couple of publications of this study. First is this was the first publication in Lancet, and it showed that the vaccine has an acceptable safety profile, and boosting, which was very important. Initially, even Oxford thought that this could be a single dose vaccine, and single dose did show good immune response, let me tell you. So IgG response, if you can see, was 157, but there was a boosting. By the second dose, it went up to 639. So there was a very significant jump in the antibody titers. This was about IgG. So neutralizing also, with the first dose, it was seen in 91%. But when the second dose was given, 100%. Right? So the booster, the second dose is making a difference. That's what we saw here. And that's the reason why taking second dose is so important. Then this is another publication from the same study, and in adults as well as in elderly people. So here you can see 18 to 55 and 56 to 69, because there was concern whether the vaccine will be safe and immunogenic in elderly people, right? So what actually found, we found that the vaccine not only was better tolerated in older adults, and that I'm sure you must have seen. So people above 40 and 50 are hardly getting any reactions. It is more of the younger crowd which is getting reactions. So safety was no problem at all in the elderly people. And immune responses were also very good, though they were a little lower as compared to the younger people, but still they were excellent titers. So you can see here that here, see 20,000 in the 18 to 55 age group. That was the IgG 20,713. In 56, it came down to 16,000, and 56 to 69, and above 70, it was 17,000. So little lower, but at the same time, still very, very high, very high. So doesn't mean that it's not working. Then this is another publication where the safety efficacy data was seen, and I'm sure many of you must have read about this, and the overall vaccine efficacy when the data was pulled from UK and Brazil, and this data was see, this was between April and November, right? Last year April, 23,000 people were enrolled, and this data is almost around 24,000 people, and the vaccine efficacy was 70%, right? And the most important part, 70% was for symptomatic, which included mild, moderate, severe disease. But when you talk only about severe disease, the efficacy was 100%, right? And that's what we are more worried about. We're worried about COVID-19 because it can cause severe disease, can go into the lungs, can require hospitalization and ventilator support and all that. All that gets prevented. Hospitalization is completely prevented. That's the best part of the vaccine. So vaccine again showed acceptable safety profile in this large population of 24,000 people, and also showed excellent efficacy. There are a couple of more publications in the Nature where the T cell responses, because as you know that the immune responses can be humoral and cellular. So humoral means antibody responses, and cellular means T cell antibody responses. So both these responses were induced by the single dose of the vaccine, the phase 1/2 trial. And this is one more after booster dose. In fact, the titers went up, and also there were multifunctional antibody responses. And in this report, we demonstrate a booster dose is safe and better tolerated than the priming dose. So that's again, I will be touching upon this, that the safety of the second dose is even better. So you are less likely to get reactions, and if at all you get them, they will be milder. And we also demonstrate that the anti-spike neutralizing titers as well as the Fc-mediated functional antibody responses, including neutrophil monocyte phagocytosis, complement activation, natural killer cell activation, are substantially enhanced by a booster dose of the vaccine. So this is the reason why we really need to take a booster dose, a second dose. So coming to the Indian study, we did this study, which was an observed blind randomized placebo one-dose study in 1,600 people in adults more than 18 years. There was 3-to-1 randomization to Covishield and placebo, and we had an immunogenicity cohort of 400 where 300 got Covishield and 100 got the Oxford vaccine made in UK, so that we could bridge our vaccine. So whatever in the lab, if we are claiming that our vaccine is the same, but whether it is actually happening in the humans, whether the responses are the same. So that was the idea behind doing this. So here, coming to the IgG antibody responses after first, so baseline, as you can see, the GMTs is called as the titers, geometric mean titers. So very low titers in the group, in the entire group of these people, very low, as you can see. After the first dose, from 95, there was a jump to 10,000. And here 6,600, right? There was a huge jump. So 105-fold jump, 83-fold jump from the baseline. Once we gave the second dose, it went up to 31,000 and 21,000, 325 times jump from the baseline, 388 times jump from there. So the vaccine was definitely very, very immunogenic, gave excellent immune response. And so it was working very well. And as you could see, the responses were similar. Whether the vaccine is made in serum or in UK, responses were similar. There was no difference. In terms of seroconversion, meaning those who had 4-fold rise in antibody titers compared to the baseline, there also you can see that after the first dose, 96% and 91% people had this 4-fold jump in their titers. After the second dose, it was almost 100% with both the vaccines, right? So, so vaccine was working, and vaccine was as good as the UK-made vaccine. So this was the Indian data. Coming to the international data, we saw a little bit about from the paper. So this data, as I said, 23,000 people data, Brazil, UK, South Africa, and as I showed to you, 70% efficacy. There were 30 cases in the vaccine group and 101 cases in the placebo. Excellent efficacy. Again, I reiterate, for the severe disease, the efficacy was 100%. Nobody was hospitalized who got the vaccine. In terms of immune response from these studies, again, excellent immune response after the first dose, 8,000 titers and then 29,000. Exactly like what we saw in the Indian trial, right? So the data looks absolutely similar whether you do the trial in India or in UK or in Brazil or in South Africa. The vaccine is showing a consistent immune response. Then there has been some global update. Now this is the global update. The paper will be published very soon, though it is already in the public domain. So as you must have heard about this, that less than 6 weeks when the gap between the two doses, the efficacy was 54%, and as you increase the gap, the efficacy went up, right? So the gap, and this is known not just for this vaccine but for all vaccines. More the interval between two doses, you are going to get better response, right? So that's expected. Nothing new about this, and that's the reason why you must be aware that WHO has recommended that though the label, the package insert of both our vaccine as well as AstraZeneca vaccine says 4 to 12 weeks, they are recommending 8 to 12 weeks, right? And so that's what it is. Does not mean that if you get it at say fourth week, you're not going to be protected. Of course, you'll be protected. Definitely going to get protected from severe disease. That's for sure. But that's some additional finding. Here again, when SDSD and LDLD, so all groups were combined. There also you could see an increase in the efficacy as the time interval goes up, right? Also, single dose gives you a good efficacy at least for some time. And that's the reason why you could take a chance by delaying the second dose. But of course, that decision will be taken by the government of India. They are thinking about this, and in fact, I was part of one of such meetings. So let's see what the policymakers take a decision. So this gives us a confidence that even though you may get, let's say, a little delayed at 2 months after the first dose or 3 months, you are going to get some protection from the first dose, right? The overall efficacy with the first dose is 76%, which is excellent, right? Of course, as you advance, if you go beyond four months, then it goes down, and that's the reason why you need a second dose, right? But you could wait till 8 to 12 weeks. In terms of hospitalization, as I said, after 22 days after the first dose and less than 15 days post booster dose, there were 0 hospitalization, whereas 6 in the control group. And after the booster, again 0 and 9 in the control group. So as I said, it completely prevents, even after the first dose, it completely prevents hospitalization. And after second dose, naturally you are going to get protected from hospitalization, which means obviously the severity, right? So that's the good part of it. So this was about the clinical data that is available so far, and which of course shows good safety as well as efficacy. We'll talk a little bit about the actual operational issues, which obviously are queries of a lot of people, and we are getting hundreds of such questions and inquiries from different doctors and also other people. So just to recapitulate, and this is all given in the package insert, I'm just repeating from there. Indication is individuals more than 18 years of age against the prevention of COVID-19. In terms of contraindication, so that's very often asked question, what is the actual contraindication? So the only strict contraindication is hypersensitivity to the active substance or to any of the excipients, right? So and these are the excipients. The list is also given in the package insert: histidine, hydrochloride, monohydrate, etc., etc. So if anybody is hypersensitive to any of this or to this thing, then it is contraindicated. Or let's say somebody gets allergic reaction to the first dose, he should not get the second dose. So these are the only absolute contraindication. We get a lot of queries. I have fish allergy, egg allergy, I have sulfur allergy, I have penicillin allergy. Should I take? Not a problem, as long as you are not allergic to any of these constituents or excipient. It's all right, right? If you are generally very allergic person, in the sense if you have multiple allergies, then you should be more careful. You should give the history to your doctor, so that they are more cautious. And obviously, you should remain for observation for at least half an hour, which is good for everybody actually. So that if at all someone develops any allergic reaction like anaphylaxis or something, you can immediately get required management, right? So this is about the real contraindication. Use of multi-dose vials, because right now what everybody is getting is a 10-dose vials. So these multi-dose vials should be used as soon as practically possible. So once you have opened it once, should use those 10 doses as early as possible, but within 6 hours, and it has to be stored between 2 to 8 degrees Celsius. Beyond 6 hours or beyond end of the immunization, if there are any doses remaining, you should just discard them, right? Should not keep them in refrigerator and try to use it after that, because there is a likelihood of contamination, bacterial contamination. In terms of precautions, concurrent illness. So if you are having any acute febrile illness at that time, so just like any other vaccine, you should postpone the vaccination naturally till you are out of that. But if there are minor cold or something, then you can go ahead. Many people, I'm having diabetes, hypertension, kidney disease, what should I do? So such people have been part of the clinical trials. No safety issues have been identified in them. Efficacy has also been excellent in them. And as you are aware that these are the people who are at the highest risk of getting severe COVID disease. So they are the ones who need the vaccine the most, right? So such people with comorbidities, even including history of heart attacks and maybe angioplasties and all that, they should take the vaccine, in fact, because they need the vaccine more. Then thrombocytopenia, there has been little bit of controversy from thrombocytopenia, coagulation disorders, anticoagulation therapy. So only reason why this is mentioned, and this is applicable not to coagulation but to any injection that is given by IM route, because such individuals may have more bleeding and bruising after the IM injection. That's the only reason why this comes under as a precaution, right? Otherwise, this is not really contraindication. This is not a contraindication. If you are taking aspirin as an antiplatelet for your cardiac conditions, not a problem at all. Just be little cautious. There can be little more bleeding. That's all. Immunocompromised. This has been often asked questions. What should we do? Again, these people have not been really included in the clinical trials. So there have been no special trials for this kind of population. But again, these are the people who are at the highest risk of getting severe disease. So do they need the vaccine? They do need the vaccine. Do we anticipate any safety issues? No, we don't anticipate any safety issues. As I said, this is a chimpanzee adenovirus, so it's not pathogenic for humans. Moreover, it is replication deficient, so it's not going to replicate and cause any damage. So safety-wise, we do not anticipate any problem. Your doctors should take a call based on the benefit risk analysis. And only caveat is that these people may have slightly lower immune response as compared to immunocompetent people, but even then it will be substantial and should be able to give you protection, right? So this has been a very common query. In terms of interchangeability, I got 1 dose of this vaccine. Can I take another second dose with another vaccine? You should not. You should only use this vaccine only as a second dose. So because we don't have interchangeability data. And should I give this vaccine along with flu vaccine or that vaccine? We do not have it, to be honest. So we cannot comment on that at the moment. Again, another very, very commonly asked question, does it affect fertility? Does it have any effect on pregnancy, breastfeeding? Of course, we are not done clinical trials, as you can imagine. The trials are still continuing and the data is still getting generated. So there have been no specific trials to look for these conditions. But we know that at least animal studies do not indicate any effect on fertility, any effect on pregnancy. So animal data, not human data. Human data will take time. And again, we don't know whether this gets excreted in the human milk. It's very unlikely. There is no biological reason why it should get into breast milk, but we do not have data. So any such condition like pregnancy or breastfeeding, the physician should take the decision based on the benefits and risks. Right? If the woman is at high risk of getting COVID-19, which is a potentially fatal disease, then obviously one should go for it because the risks are not anticipated. Though obviously, so a government program does say that pregnancy is a contraindication. I am sure you must be aware. So they are playing it very cautiously. So that's what will be followed most probably in the entire government program. So this is about this thing. In terms of adverse reactions, there are some reactions which are very common. By very common, it means basically more than 10% of the people can get it. And these reactions, as I said, so this can be headache, nausea, myalgia, arthralgia, or injection site reactions like pain, tenderness, etc. There can be in some people vomiting, induration, body ache, etc. And very rarely there can be decreased appetite, dizziness, abdominal pain, etc. Most of these reactions, they will happen within a day or two. They will last for a day or two, and most of them will be mild, right? So they are mild. Usually they are mild. They are transient, and they are self-limiting. Usually do not even require any medication. Nothing to worry about it. Protection from COVID-19 is more important than any of these reactions. Please remember that. So benefit is protection from COVID-19, and risks, these are the risks, right? So these risks obviously do not compare, do not stand anywhere close to COVID-19. So just keep that in mind. And the most important thing is the vaccine does not cause any serious adverse reaction. That's very important. So that has been clearly seen. No serious reaction is caused, no neurological reaction is caused. And also, the reactions will mostly happen with the first dose. With second dose, the reactions will go down, as I already said. They will become less frequent, they will be milder. Also, older people, I told that they usually hardly get any reactions. Maybe if at all they get, they are milder and very, very infrequent. If at all you are having such problems, you can take paracetamol or such product, which will give you symptomatic relief. That's all you need to do. There is no antidote. As we get questions like, is there an antidote? No, there is no antidote. You just need to take symptomatic treatment. And obviously, there is no antidote for any vaccine for that matter, right? So in terms of regulatory approvals, so we got the EUA, or the emergency use authorization, also called as restricted use authorization, on 3rd January last month. And as you are aware, that Government of India started vaccination on 16 January. And in this time, we have supplied millions of doses to government and also to other countries like Brazil, Myanmar, Bangladesh, UAE, Morocco, Nepal, and many. The list is not even complete. So in India now, more than 9 million people have received the vaccine, COVID vaccine. So which means that some of them must have received Covaxin also, but most of the people have received Covishield. So millions of people in India have received Covishield. And in fact, we have supplied across the world around 55 million doses so far. So millions and millions of people have received the vaccine, and no serious adverse event that was caused by the vaccine has been reported. So that's a very reassuring fact. In such a large use of the vaccine, no serious adverse event caused by the vaccine. So far, 23 countries have already given approvals, and more and more will be added to the list. And WHO also approved, gave the UL, the emergency use authorization, recently on 15th February. So from regulatory point of view, this has been accepted worldwide, and now because of the WHO, this thing, license now UNICEF and PAHO. PAHO means Pan American Health Organization. So they have started procurement of the vaccine, and then under COVAX. I'm sure you must have heard about COVAX, which is a collaboration between Gavi, WHO, CEPI, and UNICEF. So this facility, COVAX facility, is meant for supplying the vaccine to the countries under one umbrella. So COVAX has started procurement of this vaccine already and are now in the phase of supplying it to individual countries. So COVAX will basically supply to Africa, Asia, and also to Latin America, and also to some of the European countries. Already they supplied under COVAX only 1 million doses to India. So India also received some part of the COVAX supply. So vaccine is being used and has been found to be quite safe. So that's not a worry. So now we come to the end of this presentation. So to conclude, the Oxford vaccine has been tested in multiple countries, in multiple ethnicities, races, and the results have been very, very consistent. The data from the phase 1-2 study, as we saw, showed that the vaccine is safe, highly immunogenic. From the phase 2-3 and phase 3 studies in UK, Brazil, South Africa also showed high efficacy of the vaccine. Also safety. Indian study also showed that the vaccine is excellent, immunogenic, and safe in Indian population. Not any different from the results in UK and other countries. And the rollout, as we all are aware, has shown no safety concern. And therefore, we believe that Covishield can be a solution to this scourge of COVID-19 pandemic. And we really hope that we all together can use the vaccine to its maximum potential, so that we can really overcome this problem. So thank you very much for your kind attention, and I'll be open to questions.
Thank you, Prasad. And we'll go for the first question, and later on we'll have some interesting chat of the journey which you have gone through since the month of February and even before that. So the first question is from Dr. Shreya Kulkarni. She says that we have few cases who became symptomatic after 12 or 13 days after the vaccination, after the shot, and they became RT-PCR positive. Now, how many such incidences you found in the trial, and what will be the approach for these patients for the second dose of the booster dose of the vaccine?
Right. So such cases, I already showed you some data that after the first dose, the efficacy is 76%. So obviously around 24% people can get infection, and before even you get the second dose. So that is very much possible, and that's the reason why you need the second dose. After you get such infections, 2 weeks after the clinical recovery, you can give the second dose.
So need not delay the second dose at all.
Need not delay the.
You can go ahead.
See, WHO is saying, and many of you might have read this, that 6 months after the infection. Okay, that's because they're talking in terms of the immune response and the efficacy part, right? They are not talking about safety. So safety-wise, there is no problem at all. As long as you're going to complete the vaccination schedule, it is always better. So rather than delaying it for 6 months, if the vaccine is available, you can give it 2 weeks after your clinical. That's always better.
And just another question on this regard. Now, if this patient develops antibodies, how long will their antibodies stay in their body? Like
right.
6 months.
So obviously, this data is getting generated. The long-term follow-up is still going on, so we do not have a ready-made answer to that because the trial started only last year, as you know. But what we have seen, and many of you must be aware, that natural infection antibodies are lasting till 10 months. That has been already seen. And the titers that we saw in the clinical trials, especially in the phase 1-2 trials, were comparable to the titers induced by the natural infection. Right? So this is working as well as a natural infection, giving the immunity. So if the natural infection is lasting for 10 months, we expect that even the vaccine response will last that long. And of course, that does not mean that it will stop at 10 months. More data will come out and we'll get to know more about the durability of the titers. At the moment, all we can say that at least 10 months, the immune response should be there.
Okay, so you are hinting at a possibility that COVID vaccine shots will be a reality in future, just like the swine flu shots, maybe yearly shots?
To be honest, nobody knows this as of now. We'll have to wait. We'll have to wait for more and more data to come. With regard to flu, as you are aware that there are multiple strains of the flu virus that circulate at in any given season, right? You have H1N1, H3N2, B types, Yamagata and Victoria and all that. And these co-circulate together, and that's why, and they change every season. They change every season. That's why you need annual vaccination. This so far has not been seen. The vaccines have shown excellent efficacy against the UK variant, right? So even though there was a big change in the Wuhan strain, still the vaccine was giving protection against the UK strain. South Africa strain, there has been some reduced efficacy against the South Africa strain, but there again, the vaccine is giving complete protection against the severe disease. It's only the mild, moderate cases that may not get prevented. But because of the T cell responses and all that, severe disease is still getting prevented. So my guess today that vaccines are going to give protection, at least the present variants that we are seeing, whether it is South Africa, Brazil, or UK, they are going to give protection. And so we'll have to wait till more and more data gets generated. At the moment, I don't see a possibility of that happening. Let's keep our fingers crossed. Just to tell you that, of course, this is a completely different situation, but you must be aware of the SARS epidemic, severe acute respiratory syndrome epidemic in 2003, and which occurred more in Hong Kong, China, and somewhat in Canada and all. And the 2011 epidemic of MERS, Middle East Respiratory Syndrome, which happened in Middle East regions coming from camels. Both these epidemics were caused by coronaviruses, right? And these viruses did not change much. And of course, they died down very quickly. The epidemics died down quickly. But there was no emergence of multiple strains of those viruses, at least in those two recent epidemics that we saw. Of course, COVID or SARS-CoV-2 has become a much larger problem as compared to these two epidemics. But still, those two episodes do tell us that maybe there is not such a possibility of this kind of thing happening. But let's see. We'll have to wait for more and more data.
Coming to the strains, there is a general opinion that South Africa has refused the Covishield because that particular strain is not included in the preparation of vaccine, or it does not protect it from the South African strain. And now the cases are increasing in India suddenly since the last 5 to 7 days. So do you think the South African strain is probably contributing to the rise in India as well? And do you think if at all it's a South African strain, this vaccination drive which is across the country, do we need a third shot for particularly that strain as well?
Right. So I think the report so far shows that South African strain has not been seen in India. Right. So that's not a concern, at least at the moment. UK strain, of course, has been reported in some people. And as I said, UK strain, there is no worry at all. In fact, UK strain, it is giving excellent protection. That data will be published very soon. So that's not a worry. South African strain, yes, as I said, little bit lower efficacy. But again, severe disease is not a problem. And the T cell epitopes that we see are possible that it will give some protection. So South African issue is being sorted out, and we don't have still final word about whether they are going to take the vaccine or not. But as I said, India doesn't have to worry at the moment. All the spike that we are seeing, I don't think there is any new variant that is causing the spike. It is, as of now, it is still the original strain that is causing the spike.
One more question about the adverse effect. one of our very nearby dentist from Ghoti. After the COVID first shot, the patient, was she a female? Lady?
She was female. BDS.
A lady BDS doctor suffered from stroke and she died, I think, probably. She is reported to be dead just 3 days ago. Do you have any idea? Someone has reported to you?
I think I will have to check. I will have to check. Most of them do get reported because, see, these cases we come to know only from the media reports. Once we become aware from media reports, we of course take them into our database and investigate them. So that's what typically happens. If it doesn't come under any of this media or nobody informs to us, then obviously it is not possible. I will have to check. But yes, there have been some deaths. Sorry.
She's probably ventilator and she's declared brain dead. Maybe she'll be reported within a couple of days. And
Okay.
sir, there are a lot of issues about doctors who are having their second shot. Maybe it's 7 to 10 days since the time few doctors, healthcare workers are received their second shot. They are trying to do the antibody testing. Now, which lab is actually really authorized to do this specific IgG antibody testing? And should we go for it immediately within a week after the second shot, or there is some time span to wait for? Because the guards we have to be put on all the time. We have to be on mask all the time.
I know
What
this
is your say?
very, very often asked question. Now, there is no one such lab which has been recognized or anything like that. There are kits that have been approved for IgG antibody tests, and they are being used, commercial kits by different labs. Many of these kits have issues, so they may give false negatives, and so one has to be very careful about these tests. And I would suggest that ideally there is no need for anybody to test their antibodies because once you have got 2 shots, that's good enough. If at all you are very keen, you can test them 4 weeks after the second dose. That's when you are going to see the optimum response. But even then, whether the kit is really sensitive and specific, that is the question. So we'll have to look at that also. That's one issue. And that's why some people actually think that they should go for neutralizing antibodies, right? Rather than the IgG antibodies, which are tested by the commercial ELISA kits. So that's, and those labs are very, very few, like NIV, for example, National Institute of Virology. And I think there are a couple of more. So that may tell you some better picture. But otherwise, it's not really required. Once you got 2 vaccines, I don't think there is ample data, as I have shown, from thousands and thousands of people, which shows that the vaccine has caused 100% seroconversion. Right? So if that data is there from the best labs in the world, just don't worry.
Otherwise, the question was because within few weeks we'll see some doctors and healthcare workers discussing about themselves. How much is your stock price market going on like that? So my
Yes.
antibodies are 40, yours are 10.
Correct.
That would go on in our groups.
Yeah. There can be some kind of competition. No. So we should not get into that. Believe the data, which is very scientific data done with the best possible assays in the best possible labs. And the data coming from different countries where you are seeing 100% seroconversion, titers as high as 30,000, 33,000. Just believe that data. No need to go for testing.
So 2 jabs of Covishield and you are almost having 100% immunity against COVID. That's what you say. So 2 shots of Covishield immunity.
2 shots of Covishield, yes. 100% seroconversion, as we call it, is seen against spike protein, against the virus, against the RBD. So nothing to worry. 100% seroconversion, both by IgG, by neutralizing antibodies, and good T cell responses. That's been seen already in thousands of people. No need to go for it.
A question on a lighter note coming from the small audience that we have here. What does it take about alcohol after the vaccine shot?
I know this has been also one more query, and I think the origin was some WhatsApp university. So alcohol is not a good thing, as we all know. So if for this reason, at least you can avoid alcohol, nothing like it, right? And in fact, we discussed this internally. They said, why don't you tell that 3 months before and 3 months after taking the vaccine, you should not take the vaccine, so that alcoholism will go down. It will be good for the country. But seriously, obviously, we have not done studies like this. We are not monitoring how the volunteers in the trials were behaving at their home, whether they were taking alcohol or not. Some of them might be taking also. So we don't know, but we don't expect any issues, to be honest.
No issues about smoking.
Sorry?
No
Smoking,
issues about smoking.
same thing applies. What applies to alcohol applies to smoking as well.
True. Prasad, you have been very frequent traveler because of your job profile, and you are visiting many research institutes as well. I remember you had gone to Oxford 7, 8 years ago. So, what was your experience when actually COVID was at a very high pace in Europe, and you had to go for meetings and international travel? Uh, Personally, did you feel the fear, and how were those days when you had to work for developing the vaccine? I mean, your company as well. I mean, those were
Yeah.
really tough times.
Of course, very, very bad days, no doubt about it. I mean, nobody would want those days again, for sure. And of course, once the lockdown was declared on 21st March, our international travel was obviously completely stopped. So we never went to Oxford after that. Whatever visits happened, meetings happened, uh, uh, happened before that. And then, of course, we were in constant touch by Zoom and all that. But in those days, we uh, initially we were just wondering whether we need the vaccine. That was one, debate whether a vaccine is really required or not, because overall in general public it was like some Chinese disease and it's not really going to make any difference to us. But slowly, as the situation unfolded, then yes, everybody became serious, and when the virus started spreading like wildfire, then we thought that yes, something must be done for this. And then, of course, Oxford, our partner, already had this technology, and then they contacted us, and then immediately we said yes. And then we started working towards that. March, April, we started working towards that. It was complete lockdown, and yet every day we used to go to office, uh, taking all the precautions. And there was nothing on the streets, as you must be remembering. There were no shops open, no vehicle on the street. There used to be police, so we used to be stopped at different levels of those blocks created by police. We were given special this thing placard kind of thing to be put on our vehicles, so that we won't be stopped because we were in essential services. Still, some people had difficulty because some of them were coming from faraway places. Then there were issues. If you remember that one case is found in one building and then the complete area is sealed. So we had some employees who were living in that area, so they would stop coming, obviously. And that happened to many departments. And naturally, we were really short on manpower in those days, right? So many such people, we had to stop them, this thing. Then some of them came positive also, so they had to again send home their contacts. It was not a very easy situation at all. And yet we were struggling, but we were very confident that yes, we must strive and come together to make a vaccine so that we can solve this problem. And so every one of us really put all their heart and body and soul into this. Still went on going. You saw that March, April, the phase 1 study started, and the phase 3 UK study started in May itself. Regulators were very, very flexible. Usually regulatory permissions are always a challenge, but they were very flexible considering the pandemic situation, and without cutting any corners, of course, without taking any shortcuts that can affect the quality of the vaccine. They were giving us, some freedom, and because of that, so when the Bastard seed came to serum, our people started manufacturing it. Initially, you have to make some engineering batches just to get a hang. You cannot directly start making the real product. So that those engineering batches were made, and people got a habit. Yes, they got an idea how the virus grows and how all the parameters are there. The testing, the quality checks, all that was getting established, and then finally we said, okay, the vaccine is ready, and now we should go and apply for the phase 3 trial, phase 2-3 trial. In the meantime, the phase 3 trial was ongoing in UK, and as I said, in Brazil and other countries. And then once we got, and of course, it was not easy to also convince our regulators that yes, this is the way we want to go. And after this trial, we'll be applying for the license and all that. But still, they were kind enough. And once we got that, then there was another big permission that we were given, was to make the commercial scale vaccine. Usually in routine course, you get commercial vaccine manufacturing license only after you get the marketing license. Meaning once you have completed your phase 3 trials, only after then they give, and then you will have to start manufacturing. Here, obviously, the time was essence. Correct? Time was essence. We could not have waited that we got license in January and then we start making vaccine. It would have taken 3 more months. And after making the vaccine, quality control tests, and then it goes to the National Control Laboratory, which releases it for 3 months. So the vaccine would have come in April, right? So that obviously was not the solution. So they gave us this permission that while your trials are ongoing, you can start making commercial lots, obviously at your own risk, without knowing whether the vaccine is going to work or not. If God forbid the vaccine had failed in clinical trials, all the millions and millions of doses that we had manufactured would have to be thrown in the gutter, right? It would have been a huge loss. So that was a risk that the company took, right? Millions of dollars at stake, but it was a leap of faith, and with that faith we continued, and fortunately for us, for all of us, everything fell into place. The results from the UK trials and other trials were very, very positive. The results from our trials were also very, very positive. And all that data was collated and again given to the regulators. We had multiple meetings with them. There were people who were concerned that whether regulators will take any shortcuts in giving license to the products, and no corners should be cut, no unsafe products should be given license. So that's what many people, not just in India, but in many countries were saying. They were genuinely, so it was not an undue concern, but they were worried that whether any shortcuts will be taken. And that's why regulators were, not just in India, but also in UK, in USA, in other countries, were very cautious. But they went through each of the data rigorously, and only after they were convinced, their experts were convinced that yes, the vaccine is working, very, very safe and giving protection, only then they gave us this license. And even then, this is not a license, full license like for other vaccines. It is only restricted use authorization, which means that we can only supply to the government. It's not available to private pharmacies or private hospitals as of yet. So this was the whole process, a very cautious approach taken by everybody concerned. At the same time, taking some, some calculated risk, so that millions of doses could be made quickly available if we get the license. And so that was the whole journey about taking risks, but at the same time going on with all your spirit and your heart and soul. And I think this is what finally culminated into having this vaccine.
Absolutely, Prasad, that was beautiful. The journey which you have explained, and in spite of all the hurdles, and whatever issues your employees, your engineers, your biotechnology people, your virology people, the technicians and the ground staff, whoever have contributed to prepare this vaccine, apart from people like you who have been the pioneer in this field, and your owner, of course. I mean, India is really feeling proud that Serum has developed, by God's grace, something to as a ray of hope against this COVID. And the war probably has now a weapon in the form of a vaccine or like a bulletproof jacket for the public. I just hope that we are able to actually help the entire world in the form of vaccine, and the vaccine is also available for our countrymen as soon as possible. And I know that your job is not going to end here just by producing and marketing the vaccine. I know you will be assessing the adverse effects of the vaccine, and there'll be a lot of technical data analysis here on, and probably your job of vaccine and post vaccination data analysis will go on, and we as doctors and healthcare workers probably will have a sigh of relief that we have got this 2 doses of Covishield, and now little bit easy to practice. Of course, as you have advised, we will be putting on our masks all the time,
Correct.
and we'll continue to serve our patients and our country. Thanks so much. I'm feeling very proud, and we are thankful from Indian Medical Association Nashik that Dr. Prasad, who is the vaccine man, had joined for the lecture. Thank you so much, Prasad.
Thank you so much. Thank you so much, Dr. Samir, Dr. Birari. Wish you all the best.
Thank you, sir. Thank you.
Thank you. Bye.
Sir, after vast discussion on COVID vaccinations, we'll be moving forward with non-COVID issues, that is obesity. And Dr. Vikram Rajadnya. Are you there, sir? Dr. Vikram?
Yes, sir. Can you hear me? तुमचा आवाज पोहोचत नाहीये सर. तुम्ही तुमच्या साईडने अनम्यूट करा.
अनम्यूट करा.
Okay, you will find one mic on left corner of your phone or laptop.
So we will move forward. Dr. Tejas, Dr. Tejas.
Are you online?
Are you online? Dr. Tejas?
He is not on the list, I guess. Yes, he's just joining right now.
Yes, yes, Dr. Tejas
Hello.
Sakai.
हा अहो राजात सरांचं ईमेल आयडी डेलिगेटचे आहे ना, तुम्ही त्याला प्लीज ह्याच्यात कन्वर्ट करा स्पीकर मध्ये.
Yeah. Coming to again touching to a COVID again, as a physician we have faced many patients with neurological issues like stroke, even without history of fever they directly come with hemiplegia or ICP. So we really need to learn about what is the relation between COVID and neurology. So I will request Dr. Tejas Sakre, sir, who is a consultant neurologist, has done DM, and sir is working in Medicover Hospital, Ashoka, as a consultant neurologist. And so I will request Dr. Tejas, sir, to guide us on relation between COVID and neurology.
Dr. Tejas sir has left. I guess he might having some internet issue, bandwidth issue. So let's wait for him. He might join in 2 minutes again.
Yes, we will wait for Dr. Tejas Sakre.
Yes.
So I think we will move forward with Dr. Reddy, sir. So are you there?
Yes, Dr. Sarath Reddy is here.
Dr. Reddy, sir, are you there?
Yeah. Am I audible?
Yeah, Dr. Reddy. Hello.
I'm there.
Yes, sir. So we'll move. Hello.
Yeah.
We are just.
I'm available. If you guys want me to pitch in,
we'll go with Dr. Sakre, sir. Okay, just wait for 20 minutes. Tejas sir is online.
Okay.
We'll start, sir. Tejas sir.
Shall I share my screen?
Dr. Tejas.
Yeah.
Okay, sir.
Am I audible?
Yes, sir. You are audible. Please share the screen. Yeah, even screen is shared. Yeah, sir. Requesting you to guide us on COVID neurology, sir.
Okay. Good afternoon, everyone. I'll just zip through. I'll not take much of time. Another COVID-related topic now. This will be how we'll be going about. Predominantly, very early in the course of epidemic, we knew that there is some definite neurological involvement. Anosmia and hypoxemia were recognized very early on, and we had patients coming with these symptoms very frequently. At that time, it was expected that probably the virus might have high neurotropism and may show neurological manifestations. However, over a period of time, we realized that that is not the case. In spite of that, there is a very high incidence of neurological symptoms in these patients. As many as 40% patients have neurologic symptoms at the disease onset, and over the course of illness, around 80% patients develop some or the other neurological symptoms. Many a times, these are non-specific symptoms like headache, dizziness, giddiness, myalgia. However, the number is fairly high. Coming to the mechanisms were discussed in the morning session. I just would like to highlight the ACE2 role of ACE2 receptors. Viral spike proteins binds to it, and then the virus is internalized. The direct viral injury is caused by these ACE2 receptors. These ACE2 receptors are found in some sites in the CNS, especially the striatum, the hypothalamus, brainstem, and in the gland tissue. The direct viral effects are not that common and not that severe. However, there are indirect mechanisms by which this illness affects the central nervous system. These are the hypoxemia or hypoxic insults. The insults because of prothrombotic or a procoagulant state, endothelial dysfunction, which is induced by again ACE2 receptors on the endothelium, which leads to leaky blood-brain barrier and CNS manifestations. And the most important and most commonly noted immune-mediated CNS dysfunction. This is one way to look at the neurological dysfunction in COVID-19. The non-specific symptoms like headache, confusion, dizziness, neuropsychiatric issues like anxiety, post-traumatic stress, the core CNS symptoms, encephalopathy, encephalitis, alterations in sensorium, hypoxic brain injuries, strokes, acute ischemic strokes and bleeds, parenchymal hemorrhages, rarely subarachnoid hemorrhages and cortical venous thrombosis, seizures and status epilepticus, immune-mediated demyelinating events, very rarely movement disorders, myelopathies, and cranial neuropathies. Some cranial neuropathies like Bell's palsy are fairly common, and the peripheral nervous system involvement, especially the GBS. Autonomic symptoms very under-recognized but very common, especially dysautonomias and syncopes, and the musculoskeletal symptoms like myalgias, myopathies, myositis, and exacerbations of pre-existing myopia. We'll briefly discuss the important ones.
Dr. Tejas sir, hello. Hello, Dr. Tejas sir.
Dr. Tejas sir, I guess, left again due to low bandwidth issue. He has joined back. So if he can just off his video, we'll be able to listen to him properly if he has low bandwidth.
Am I audible?
Tejas,
Yes,
you
yes.
are audible, but probably your net is not good. So if you can off your video, at least your audio will be without
Okay,
interruption.
I'll do that,
Be
yes.
clear, because many delegates are saying that your audio is not good. So yes, that's good.
Right. My screen is visible?
No, sir.
Okay.
No. So please share the screen, sir.
My screen is visible?
Yes, sir.
My screen is, yeah. So
Yes, sir.
Coming to strokes, nature of illness is thromboinvasive occlusions. One interesting thing that was observed was patients without respiratory symptoms, so many a times presented with acute events, and on further evaluation were noted to have COVID positivity. Hello, am I audible?
Yes, sir, you are audible.
Sorry. Okay. These patients on further evaluation were noted to have COVID positivity. Almost 6 to 7% of our patients had stroke as a presentation of the neurological symptoms. Coming to the management of strokes, the stroke protocols are essentially remain the same. Standard stroke care is offered, including thrombolysis. A protected stroke code was activated very early in the pandemic by the Indian Stroke Society and the American Stroke Association. Imaging guidelines also remain the same. One thing which COVID has taught us that our dependency on MRI has drastically reduced. CT almost always answers the question. We were avoiding MRIs because the risk of exposure and to prevent further spread. Mortality is again dependent on the severity of it and severity of stroke. In general, it has been observed that mortality is slightly higher as compared to compared to patients with routine stroke than in patients with stroke plus COVID. Rehabilitation becomes a challenge, especially if the whole family is infected, or especially if the patient alone is infected and is planned for discharge in the early course of illness. Coming to other types of stroke, venous strokes, cortical venous thrombosis, though not as frequently seen as arterial thrombosis, was frequently seen, and we had some interesting patients with central retinal artery occlusion who few days later presented with a cortical venous thrombosis. Again, the guidelines and management remain the same. Patients do well. Only thing is, many a times patients with COVID report headache, and it requires a very high suspicion to diagnose cortical venous thrombosis in time. Hemorrhagic strokes still rare as compared to the arterial ischemic strokes. Intraparenchymal hemorrhages, especially lower hemorrhages, are related to COVID-related endothelial dysfunction and loss of cerebral autoregulation. Many a times, hypertensive bleeds are also frequently seen because of steroid-induced hypertension. Very rare SH have been reported. We saw only one SH, which was an aneurysmal SH and probably had an incidental COVID positivity. Another thing I would like to highlight here is syncopal events. Though not typically under the umbrella of stroke, syncopal events are very frequent, and very COVID-19 who had presented to me with a syncopal event. This is believed to be because of the autonomic dysfunction caused by direct medullary involvement of because of the COVID-19 virus. Coming to encephalopathies, again, encephalopathies are very common. They are very severe, especially in patients with severe illnesses and elderly. It is again a multifactorial encephalopathy, hypoxia, sepsis, severe inflammation, renal failure, metabolic derangements, and cytokine storms worsen these encephalopathies. Underlying dementia and cognitive dysfunction prolong and increase the severity. One thing that is important is many times drugs which we use for COVID tend to worsen the encephalopathies. Drugs such as linezolid, fluoroquinolones, opioids which are used to treat air hunger can worsen encephalopathy. Even antihistaminics are known to worsen encephalopathies. Another thing when it comes to drugs is many times encephalopathies are precipitated due to nicotine or alcohol withdrawal, and we should always look for that. Next is meningoencephalitis. It is a very rare complication. In fact, we did not see any patient of meningoencephalitis. To call a meningoencephalitis as a COVID-19 meningoencephalitis, the criteria laid down is that there should be RT-PCR CSF positivity, or we should demonstrate intrathecal antibody synthesis of COVID antibodies. We did not see, but there are a few reports here and there. Essentially not a very common complication. Seizures, I have included it here because they are very common, especially in patients who are already on antiepileptics. COVID infection can lower the seizure threshold because of multiple factors, metabolic factors, hypoxia, non-compliance with drugs, or a difficulty in taking drugs, or the infection itself. So it is very important that we continue drugs and we always watch out for seizures. Many a times patients develop acute symptomatic seizures because of metabolic or hypoxic insults, or sometimes drugs like fluoroquinolones. Coming to other serious afflictions, edema and acute hemorrhagic necrotizing encephalopathy. Again, not very frequent, but they are immune phenomenon and require steroids, further steroids and immunomodulation if they develop. Generally seen in post-COVID period than in the para-infectious period. Acute hemorrhagic necrotizing encephalopathy is a very bad illness to have and carries a very grave prognosis. Now coming to the peripheral nervous system, GBS and GBS variants, they present with similar symptomatology as the other non-COVID GBSs, ascending areflexic quadriparesis. Post-COVID GBS is fairly common than the para-infectious one. Para-infectious as early as second day have been reported, but whatever we are seeing are all post-infectious. Standard treatment protocols are followed. However, IVIG is preferred over plasma exchange. for the simple reason that plasma exchange involves lot of patient handling, one thing. Secondly, plasma exchange is associated with lot of BP fluctuations. In a patient who already has dysautonomia because of GPS as well as COVID involvement, it is better that IVIG is preferred. One word of caution for IVIG here is that IVIG sometimes is associated with prothrombotic tendencies, and we have to watch for it and ensure prophylaxis. Generally, whatever GBS we are seeing show good response. The para-infectious ones sometimes develop respiratory compromise and get complicated. The post-infectious, if diagnosed and treated in time, generally show good response. Coming to cranial mononeuropathies, facial palsy fairly common. In fact, at the peak of COVID pandemic, we had a small peak of facial palsy paralysis epidemic. It was that common. In fact, many patients who were asymptomatic and unasymptomatic or polysymptomatic for COVID later on were noted to have facial palsy. Oculomotor and abducent palsy is very rare. 1 or 2 patients we saw. The catch with these abducens or oculomotor palsies is, especially if they are post-COVID, we are always worried whether it's a mucor, especially if the patient is diabetic, if he develops oculomotor palsy post-COVID. We'll be discussing that. Coming to muscle involvement in the form of myalgia is very fascitis, and rhabdomyolysis is rare, but it is important that we have a high index of suspicion for this thing, rhabdomyolysis and myositis. Whenever patient reports a pain out of proportion to his illness or there is evident muscle weakness on testing, it is imperative that we monitor total CPK, because rhabdomyolysis, if undiagnosed and untreated, can lead to renal injury and further complicate the course of illness. Myopathy, direct COVID involvement causing myopathy has been reported, but is fairly rare. More common is the critical illness myoneuropathy. It is associated, as with other illnesses, prolonged hospital stay, cytokine storms, prolonged steroid exposure. Certain drugs, especially cholesterol, aminoglycosides, can worsen or prolong critical illness myoneuropathy. Another thing which we feel worsens the critical illness myoneuropathy is difficulty in mobilizing patients who are suffering from COVID. One more interesting thing which we very frequently see here is, which we very frequently see with critically ill COVID patients is drops. Patients who recover on discharge or after discharge realize that they have developed foot drops. Many times it is because of the fibular peroneal nerve compression at the fibular head. DVT stocking or positioning is at fault. If we look for it, it is very easy to manage and easy to treat. Now, coming to the post-COVID things, this post-COVID mucormycosis, this heading from the frying pan into the fire is taken from JAPI January 2021 issue. It is that common. JAPI has an editorial on it, the recent issue. Post-COVID mucormycosis is commonly seen in diabetics. Diabetics whose control has been poor prior to COVID, after COVID because of steroid exposure, or after COVID because of direct glycemic this thing. Early recognition is the key, and it requires prolonged and expensive treatment. Also, the thing with mucormycosis is that in spite of early debridement, antifungal and blood sugar control, post-COVID mucormycosis seems to have a higher virulence and mortality. We have had almost 20 patients now with post-COVID mucor, and many patients are are having a long course, and this has not been observed with pre-COVID or mucormycosis, which we were used to see previously. Probably there is some underlying factor associated with COVID that affects our immunity. Lastly, post-COVID fatigue syndrome, also called as long COVID. Fatigue as a manifestation of COVID is well known. However, it has been observed that a very high percentage of patients tend to have a very long duration of fatigue. This has been called as post-COVID fatigue syndrome, and this has been noted irrespective of the initial severity of illness. Patients with a mild illness also tend to develop it. Many patients tend to have underlying depression or chronic fatigue syndrome, And it is always better to rule these out. Also, it is better to rule out thyroid dysfunction in these patients. It has also been observed that patients with migraine and migraine-associated vertigo tend to have worsening of their migraine attacks and migraine severity after COVID. One thing which we have frequently seen is that new headaches or migraine which are worsened after COVID, it is sometimes difficult or tricky to rule out underlying cortical venous thrombosis or underlying mucor or exacerbation of some infectious meningitis after exposure to steroids. So it is better to keep a low threshold for new onset headaches or headaches post-COVID headaches which are refractory and which are associated with some signs. Coming to COVID insomnia or the sleep disorders associated with COVID. Commonly, insomnia is reported for obvious reasons: the stress of COVID, the anxiety, and loss of employment. It is very commonly seen.
But I think there is a lot of issue regarding
That are seen are worsening of obstructive sleep apnea, worsening of REM behavioral disorders, and night terrors. Very rarely we see important here to.
Hello.
It is important here to rule out anxiety and depression in this patient. Also, melatonin has come up in a big way. It has been promoted as immunomodulator. As far as sedation is concerned, or as far as sleep is concerned, it works in setting the circadian rhythm. It is generally advised 2 hours prior to the expected sleep time, and many a times it is not a very potent sedative. So many a times, along with melatonin, we need to give some clonazepam or other. Onset of the pandemic, there were concerns whether there will be any congenital involvement, whether there will be any long latency related disorders, whether there will be tardive neurological disorders like measles associated SSP. However, currently, as far as we know, this virus doesn't seem to be a highly neurovirulent or neurotropic virus like what we see with herpes, measles, rubella, or polio. And probably we will not be seeing such complications in future. On this positive note, I think I will end.
Thank you, sir. Yes, thank you, sir. I think Dr. Tejas sir had a lot of issues with connection. So we will moving forward with Dr. Vikram Rajadnya. Sir will be talking on a common problem of non-COVID era, that is obesity. I have already introduced Rajadnya sir. Sir, please hand over to Dr. Rajadnya.
Can you hear me?
Yes, sir.
Yeah. And my PPTs are visible?
Yeah.
Yeah. Okay. Should I start?
Yes, sir.
Okay. So thank you all. Moving from a very hot topic of COVID to a very cold topic of weight. You know, weight is cold. It doesn't move at all. So it's literally we are moving to a cold topic. Myself, Dr. Vikram Rajadnya. I'm a practicing nutrition, exercise, and yoga consultant, and I'm also working as an associate professor at DY Patil. Now, in the beginning itself, I wish to thank Samir, who is a close friend of mine from BJ days, all your IMA Nashik office bearers and the audience as well. So, tucking in tummy, Marathi मध्ये ज्याला आपण पोट आत ओढणं म्हणतो, probably the commonest self-appraisal in the modern era, right? You'll all agree with me as far as this is concerned. So I call it as a biggest or commonest appraisal of self. Now, which is the biggest pandemic? If you ask this question, the automatic answer today will come as COVID, because it was very swift, very fast, and yeah, it created a lot of panic. But you know what? A very slow moving, all the time in the background pandemic is obesity. And central obesity adds to that burden, or you can say the fuel of it. Let's move to the next slide. Yeah, this lady is showing you the typical central fact. She is overall obese as well as she is centrally obese. And Of course, we are going to discuss about it. Now, central fat can be with normal BMI. So let's, as a clinician, we should not get misguided. That person is looking thin is not obese. It's not so, especially in Asians and that too in Indians. And another common is with increased BMI. Means they look fat as well as they carry central obesity. Our focus today, as far as my discussion is concerned, will be on otherwise thin-looking person, but who is centrally obese. You know, I have selected a specific subclass of these patients. Now, in clinic, how do we measure obesity? We all know these points. I would like to just highlight a few things in front of you. We do body weight, we do body mass index. We have got a formula which is very famous as far as body mass index is concerned. Body composition, if you have got facilities like BIA, DEXA also is available in nowadays in my town also. Waist to hip ratio and abdominal girth. These are the things which are usually mentioned in the literature. I will go to the next slide and then explain it to you. The cutoffs, please see this slide. These cutoffs are for Indians. Let's forget the European cutoffs. Okay. So body mass index of 18.5 to 23 is normal for Indians. It is 25 up to 25 normal is for Europeans. Okay. But by the time we reach 25, we are already obese. So a body mass index of 23 to 25 is overweight, and more than 25 body mass index is already obesity. And abdominal girth cutoff is very, very important in Indians because we are centrally obese. We Indians are centrally obese. 90 centimeters is a cutoff in men and 80 centimeters is cutoff in women. So please, now it is very well established that we should no more follow the European standard. For example, abdominal girth cutoff for men in Europe is 102 centimeters. We become huge by the time we reach 102. Of course, a lot of us carry that much, but then we become clinically very huge by the time we reach 102. So these are the cutoffs. Yeah, this is one where this is what you need in an obesity clinic, nothing else. If you're doing DEXA scan, if you're sitting in South Mumbai, where Amitabh Bachchan or not, of course, not Amitabh Bachchan is very thin, some very high-end patients, then you can have DEXA scan and so many things. But this is the basic you need in your clinical practice. I have put a teaser here. If I am asked to pick the least expensive and only one measurement of the patient, what should I do? Should I do BMI? Should I do body fat in my patients? Or should I do abdominal girth? In Indians, I have specifically written it here. And the answer is abdominal girth. If I keep a measuring tape in my clinic, I may not even require weighing scale. So this is that highlighting. Yeah. Can fruits define obesity? We all have heard that apple and pear-shaped obesity. Apple-shaped obesity is central obesity, and pear-shaped is typically seen in women, as it is said, which is not central. Hips and thighs are involved, lower part of the body. So this is how it was differentiated. It was. Why I was saying it was, I'm coming to it. My next question is, are women immune to central fat deposition? In other words, do women gather central fat less commonly than men? The answer is no. Now, it is very well established that by American Heart Association that women equally are predisposed to accumulate central fat. So, moving on to next. In research, central fat is measured by ultrasound, CT scan, MRI, but of course, these are not feasible in clinical practice. Again, another teaser I have put here. An American president openly said in a press conference, I weigh 86 kilograms for last 30 years. Okay, so he says I'm maintaining. He failed to mention the expansion of his core assets. He had expanded from 34 inches to 42 inches. What is the inference? I leave it to you to decide what the inference is. It's a very interesting phenomenon in metabolic clinic. Now, this is very common with those who otherwise look thin but carry central fat. I have selected or chosen a phrase, to be or not to be. It's a confusion for those patients. Am I obese? They're always confused. Am I obese? I am otherwise thin. These patients literally tell me this. I am putting Marathi madhe मी डॉक्टर बारीक आहे, मला कुठं काय प्रॉब्लेमच नाही, मला ह्यांनी धरून आणलंय, अशा टाईपचं त्यांचा एक अप्रोच असतो थोडासा. अँड ओनली दिस मच एरिया इज फॅटी, म्हणजे ते पोट दाखवतात आणि एवढंच मला आहे. सो दिस इज हाऊ दीज पेशंट्स आर कन्फ्युज. अँड सो दिस कन्फ्युजन लीड्स टू व्हॉट? शुड आय रन? Should I do lots of crunches? Yes. Even today, I have seen a lot of people who do a lot of crunches. More proteins in my diet, and or if I get frustrated, should I go to a cosmetic surgeon and get it chopped off? So these are the things the patient is going to go through, and then the market is ready for you. Once the patient is confused, these kind of markets are ready. Tummy trimmer and this roller and sauna belt and whatnot, everything is ready. I will tell you, nothing out of this works. Patients ask me, doctor, does it work? I say, yes, it works for the manufacturer and not for you. So this is how it goes. Yeah. Why central fat is important? We all are aware that central fat is subcutaneous and visceral. There are two types of fat. Visceral fat is metabolically very active. It is around the viscera. Disorders like dyslipidemia, insulin resistance, diabetes, hypertension, even inflammatory joint disorders and skin disorders are directly or indirectly related to central fat because it is metabolically very, very active. What to do? I am just putting some questions across the table. Finding answers to this is varies according to the case. Depends on the case, as we do it in any medical patient or medicine patient. Should I give typical calorie deficient diet? I will tell you, a thin, centrally obese patient, typical calorie deficient diet never works. Rather, it's a boomerang. Should I go for endurance exercise? Again, the answer is no. Take a guarded opinion on this. HIIT means high intensity interval training. You must have seen nowadays, it's very famous. Though it is risky, many people follow it. It's like playing basketball or doing some kind of exercise where you suddenly do a very fast, rapid exercise, take some rest, again do fast, rapid exercise. It's like playing tennis virtually. Should I do anything else? So the role of weight training, developing lean mass, all these
Sir, we are not able to hear you.
Dr. Vikram, we lost you a few seconds back.
Oh, so what should we do?
On your previous slide, if there was something you said in the end, just two statements about it.
What to do? What to do? This one?
I think we heard about HIIT.
Yeah.
And everything else.
Anything else is, see, as I said, our focus is mainly on thin looking, but centrally obese patients. So anything else means, should he go for weight training? What kind of weight training? Should he go for putting up muscular bulk, or should he go for some other kind of regime for this? So as I said, these questions will come in front of those who are practicing in this field, and then they will have to decide based on the case. For example, a patient weighs also very heavy and carries central fat, then your typical choice will be calorie deficient diet and endurance exercise. If your patient is thin and carries a lot of central obesity, your option will change. If your patient is thin, carries central fat, but is hypertensive, carries cardiovascular risk factors, HIIT is already ruled out. Because as I said, HIIT is high intensity interval training. You have to do a 20-meter run very fast, take some rest, again very fast, like that. There are variations in that. But as I said, sitting in the clinic, if I see that patient is hypertensive, HIIT I already rule out. So diabetic, HIIT I most of the times rule out in these patients. So this is how the clinical decisions are made. I hope you could hear me.
Yes, sir.
Yeah.
We can. Yeah.
So as I said, tummy is a big topic. I have put it in the bracket. It's a big topic.
Great. Thank you, sir. Thanks a lot for your lucid explanation on obesity. We will move on last topic, and before that, I will just request all the participants to be log in from tomorrow 8 a.m. To get all the 6 points. So I will request Dr. Reddy, sir, who is a cardiologist from Hyderabad, Telangana. Sir has done DM from Osmania Medical College, Hyderabad. Sir has many publications, research papers, and presentation nationally and internationally. And sir will be guiding us on percutaneous valve procedures. Over to you, sir. Dr. Reddy, sir.
Thank you. At the outset, I'm very thankful to IMA Nasik for inviting me to present on this percutaneous valve procedures. So I'll share my screen. So do you see my presentation?
Yes, sir.
Yeah. Yeah. So last 3 to 4 decades has seen a huge evolution in terms of structural heart interventions. We used to do open surgical valvotomies, which became closed valvotomy, and then balloon valvotomy, and surgical valve replacements slowly replaced by percutaneous valve replacements. And thanks to all the investigators who are involved in this evolution of structural heart interventions or valve procedures. In a nutshell, percutaneous valve procedures are basically balloon valvotomies that is done for stenosing lesions, or valve replacements, which are done again for stenosing lesions, and as well as regurgitation lesions, that is replacement or repair. Coming to the balloon valvotomies, these are well established methods from 80s, that is almost since 3 to 4 decades. We have these balloon valvotomies available: aortic balloon valvotomy, mitral valvotomy, and pulmonary balloon valvotomy and tricuspid valvotomies. So, and percutaneous valve replacements and repairs includes the latest procedure with huge data in support, that is transcatheter aortic valve replacement and implantation, and percutaneous mitral valve repair, which is which is accumulating data now, and percutaneous pulmonary valve replacement, which is already well proven in cases where surgery is not an option, and as well as valve-in-valve techniques. Coming to the balloon pulmonary valvotomy, so this is one valvotomy which is considered as curative for most of the patients suitable for this procedure. And usually it is done for congenital pulmonary valve stenosis, either doming pulmonary valve or dysplastic valve. And usual balloon which we use is 1.2 to 1.4 times the annulus of pulmonary valve. So, and this is considered completely curative. So there is restenosis rates are very, very minimal in doming pulmonary valve, and to some extent it may restenose in dysplastic valve. This is how we do it. We'll place a pulmonary valve from femoral vein through RA and RV, a balloon in the pulmonary valve, and which we deploy till the waist on the balloon disappears. You can see the waist on the balloon disappears at full balloon expansion. And balloon aortic valvotomy is well described entity, but this is not curative. This is most often it's a procedure to tide over the crisis or to bridge to another therapy. So, and there are indications. The indications are there in intrauterine life, and also first year in infancy, neonates, infancy, and then pediatric patients as well as adult patients. So my topic today is mainly on adults with aortic stenosis. So patients with aortic stenosis and cardiogenic shock, severe aortic stenosis, and who are planning for aortic valve surgery but hemodynamically unstable. So you can do balloon valvotomy and then take patients for surgery later on. And also symptomatic critical aortic stenosis requiring emergency non-cardiac surgery. So you can do a balloon valvotomy and then do a non-cardiac surgery and followed by specific therapy for aortic stenosis. Also, any patient who is poor surgical candidate to improve quality of life in aortic stenosis, you can do a balloon aortic valvotomy. And Sometimes we do it as a diagnostic testing in a low gradient, low output setting. That's a severe aortic stenosis with an LV dysfunction where the calculator pressure gradients comes low on in echocardiography. So, and congenital aortic stenosis and rheumatic aortic stenosis, and also as a pre-balloon valvotomy before TAVI. This is how we do balloon aortic valvotomy. Here we use a balloon annulus ratio of 0.8, unlike pulmonary valve, because most often these valves are very fibrotic and calcified. So chances of ending up in annular ruptures are high. That's why we maintain a very low balloon to annulus ratio in aortic valvotomy. And as I already mentioned, it's most often a bridge to next therapy. It's not a destination therapy. In very few patients, elderly, high surgical risk, where quality of life is limited because of aortic stenosis, there only we do it as a destination balloon aortic valvotomy. Coming to the mitral valvotomies, so this is again a well-proven procedure, especially in our country, developing country where rheumatic heart disease is quite prevalent, and which commonly involves mitral valve, and the commonest way it involves is the stenosing. So any mitral valve stenosis, usually rheumatic, with a pliable valve and with a valve area of less than 1.5 centimeters square and symptomatic patient is an indication for balloon mitral valvotomy. And so here we generally decide sizing of the valve based on patient's height. That is a usual mode of deciding sizing of the valve. And how we do it is basically we go through the femoral vein, and then we do a septal puncture. You can see I'm puncturing septal here. So we enter from right atrium to left atrium through intraatrial septum, and then we pass a wire into left atrium. So, and then over the wire, we pass balloon, and this is a balloon. And from left atrium, we enter left ventricle, you can see, and we inflate the distal balloon and pull it back, and edge it over the mitral valve and deploy the entire balloon. So that's how it causes valvotomy, and this is quite well proven, and most often it gives 8 to 15 years of asymptomatic life after balloon valvotomy. See, most of the patients, they go into restenosis in 8 to 15 years, and after restenosis, if still the valve is pliable, we can again try a balloon mitral valvotomy, or if the valve is not pliable, we may have to consider surgical options of valve replacements. And this is a data which in fact includes even Indian patients. Then tricuspid valvotomy is one more procedure which is most often combined with valvotomies of mitral or aortic, because isolated tricuspid stenosis is very, very rare, and most common cause is only rheumatic heart disease. So most often we combine this valvotomy with either mitral valvotomy or aortic valvotomy, sometimes triple valvotomy, or based on the indication. Coming to the percutaneous valve replacements, and the most prevalent and widely approved valve replacement is the transcatheter aortic valve replacement or implantation, which is known as TAVI or TAVR. So, so coming to TAVR, so it started as an option of therapy in high surgical risk patients initially, but now data is accumulating even in low and intermediate risk patients. So from moderate to high surgical risk patients with severe aortic stenosis is a good indication for TAVR, and also in valve-in-valve procedures for failed prior bioprosthetic valve, that's a surgical bioprosthetic valve. And we have data trickling in for mild surgical risk patients also. There are contraindications for TAVR. So mainly, the life expectancy of the patient, if it is less than 12 months, there's no point in doing. And MI with the with the short, life expectancy, and patients having hypertrophic cardiomyopathy or need for any emergency surgery, or EF less than 20%, or severe PH. So these are the patients who may not get benefited by doing TAVI, as their life expectancy is already very short. So, and these are the typical valve. So in echocardiography, so calcified valve, not moving, with high gradients, almost 90, more than 40 mmHg of gradient is enough for more than 4 meter uh, per second velocity across the aortic valve. So to say it's a severe aortic stenosis. The cornerstone of planning TAVI in an aortic stenosis patient is cardiac CT, which is very, very important for planning. So for every patient, we do a CT with the TAVR protocol. So in which we assess various parameters, as I mentioned now. One is annulus, the size of the annulus. You can see we measured this in a 3D, in MPR imaging. So this is annulus. So, and we measure both diameters of annulus and annulus area, as well as perimeter, based on which we decide on the size of the valve. So, and this is LVOT, which again affects in deciding the size of the valve, as well as this is the STJ, which is mainly to decide the occlusion point, and also to know whether your coronaries flows further. So the commonest problem in TAVI or TAVR is closure of the coronary arteries. See, when we place a valve here in our aortic valve, so this native valve moves onto sinus, and sometimes it may occlude the coronary arteries which are coming out of sinus. So the safety is the priority. So the coronary heights and STJ height, and also the sinus size is very, very important in understanding possibility of coronary occlusion after TAVI. So any coronary height from the annulus more than 10 millimeters is a good size, and also the sinus size of more than 15 millimeters is generally a good size, wherein coronary compromise is very unlikely. So this is a very, very important safety point in deciding on TAVI in a patient, in a given patient. So, and these are the angles which makes job difficult sometimes. So angle of axis of aorta with LV is very, very important in choosing the type of the valve, or also choosing deployment technique. So next thing in TAVI is so you need to know the access. So from usually we take valve from femoral artery. So this is a femoral artery. So in a curved MPR imaging, so we have to take sizes of femoral artery and iliac, external iliac, common iliac. So the size is very, very important. So you need a minimum size of 5.5 millimeter for TAVI, to take TAVI valve through. And sometimes it is even 6 to 6.5 millimeters based on the size of the valve. So the access vessel size is the key in deciding on TAVR in patients. So if you have a good annulus and good coronary height and good access vessel, and those patients are suitable for TAVI. And what usually we do, all such patients, after complete assessment, we take these patients' data through the heart team, including cardiologist, cardiac surgeon, and cardiac anesthetist, and sometimes intervention neuroradiologist and pulmonologist, based on, and also nephrologist, based on the clinical situation. Once this heart team goes through the information and also the pros and cons of TAVI versus surgery, and then we sign off patient for TAVI. So once we sign off patient for TAVI, we decide on anesthesia. Is it previously it is all general anesthesia, but now we are doing in conscious sedation, no need of general anesthesia to patient. and no need of even transducer vessel echo also. And the usual approach is femoral. If we don't have femoral access, then we think of subclavian or carotid access, and sometimes even direct aortic access based on the patient vessel anatomy. And what we usually do, we do a puncture of femoral artery under Doppler guidance or under digital subtraction angiography guidance. And once we puncture, then we place two sutures, that is percutaneous sutures, as a minimalist approach. So no need of opening artery or doing arteriotomy. We keep two sutures percutaneously, and then we'll pass a sheath. We can see this is almost a 14 to 16 French sheath, which is nearly a 5.5 to 6 millimeters in size. So the key is these arteries, this femoral, common iliac, external iliac should accept this sheath. Otherwise, if the vessel size is small, it may cause perforation of the vessels, and it may complicate procedure. So the access vessel size is key to send this sheath. Once we place sheath, then temporary pacemaker, and then we cross the valve. You can see here I'm crossing the valve, and once valve is crossed, then we'll take pressure gradients across the valve and then decide on procedure. So we place a wire. This is an LV wire into the LV, and then see we dilate. See, it depends on the case. Sometimes we do dilate with the balloon so that we can create a space for next valve. See, this is a valve. This is a balloon expandable Sapien 3 valve, so which comes from Edwards company. So I'm just sending the valve across the valve, and then we confirm position of the valve in an angiography, and then we deploy the valve. And after taking after pacing heart up to a level where systolic pressure drops below 50 millimeters of mercury, so that it reduces the movement of the valve. So now I'm deploying the valve. You can see we're deploying the valve. So we deploy it to full extent. This is a 23 millimeter valve. So, and this is post deployment. You can see there is a good valve opening and closing. So, and in fact, patient gradient came back to normal. And yeah, so that is balloon expandable. You can see this is a self-expandable valve. So we place the self-expandable valve here. Slowly I'm opening the valve. So as I open the valve, I can hear valve is under my control. So if the position is not good, I can again retrieve and reposition the valve. So, and this is the final position of the valve. So, and you have enough data now on Edwards Sapien 3 valve and Evolute R or Evolute Pro valve from Medtronic. So, and also our Indian valve, that is my valve. So, which all these three valves has enough data, enough safety data, and also data showing good, primary outcomes and secondary outcomes. So, this is now proven. So, in moderate to high risk patients, but in low risk surgical patients, we have to choose based on certain factors, approaching patient holistically with a heart team. So percutaneous mitral valve repair, this is again technology which is coming out for a mitral regurgitation, either secondary or primary mitral regurgitation, where patient is symptomatic despite optimal medical therapy. So as you know, mitral leaflets has scallops. So anterior mitral leaflet has 3 scallops, as well as posterior has 3 scallops, that is A1, A2, A3, and P1, P2, P3. And based on the anatomy of the scallops and the cause for mitral regurgitation, so they are, and also the physiology of regurgitation, they are divided into primary and secondary mitral regurgitation. Any primary mitral regurgitation with a suitable anatomy of leaflets, or secondary mitral regurgitation with severe symptomatic patients and severe LV dysfunction. So this procedure is indicated. So we have various techniques in percutaneous mitral valve repair. And this, as of now, the study is going on in high surgical risk patients. So patients with a porcelain aorta or calcified aorta, high surgical risk, mortality risk more than 8%, and frail patients associated severe liver dysfunction or severe PAH or RV dysfunction. So these are the patients who are taken into clinical trial that is ongoing. So, and this is the mitra clip. So system. So wherein so this clip is taken down the mitral valve, and two leaflets are pulled up and stitched in the middle. So it's something like mitral valve repair, surgical repair, so which is done by Alfred in the beginning. So Everest is the trial which is ongoing in these patients, as well as COAPT in heart failure patients with the functional MR. So which is showing promising results, and which probably the indications may expand in near future to more patients. So, and as of now in India, it is going on in trial basis. It's not widely available. So coming to the percutaneous pulmonary valve replacement, so which is again most commonly done in pediatric patients after repairs of congenital defects, VSDs associated with pulmonary stenosis. Patients who end up in pulmonary regurgitation will be given this option of percutaneous pulmonary valve replacement. Otherwise, before there was no option other than surgery in these patients. So this is a valve which is replaced, which is placed in RVOT2 PA percutaneously. You can see here, which is crimped onto the balloon, and just take it through the femoral vein and RA, then RV into the pulmonary artery and deploy there. So you can see there is no leak afterwards. And primarily it is for pulmonary regurgitation post intracardiac repair for congenital heart disease. So we can also place these valves which are approved for aortic implantation in pulmonary valve too. So coming to the valve in valve, this is another expanding indication. So patient who underwent a valve replacement with a bioprosthetic valve and went into stenosis, now we have this option of valve in valve. So you can see here, this is an aortic valve, surgical aortic valve. After stenosis, we can place a TAVR valve, percutaneous aortic valve replacement valve inside the surgical valve. So this is a mitral valve, so bioprosthetic valve, which is restenosed. We can place a balloon expandable TAVR valve inside mitral valve in a reverse position, so that quality of life of patient will improve. Again, this is a tricuspid bioprosthetic valve. After restenosis, we can place transcatheter valve inside. So valve in valve is indicated for any bioprosthetic valve got restenosed in pulmonary, in aortic or mitral or tricuspid position. And also we have now data trickling in for TAVR in TAVR valve. So a patient with the TAVR again came back with a restenosis, we can do TAVR again. So this entire structural heart disease therapy is expanding, the arena is expanding, and new therapies are adding up. So I think next 2 decades is going to see a huge change in the mode of therapy of these valve diseases. So structural heart treatment options are rapidly evolving and moving towards percutaneous in the last 2 decades. And pulmonary valvotomies in doming and dysplastic valve is curative. Balloon valvotomies of other valves are to survive the crisis and bridge to the next treatment. And TAVR is established in moderate to high risk surgical patient, and data on mild low risk patients is trickling in, but decision needs to be taken holistically by a heart team, which is very, very important. Valve in valve is therapeutic option for all moderate to high risk surgical risk patients, and TAVR in TAVR or TAVR in SAVR is evolving with the dawn of new data. Percutaneous mitral repair with MitraClip is about to cross final line to reach all suitable patients in near future. So thank you.
Thank you, sir. Thanks for your very lucid presentation and showing all your interesting videos. Sir, this was our last lecture of today's session, and tomorrow we'll be having a session starting from 8 a.m. and many topics are will be discussing on financial intelligence. So I will declare this to conclude this session. Thank you all panelists and attendees. We'll meet soon tomorrow morning at 8 a.m. Thank you.
Thank you.
Thank you, sir.